if patients have more skin manifestations, and also an excellent safety profile. Janus kinase inhibitors, we'll focus on this in a minute. Oral, this is also now outdated. So in the United States, this is now upadacitinib is approved for ulcerative colitis and Crohn's disease. Ulcerative colitis and Crohn's disease. Rapid onset, it's effective in both TNF naive and failure. No immunogenicity, also works very well for joints, especially rheumatoid arthritis. Herpes zoster is probably the biggest risk with Janus kinase. And then finally, the S1P, sphingosine 1-phosphate agonist, ozanimod is the current one that we have approved. Oral for ulcerative colitis, better in TNF naive, no immunogenicity, also works for multiple sclerosis. Actually very good safety, although there is an initial need to titrate the dose with ozanimod because of the heart rate decrease. So these are the totality of medicines we have today for inflammatory bowel disease. So let's think about this. At the conference already, you've heard about our emerging concepts of treat to target and how we look at targeting therapies in ulcerative colitis. If you look from left to right, we're now focusing on patient-reported outcome 2, diarrhea and bleeding in ulcerative colitis, but we're now moving towards more objective markers. We talked a lot about fecal calprotectin, endoscopic remission, and maybe one day histologic. I will tell you today, I am not using histologic information to make a decision on treatment, except if I biopsy a patient and they have inflammation microscopically, everything else looks normal. Macroscopically, and the patient says, I want to de-escalate medicines, I tell them this is a reason we do not want to do that. I put this up here and you'll see percentages in yellow next to low risk and high risk. This is my opinion as far as ulcerative colitis. I was part of a group in 2015 with the AGA that put together a clinical pathway in terms of how we look at this. On the left-hand side, 40%, approximately 40% of ulcerative colitis is low risk. What does that mean? That means they do very well with mesalamine and 5-ASAs, and they do not need escalation of therapy. So we don't talk about those patients a lot at these conferences, but I think it's important to remember 5-ASAs do work for ulcerative colitis in that low-risk group. And these are limited extent of disease and more mild. On the right-hand side, the high risk is about 60%. That means when they come to see you in the clinic, from day one, we should think about an advanced therapy. And you can see the different parameters. This has already been outlined in this conference, and these are the patients that we focus on advanced therapy. So that's ulcerative colitis. What about Crohn's? Same concept, clinical symptoms, but the PRO2 in Crohn's is abdominal pain and diarrhea. We will use fecal calprotectin. Fecal calprotectin works in Crohn's disease, and we also look at histologic outcome, but less so. I think what we're actually focusing on now is more cross-sectional imaging, and you've certainly heard a lot about ultrasound at this conference. Same theme with Crohn's, except look at the yellow percentages. Low risk for Crohn's progression to needing surgery is probably only about 20%. Again, at these conferences, we don't talk about that much, but these are the low-risk patients who probably do well, maybe with no therapy. Again, we don't talk about that, but very mild ileitis, maybe we don't need to do anything, or budesonide may be reasonable. However, on the right-hand side, over 80% of the patients, and these are the majority that you see in your clinics, are at a high risk for complications, and these are the patients we look at advanced therapies. So let's come now to the small molecules. These are the anti-cytokine, these are the biologic monoclonal antibodies, but at the bottom in green is the emerging small molecules. And I think this is now today what we're using more, and probably in the future. What are some of the benefits? Oral, once a day or twice a day, short half-life, rapid clearance, no immunogenicity. So what's a small molecule? Simply put, a small molecule is usually an orally administered medicine that's well uptaken in the small intestine and absorbed. And we don't think about it, but azathioprine, methotrexate, cyclosporin are small molecules. Aspirin is an example of a small molecule. So I'm going to focus a couple minutes on the Janus kinase, the JAK inhibitors. I think this has been reviewed a little bit already at this conference, but this works on the Janus kinase, the JAK-STAT pathway, which means it works through downstream cytokine signaling. Let's focus on tofacitinib, and this is something I think that many of you use. This is now, I think, approved in many of the countries and certainly in the Middle East. We've been using this for a long time. It's a JAK1 and JAK3 inhibitor. It comes as 5 or 10 milligrams twice a day, or extended release 11 or 22 milligrams once a day. There is actually an oral solution. We don't talk about this much, but this may actually be a good option for patients who have a feeding tube, or if you need to actually administer it as a liquid formulation, it does come in that way. Now, when I go through the data slides, I'm going to give you the bottom line. I think at conferences we can overwhelm people with percentages. I'm just going to really give you the high level, and then I'll give you kind of how I position these. So these are the octave induction studies for tofacitinib. You've seen these before. The red bars are tofacitinib, the gray is placebo, and you can see statistically higher rates of induction at week 8. For remission, the red bar is 10 milligrams twice a day, blue bar is 5 milligrams twice a day maintenance compared to placebo, and again, you can see statistically higher remission rates. One thing I'll say up front, this comes up a lot in the Q&A sessions, when I use tofacitinib, I almost always continue 10 twice a day. I do not de-escalate to 5 twice a day. I find too many times when I do that, the patient flares and I go back up. Now, if it's been a patient in remission for a long time doing well and you want to lower the dose, it's okay, and both are approved, but I'll tell you, in my practice, I have a hard time coming down to 5 twice a day. One thing we should mention, and I think this is different here, but in the United States, we cannot give tofacitinib or upadacitinib until we use a TNF inhibitor first. Why is that? That's very confusing. The reason is this. There's something called the oral surveillance study. This was a post-marketing study done by the FDA asking the company to look at safety in rheumatoid arthritis patients over the age of 50 who had at least one cardiovascular risk, and all of them were on methotrexate. So very different population to what we see. And what they essentially did is randomize patients to the 2 doses of tofacitinib and compared it to anti-TNF. So this is a post-marketing study. MACE, so what was found, and this was the bottom line, that overnight changed the label in the United States. Major adverse cardiovascular events were higher in the tofacitinib group, cardiac events and clots. So the oral surveillance study essentially changed the label in the United States to say that there's an increased risk of heart disease, clots, and that we must use a TNF inhibitor first. This is actually, unfortunately, somewhat of, I think, I'll say a politically editorial loaded comment. I think this is doing a disservice to our patients because we have patients who we should use first line, and the patients are now needing a TNF inhibitor first. You'll see in the next few slides with tofacitinib and others, we have not seen an increased rate of cardiac events or deep vein thrombosis significantly in our long-term studies. Serious infections, opportunistic, MACE, DVT, PE, actually look fairly similar to the SEER, the nationalized registry in terms of events. What is the number one thing that is higher in all JAK inhibitors is herpes zoster. That is definitely something that we've seen, and we recommend giving Shingrix to our patients. All right, so that's tofacitinib. Now we'll switch to upadacitinib. I'm going to say this, and I know from pharma they don't like when I say the truth, but I am now almost always exclusively using upadacitinib in my clinic. I have many patients who've been on tofacitinib. I'm not stopping tofacitinib. If it's working well, it's a great drug, but upadacitinib is now my preferred JAK inhibitor, and I think when you have more exposure or experience to it, It may be the same for you as well, but both work very, very well. Upadacitinib induction is 45 milligrams a day, maintenance is 30 or 15. I will tell you, like tofacitinib, where I continue the higher dose 10 twice a day, with upadacitinib, my maintenance dose is 30. I very rarely do 15 because I think there is a dose effect benefit that we see. All of the red bars here are upadacitinib, the gray bars are placebo. This is the phase 3 pivotal study, and you can see for clinical remission, clinical response, endoscopic improvement, and histoendoscopic improvement, fairly large differences between active treatment and placebo. Same thing in the maintenance study. We see higher rates with both the 30 milligrams dose, which is in the blue, 15 milligram in the orange. So both maintenance doses, although numerically you can see a higher rate with the 30 a day. So that is the dose that I use. So now what about safety? And I just put in the title, the main concern of safety again is herpes zoster. We have actually not seen an increase in MACE, cardiovascular events, or DVT. So one of the things that we've looked at and have looked at also is malignancy, which hasn't been higher. In the United States, many gastroenterologists are scared about using the JAK inhibitor because of the FDA label about the potential for cardiovascular events. But I think the comforting thing is the more data we have, the safer we're seeing. A long-term across multiple studies, there's no way you're going to read the table, but this is looking at different immunologic diseases, rheumatologic, dermatologic, and really the bottom line is aside from herpes zoster, we're not seeing an uptick in these other areas. What about for Crohn's disease? In the United States, upadacitinib was just approved for Crohn's disease, and we are starting to use this as well. The you excel and you exceed, again, very similar in terms of bars and differences. All right, so those are the JAK inhibitors. I'm going to briefly talk about S1P. I'll show you the safety pyramid, and then I'll tell you where I position these therapies. So sphingosine 1 agonist, as you probably know, this prevents the egress of the lymphocytes from the lymphoid organs. That's how this works, and prevents them from going to areas of inflammation. There have been several studied. Ozanimod is the one that's FDA approved. Etrasimod will be approved shortly, and I'll talk about that in one slide as well. But ozanimod is the one that we've been using for the last couple of years. Blue here is ozanimod, gray is placebo. Similar to the other studies, this is looking at induction, and you can see higher rates in remission, response, endoscopic, and mucosal healing. So ozanimod looks pretty good. Now, the one thing I will tell you, and look at the left-hand side, if the patient has been on a TNF inhibitor, there is an attenuated response. So in a way, I kind of look at this as vedolizumab. Vedolizumab doesn't work as well after TNF inhibitor, and I don't find that ozanimod works as well also. So if we use it, we usually probably should be using these earlier as first-line therapy. What about etrasimod? So etrasimod is going to be the next sphingosine phosphate molecule approved. There was a pivotal study called Elevate, randomization placebo to etrasimod. The dose of etrasimod will be 2 milligrams a day. And you can see, again, etrasimod in blue and placebo is in orange. And again, I'm not going to go through all of the data, but the induction studies did show a benefit of etrasimod. On the top right, you can see the symptomatic remission is actually very early. So this also works very fast. All of our treatments are seeming to work very fast. This is looking at the 52-week data, which is the maintenance data. And I think you can see as you scan across the bars, again, the blue is etrasimod, the orange is placebo. And you can see symptomatic remission, that separation that continues out to week 52. So good maintenance results as well. And safety, we didn't see anything new with safety. Interestingly, there's no dose titration. So you just give this at 2 milligrams from the start. You don't dose titrate like we do with the ozanimod, but the cardiac events were not significantly increased in this study either. Now I'm doing something bad. Actually, Ed Loftus did this, so I'm taking this from Ed. Looking at ezetimibe on the left and etrasimod on the right. This is not a head-to-head study, but if you look in very small blue print, the deltas between placebo and active treatment are there, and they're about the same, 22% for ezetimibe, 28% for etrasimod. So they look similar, maybe numerically a little bit higher. So I'm going to end with the safety pyramid and how I position these. You may have seen the safety pyramid before. One caveat I will tell you, these look good because this is a nice pyramid, it's easy to look at. This is not scientific. This is my opinion. I put this together for a talk about 10 years ago, and I never thought this was going to mean anything except in a presentation, but it's taken off, and we just actually published our most recent. This is actually one we just published in the IBD journal about a month ago. This is how I look at safety. At the top, integrin, the IL-12/23, and S1P, I would put at the top of the safety pyramid. You'll see in the red box on the side, inadequate treatment is an adverse event. So it doesn't mean we should exclude the use, and you'll hear in a minute me say this, of TNF and thiopurines, even though those are at the bottom. This is just purely looking at safety. And then all the way at the bottom, you can see steroids. Also, for our colorectal surgery colleagues, sometimes the absolute best biologic, fully human therapy is something called, no, slide's not, colorectomab. This is the best therapy, meaning sometimes patients need surgery. They don't need another biologic. They don't need another small molecule. They need a resection. And we've been talking about this at the conference. So even though this is a bit of a joke, at the same time, let's not forget that surgery is an important role. If you look at the names of the therapies I added to this, these are the current FDA-approved names that we have for therapies in the United States. You will notice that I put upadacitinib slightly higher than tofacitinib. That's very controversial. I'm just wondering if upadacitinib being selective JAK inhibitor, maybe, no head-to-head data. I shouldn't stand up here and say there's a significant difference, but maybe there's a slight difference in safety as well. So this is how I practice, and this will be my very last slide. In the United States, the insurance companies often dictate what we can use, but if that weren't an issue, I will show you how I look at therapies. Remember, in the United States, upadacitinib and tofa have to be used after a TNF. So for severe ulcerative colitis, I still use infliximab and thiopurine. I still will use that combination. If they've been on a TNF inhibitor, I'll use upadacitinib second, and I'm now using that more preferentially than tofa. Before upadacitinib came out, I was using a lot of tofa, and that's what you have available. I would definitely continue to use it. It works very, very well. If it's an outpatient with ulcerative colitis, then you have options. Vedolizumab first line is very reasonable, and pretty much any of them. If you look in italics, this is where I would put ezetimibe and etrasimod. The milder end of moderate. The milder end of moderate ulcerative colitis is the sweet spot for ezetimibe and etrasimod. First line therapy after a 5-ASA, that is definitely the place I would use. Sometimes I think we use those too late. What about Crohn's? Multiple segments, jejunum, ileum, rectum, colon. I'm still using infliximab with azathioprine as first line. I still think that sometimes works the best, but if the patient has been on that, I'm now using risankizumab and upadacitinib more preferentially. Risankizumab's data in Crohn's also looks very, very good. If it's more simple Crohn's, one segment, no fistula, then we have great options. Veto could be used first line, or ustekinumab, risankizumab. I will tell you, I'm starting to use a lot more risankizumab first line therapy for Crohn's. Second line, it's going to be UPA or RISA. Extraintestinal manifestations, if it's arthritis from bowel inflammation, doesn't matter what you use. Anything that heals the bowel is going to heal the joint symptoms. But pyoderma, uveitis, central arthritis, I think the TNF inhibitors, methotrexate, If it's skin, I'm using more Eusta or Risa, IL-12/23. If it's joint, I'm using more of a JAK inhibitor. So those are sometimes distinguishers. And then finally, pregnancy. As you probably know, any of the monoclonal antibodies are safe in pregnancy. We don't stop them, we continue through. No need to stop in lactation. These are very well tolerated. And actually, I wouldn't recommend stopping these in pregnancy. The small molecules are different. Today, I am not using the small molecules in pregnancy. For a woman who wants to conceive, they should be off for 1 month. 1 month. These probably are clearing the system within 1 week, but we recommend being off for 1 month. Currently, we're not using these in pregnancy. You'll hear some data at DDW that maybe second and third trimester, it's okay to use JAK inhibitors, but I would not recommend that today. So just to say, don't use these small molecules in pregnancy. So hopefully this gives you an understanding of how I position all therapies, but specifically the small molecules. And again, thank you for inviting me and thank you for your attention.
Okay, thank you so much, Dr. Aguero. Amazing presentation as usual. Now, next speaker is Dr. Ala Sharara. He's a professor of medicine at American University of Beirut Medical Center and the previous chief of the Division of Gastroenterology at AUB. He is also a consultant professor at Duke University. Dr. Sharara has over 200 published peer-reviewed articles and 4 book chapters and served in editorial boards of Gastrointestinal Endoscopy, American Journal of Gastroenterology, Clinical Gastroenterology and Hepatology, and World Journal of Gastroenterology. And he is an associated editor of Inflammatory Bowel Disease. He's gonna talk today about newly diagnosed IBD patient and management approach. Dr. Ala, it's a pleasure to have you. The floor is yours.
Thank you very much for the kind introduction. Good morning, everyone. I also want to echo what Miguel just mentioned. Really great conference. Really the content, the presentations, everything, the attendance. And it's an honor to be here. So I didn't know what quite to do with the title I was given, Management of Early IBD Patients. So it's kind of like a IBD 101 kind of presentation. So I thought I'll just spin the presentation and talk about management of early Crohn's disease. And I'm going to try to be provocative today. So I want to stir up debate, and I want to be a bit counter sort of a dogma, and I want to stir up some discussion, and I hope that everybody will get involved in the presentation. So these are my disclosures. What I'm going to do is quickly review the natural history of Crohn's disease and show you that we often don't know which way things usually go. And then talk about what is early Crohn's disease and show you some evidence, both direct and indirect evidence of improved outcomes with early treatment, with some caveats regarding wide adoption of top-down strategies in early Crohn's disease. So what is the narrative that we've heard for decades now? Is that Crohn's disease is an evolving disease, it's a damaging disease resulting in bowel loss. This is the pivotal or important study that comes from the Saint Antoine group, Jack Cohn's study, which shows that patients over time really transition into a penetrating and stricturing disease, leading to complications in a large number of patients. And the idea here is that, of course, time is tissue in Crohn's disease, and with late Crohn's disease, you have these complications that happen, but also you have a change in immunobiology, and that potentially why response to treatment is diminished, a changing ability to respond to treatment, of course, and of course, disability and loss of bowel function and increasing complications. And there's data that supported that patients who have these more advanced phenotypes or different phenotypes of stricturing or penetrating disease have a lower chance of response to treatment. And some basic science evidence, this comes from the Peter Higgins group from Michigan, showing that in an animal model of inflammation, the early elimination of inflammation, in this case an antibiotic therapy for a salmonella infection, can result in diminishing the fibrosis, although it doesn't eliminate it completely. So the general idea is that we need to intervene early. Now, I put the Mona Lisa up here because this is the slide that is most used in every Crohn's presentation, but it's a slide that's not based on evidence. It's just a pictorial, made by an artist about what needs to happen. So we have to take that also and discuss that as to how accurate is this model. Nevertheless, the idea is that the disease is progressive, and there is a window of opportunity that if we intervene early in the disease, we can change the natural history of Crohn's disease. So what is early Crohn's disease? This is a working definition that was proposed by a group, including Laurent Perrin-Biroulet. Essentially, the idea is this is a disease that has not required biologic therapy or surgery and has not resulted in surgery or complications. And the duration has been picked to be less or equal than 2 years. Now, of course, this is a kind of a little bit of a random definition, but it's a definition that we can work with. Now, you can take that definition and, for example, on your next screening colonoscopy, you get into the terminal ileum, you see some erosions. Is that early Crohn's disease? No complications. We don't know. So the early Crohn's disease can span the spectrum from no symptoms to patients who have some symptoms but have had it only for a short duration of time. So the idea, again, is that from the preclinical phase, when the damage or the inflammation is at the histological level, to the late Crohn's disease, which is manifested with complications, you have this early opportunity, and perhaps by using disease-modifying drugs, we can change the natural history of Crohn's disease. And this is really the holy grail or the bullseye that we're after. How do we change the disease course and alter the course by limiting these or eliminating these complications? The problem is, there's a saying in Arabic, اقرأ تفرح جرب تحزن. So which means if you read about it, you're very happy, but when you put it into practice, it doesn't work. So this is the data of the pivotal clinical trials in patients who have Crohn's disease with anchoring, meaning if you start with 100 patients, excuse me, how many patients end up to be in clinical remission at the end of 1 year? So the data, as you see, these are not head-to-head trial, ranges for between 17 to 36% of patients are in clinical remission at 1 year. The reason we don't do so well, and this has been debated also, is that perhaps we're intervening too late, in that the usual mean duration of disease in these trials was anywhere between 7 to 10 years. Perhaps we're waiting too long, and that's why the results are not that good. But is that true or not? We will examine this. I showed you the slide yesterday. This is kind of the same data, but looking at mucosal healing, not just clinical remission. And you see on the right side of the graph, the percentage of patients who have mucosal healing. Again, a varying definition of mucosal healing, as Sarah mentioned yesterday. But nevertheless, you could see that the rates are kind of low, ranging between 11 to 40%, with perhaps some better rates for studies that have shorter mean duration of disease. You can see that in the middle of the graph, highlighted in red, for example, in SONIC and CView, and we'll come back to that in a minute. However, the natural history of Crohn's disease is perhaps arguably not as bad as it's painted, because we work in referral centers and we see perhaps the worst cases. But generally speaking, if you look at population-based studies or European-wide cohorts, you kind of get a mixed picture. So you have disease that evolved to complications rapidly in 20% of patients within 90 days. And you have this half full, half empty kind of situation where only 50% will need steroids, only 50% will develop fibrostenosing or penetrating disease. You have 20% who have spontaneous remission, and you have nearly 50% who are in clinical remission for the last years of follow-up, and only a third of patients required surgery during their first 10 years of diagnosis. So you can look at this from two ways, it's half full, half empty situation. Now, going back to the Saint Antoine group and the Jack Cohn group, this is another study that was published more recently by the group, or relatively more recently, that actually put into question whether all patients are going to go into this inexorable progressive disease with inflammation and stricturing requiring surgery or complications. So they divided patients into mild to moderate Crohn's disease versus severe Crohn's disease. And they defined severe Crohn's disease by using a special group of Jeté experts who came up with this definition. And you could argue that this may be not your definition of Crohn's disease. They thought active disease, more than grade 1 for more than 3 years, more than 1 intestinal surgery, establishment of permanent stoma, death related to CD or complications CD, or complications of treatment as indicating severe disease. Now, on the left side of the slide, you could see that what happened to those patients. So very few died, some had resection, but you could see that many patients had quiescent disease in the mild to moderate category on the left versus patients with severe disease. And only a few had to have surgery or had active disease all the time, which is kind of surprising. And then you look on the right side of the graph, you could see the type of therapies these patients receive. And the mild to moderate Crohn's disease patients really were given nothing, or 5-ASA, and a few received immunosuppressants, and even less received biologics compared to the patients with severe Crohn's disease. So again, putting into question whether, even in a referral center, whether all those patients have this inexorable progressive course that ends up with these complications. And they couldn't really identify, what was even worse, identify what can predict this progression of severe disease, except for the things that we already know. So age, smoking, disease duration, and rectal involvement. And interestingly, high education level was protective in those patients. Whether that's related to compliance or et cetera is not clear. So what is really the natural history of Crohn's disease? That's the question, that's the million-dollar question that you ask yourself when you have a patient in clinic with disease and say, okay, which way are we going to head with this patient? So going back to this figure, my problem with this figure is that this portrays the disease in a slightly simplistic fashion, showing that the disease progression is linear. But it's not linear, and I would propose to you that this model probably is more likely what happens. People start at the first phase, but really some of them go off on a completely different curve. Some have very aggressive disease. Right from the get-go, they present to you, even within the first 2 years, with fistulizing disease, and some patients continue to do well and are basically asymptomatic. So it's kind of a very different natural history for different people. And of course, we'd like to predict which patients fall into which group, but we don't really have a way to do this very well. We'd like to identify patients who have this aggressive phenotype and try to intervene early, or the earliest possible. But what do we have as models? We have some suggestions, and this was shown earlier by Miguel this morning. We have, of course, early age, deep ulcers, extensive disease, penetrating disease, prior surgery as risk factors that can help us identify these patients. Now, Corey Siegel also tried to come up with a predictive model, so kind of a easy computer-based or web-based way of predicting outcome in patients. And for that, doing the study, they used these variables, so a combination of disease location, including perianal disease, but also some serological tests, and one genetic test, which is the NOT2 frameshift mutation. And this prospect study suggested that you can identify the trajectory of a patient by plugging in these numbers and trying to see which way the patients go. Now, the concordance was acceptable. It's not really amazing. So you have a 0.75 concordance, which is acceptable or good, but not great. The problem with this model, if you can see here on the multivariate analysis, is that you look at the hazard ratio on the right, and really your main driver remains perianal disease. So if you take that out, your predictive value is really much less. Again, going back to the basics concepts that we mentioned earlier. So what is the evidence for improved outcome in early treatment? I'll show you some indirect evidence and some less robust direct evidence. So this is data from Wales, Cardiff. This is a retrospective population-based cohort. You could see that the time of intervention of thiopurine, for example, in this study, was associated with a reduced risk of having surgery. So the earlier you start thiopurines, the less the chance you'd have surgery. Now you could say, well, thiopurines don't really work. We know from SONIC that it doesn't work. SONIC is a study that had a short disease, so the median duration of disease was 2.2 years, and it showed that infliximab and the combination was better than azathioprine, but we'll come back to this in a minute. This is data from the EXTEND trial also showing that earlier disease tends to respond better, less than 2 years versus less than 5 years versus more than 5 years in terms of mucosal healing. And also CALM showed that patients who have a median duration of disease of 1 year, you can achieve really important results in terms of endoscopic remissions in patients with a tight control strategy. So all of these pointed that we have better results with early treatment, but we don't really have a comparison with other studies.
Prof. Ala, we have 2 minutes left.
Oof. I think I might need a little longer if you could spare me the time, because this is really, I think, getting to the debate. But anyway, I'll try to go a bit faster. So this is CView, and you can see in the CView trial, which compared adalimumab, ustekinumab, is also the clinical remission was about 60% in 1 year, and I want you to remember this number of 60%. We'll come back to it in a minute. So generally speaking, for early treatment, you have a double the chance of achieving clinical remission rates compared to a step-up treatment later. Now, I want to take you back in time to this study by Brian Fagan, the COMMIT trial, which was really a triple intervention study. So it was steroids, infliximab, with or without methotrexate. And look on the right, the clinical remission rate was 50% in those patients, despite the fact that the time since diagnosis was more than 10 years in those patients, and nearly half of the patients had had surgery. So again, late disease, similar results in terms of achieving remission. This is data in pediatrics that shows that early intervention with 6-MP is also associated with improved outcome. And the question really is azathioprine effective in adults? 2 studies have looked at this, the RAPID study from the JETAID and the AZTEC study from the Spanish group. Both studies showed that azathioprine was not superior to placebo, although on post-hoc analysis there was some benefits to using the azathioprine. One point with the AZTEC study, 1/3 of the patients were not on steroids at inclusion, meaning they received azathioprine as induction therapy, which clearly doesn't work. However, just again, let's look at the rates of remission in patients, and you see this 60% at 1 year with placebo and or with azathioprine, which is really similar to the clinical remission rates in the CView trial at 1 year with patients with early disease. Again, bringing the point. Going back to SONIC, you saw azathioprine doesn't work. However, I think most of us have not really picked up on this. In the SONIC trial, 2/3 of the patients in the azathioprine arm were not on steroids at randomization, meaning they received azathioprine as induction therapy, which clearly doesn't work, and the deck was really stacked against azathioprine in the SONIC trial. How about, I'm going to finish up with top-down surgery for early Crohn's disease, which is kind of a revolutionary concept. You know the LYRIC trial, so we'll come back to this. And there is some change in the results of surgery. This is the old literature. You'd have to have reoperation rates that were very high in patients who had the first-rate surgery for Crohn's. But now things have changed, and a study from 2 eminent centers in Europe show that both at 5 years and at 10 years, your chance of having another resection is really less than 20%. So this was the basis for the LYRIC trial, which, to remind you, included patients who have only terminal ileal disease restricted to less than 40 centimeters, and the study showed that there was improvement in quality of life scores at 1 year, no difference in other hard outcomes, and the endoscopic remission at 1 year. The authors followed, this is the cost effectiveness study showing that surgery was more cost effective than infliximab. This is the 5-year follow-up of the LYRIC trial, and you see the results with the infliximab group that half of those patients progressed onto ileal resection, 40% stayed on the anti-TNF, and 20% were moved to another treatment, whereas in the resection group, none underwent a second resection, and only 26% had to go on anti-TNF therapy. Well, this is a randomized trial in early Crohn's disease, suggesting that surgery is actually a better option than infliximab. I mean, I wouldn't be advocating surgery from the get-go, but it's something that we have to keep in mind. So finally, just some caveats about adoption of top-down strategy in early patients. I mentioned that we want to identify the patient with aggressive disease, but the downside is that we might be over-treating patients who do not have a progressive disease. And the downside of this is, of course, the risk of infection. This was covered a bit earlier, especially with the drugs that are at the bottom of the pyramid, and the risk of cancer. And with the pyramid, despite the fact that the Rigero pyramid shows us that we have improved safety, there's also some consideration, including cost. Finally, cost is important when we consider those patients because the drugs constitute more than 50% of the bill in patients with Crohn's disease. There was a cost-effectiveness study done by the Swiss IBD cohort group looking at whether you give biologics early versus wait and give them late. This was actually a pretty complicated study in terms of its analysis, very well done, including tornado graphs and effect on societal perspective, etc. And in that study, adoption of early biologics in all patients was not a cost-effective strategy, although the authors suggested that maybe with the availability of less expensive biosimilars, potentially this could become something to consider. And I think biosimilars are, of course, here to stay. So my take-home messages is that the natural history of Crohn's disease is variable and not always predictable. The predictive models lack accuracy and have inherent limitations. I showed you some indirect evidence for improved outcomes with early treatment, but the direct evidence on natural history remain limited. And there are safety and financial caveats in adopting a top-down strategy, and as always, a personalized, targeted approach is the most important. Thank you.
Okay, thank you, Prof. Ala, for your, as usual, amazing presentation. We're going to open the floor for probably a couple of questions because we are tight on time. We start late, so we need to catch up with our schedule. Anyone have any question? I guess I have two questions for both. So, Prof. Rigero, you talked since yesterday about biological treatment and today about new molecules, and every day we're growing number of medication. And definitely we all know there is multi-factor in choosing which drug that we're going to use for each patient. How far are we from biological precision, and are we close, as we see some data about HLD Q105 with combination therapy, and how far we are from using this biological profile and microbiome profile to choosing and targeting certain patients with biological precision?
So I wish I could say we are very close to this. If we think about genetics for a minute, 20 years ago, we said everything's going to be figured out with genetics in 5 years. We'll have all the genes for Crohn's and ulcerative colitis, and look at where we are today. I think to answer your question, we don't have the biologic precision medicine on the horizon. The HLA-DQ was interesting, I think, in terms of predicting antibodies to TNF inhibitor. I think what we are getting better at is stratifying based on certain clinical factors in combination with some of the biomarkers at understanding who we start earlier treatment. But your question's excellent. Who do we use, a JAK inhibitor versus S1P versus 23? We're just not there yet. I'm afraid, I don't want to sound pessimistic, but I'm afraid we're going to have the same conversation we had with genes 20 years ago where we said, oh, we're going to know everything. I don't know that precision medicine, get a blood test, tell you which medicine to use is probably going to be anytime soon. I hope I'm wrong. I think it's still going to be probably 10 to 20 years before we have anything close to that.
Such jealous person from oncology colleagues. So the second question for Prof. Ala. You talk about interfering in the natural history of a disease during the clinical status. Again, I'm looking for the future. So how far are we from starting to interfere in the preclinical status rather than waiting until the disease show up?
That's a really very important question, and we really have no data on this. I mean, Fred Colombel started this study in Lille looking at pre-diagnosis or preclinical manifestations. So they have a wide population of pediatric and adolescent patients in whom they're collecting data, including tissue, blood, et cetera, and following up those patients. So we'll need to basically look at this kind of strategy also, whether you can identify these patients and whether intervening even at that stage does make the difference. As I showed you, even with early disease, the definition of when to interfere and in whom to interfere is really difficult already. So very difficult to convince somebody who doesn't have symptoms to basically get treatment.
So thank you so much. I think we are concluding our lecture today, and so thank you so much.
Thank you, Dr. Miguel Reguero and Dr. Ala Sharara for this nice presentations. I think this is a good introduction for the next satellite symposium for Bristol Myers. Dr. Miguel Reguero mentioned a lot about the small molecules, the ozanimod. Ozanimod, just as a disclaimer, is not, it's available in the market, but it's not already approved by the Saudi FDA for management of ulcerative colitis. But these molecules are coming for treatment in inflammatory bowel disease in the near futures. Today, I will just give the introduction, and Dr. Nahla Azzam will take over after that, talking about S1B modulations of S1B in ulcerative colitis. First slide, please. Okay. So we know that ulcerative colitis prevalence and incidence been increasing, especially in our area for the last few years, especially in our area here in Saudi Arabia and also in the Middle East. And the usual age of onset is usually young people around 27 to 40 years old. And the majority of the patients, when we look our data, the majority of them, they still having involvement of the left colon. Around 20% to 30% of our patients have ban colitis. It's continued to be a relapsing and remitting disease, where at least 50% historically for our patients they need at least ulcerative colitis-related hospitalization during their lives. Looking at the data for the last few years, around 20% they will end up with colectomy, although we are seeing this rate is decreasing with the introduction of biologics in the last few years. Of course, we know with the long times when they have ulcerative colitis, they have an increased risk of colorectal cancer, where they require more of endoscopy and looking for dysplasia. So what are the unmet needs for therapies in ulcerative colitis in the Middle East? We're still seeing a lot of patients where they need prolonged or repeated courses of corticosteroid to manage their symptoms. We know the side effects of corticosteroids, especially in the long run, and this is, I think, something we have through our region and also in other parts of the world. Although 5-ASA work well on some of the patients, it continue to be some of the patients, they will not respond well to the 5-ASA. From Miguel Reguero, just a presentation today, only 20% of these patients, they will not have an extensive disease. Around 80% of ulcerative colitis patients, they will have an extensive disease and they will need more of biological therapy. Thioprin are associated with also a lack of efficacy. It would need a long time to work for our patients. We have some of the patients, they will end up with intolerance and the long-term side effect, especially for young male, for a population like our population, where majority of the young male are ABV negatives. The long-term risk, even that it's still low, but the long risk of lymphoma is higher in our young male patients comparing to other areas, and also the adherence to self-administered medications, especially the sub-Q medications, and also the difficulty sometimes when they have the IV infusion medications to control the disease. So what's about the other biological therapies we have for ulcerative colitis? We know that with the anti-TNF, there is a percentage of patients, they will have a primary non-responder. Dr. Badr Bouardi in his presentation yesterday, around 30% of the patients, they will not respond, and will continue to lose around 10% of the patients with secondary failure because of the immunogenicity. Majority of our patients, they will need at one time during their treatment of a dose escalations for either anti-TNF or also anti-IL-23 and IL-12 medications. And also, even with the presence and the safety of anti-integrin like vedolizumab, there is still a percentage of patients, they don't respond well to these medications, and or they will lose response as secondary loss of response. So what are the rationale for developing a new novel mode of actions? We need actually more medications that have a rapid onset of actions. And I think we are seeing this more and more with the small molecules. We want medications that have a better and short long-term efficacy, and of course at the same time better safety, and at the same time we want a medication that is of administration for the patient, where they don't require to be admitted to the hospital for IV infusions, and for some patients who don't prefer to have sub-Q injections. I will stop here for my presentations. I will give the floor for Dr. Nahla Azzam.
My presentation, yeah, thank you. Assalamu alaikum. Welcome, everyone. I would like to thank Mr. Chairman for this nice introduction and would like to thank Bristol Myers for having me. I will go over S1P1 receptor modulator as a treatment of ulcerative colitis. This is my disclosure. The agenda today we will go over the S1P1 receptor modulator as novel therapy. Dr. Uthman told us that there is unmet need for a novel and new therapy. And we will just cover ozanimod mechanism of action. And I will touch about the key data on the clinical trial on ozanimod, Touchstone, and True North, which based on the True North, the the drugs approved by FDA and EMA, and the clinical implication incorporating this medication in UC management landscape. Then I will end with challenging case and we'll talk about it with the audience here. It is a little bit, we have to start with some immunology. S1P1 phosphate, sphingosine-1 phosphate actually was found to have a physiological and immunological function in terms of activating lymphocyte, leading to exit lymphocyte from the lymph node. It was found by actually the progress and evolution of knowing the pathogenesis of IBD. It was found the S1P1 to be increased in patients with IBD, and by binding this to lymphocyte will lead to exit the lymphocyte outside the lymph node, and it goes to the tissue in site of inflammation and will increase the inflammation, and subsequent tissue damage will happen. Actually, S1P receptor found throughout the body. It has 5 subtypes distributed throughout the body. And actually, S1P1 modulator receptor, it has been there for quite some time, but for other indication, which is multiple sclerosis. And fingolimod, which is for multiple sclerosis, is BAN receptor modulator. And we are now moving to what you call ozanimod, which is more selective and will come over. This is lymphocyte migration. This diagram showed lymphocyte migration. If you have naive lymphocyte in the bloodstream, which is activated, go to lymph node, and within the lymph node, S1 bind to the receptor and lead to exit of the lymphocyte outside the lymph node, goes to the tissue where inflammation and inflammatory cascade will happen, leading to damage. The proposed mechanism of action of ozanimod, actually it is a receptor modulator which lead to reduce the exit of lymphocyte from the lymph node and what you call trapping of lymphocyte within the lymph node, and this will lead to reduce the efflux of lymph node and subsequently reduce the inflammation and the damage. As I mentioned, we are moving to more selective. Ozanimod, it is selective S1P1 receptor modulator. It has efficacy on S1P1 and S1P5. The key data of ozanimod in clinical trial and UC, we have 2 key data, or landmark study, Touchstone and True North. For Touchstone, it is phase 2 trial designed to assess the efficacy, safety of ozanimod in 2 different doses in comparison to placebo for moderate severe ulcerative colitis. So it is 1:1 to 1 randomized trial, placebo versus 2 doses of ozanimod, and it is actually it comes as one dose kit from the pharmacy, from the manufacturer of the drug. It is 1 week escalation, and the primary endpoint was as week 8, and it was the maintenance phase up to week 32. For the one who responded at week 8, the continuous that three different, either placebo or ozanimod, two different doses with maintenance endpoint at 32, while the non-responder, they were maintained on open label extension study. The inclusion criteria, it is adult between 18 to 75 years of age of ulcerative colitis patient. They're moderate to severe Mayo score of ranging from 6 to 12, and they are allowed to maintain on 5-SA and steroid, but not above 30, and they have to require to have a stable dose through the induction phase, and other biological or immune modulator, it has to be discontinued prior to screening endoscopy. Exclusion criteria different from fulminant, colitis, C. diff as the usual, or inpatient treated with cyclosporin and tacrolimus. This is the basic characteristic of those patient population, which you can see that they are tough population, disease duration ranging up to 6 to 7 years, mean Mayo score of, as mentioned, 8 to 12, 6 to 12 was mean of 8. The majority are left-sided, while 40% were in extensive colitis. Better biological was in around 30 to 40% of the patient, and mainly either primary non-responder or secondary loss of response. The primary endpoint at week 8 was clinical remission defined by Mayo clinical score of less than or equal to, and is a lot of bunch of secondary endpoint in terms of clinical response, mucosal healing, histological remission with GOPAS score less than 2. In this figure, it shows clearly on the left side the clinical remission at week 8, which was in favor of ozanimod over placebo, and as well as a maintenance phase with week 32. If you look to clinical response and secondary endpoint, it was also in favor of ozanimod in 2 different doses, which was also maintained and induction and maintained up to 32 weeks. Mucosal healing also, it was also in favor of the drug. Same as here. As we are always concerned about efficacy, we're also concerned about safety. This class is a novel, new in era of IBD, so the safety finding on those induction and maintenance of touchstone study was favorable. Actually, majority of the side effect, which is common in other class in terms of anemia, headache, pharyngitis, just mild raise of transaminase, and no serious side effect, only less than 2%. Then after that, it came the landmark study, which is True North, the phase 3 randomized 52 weeks clinical trial conduct to assess efficacy and safety of ozanimod in patient with moderate severe ulcerative colitis. It is little bit the study design different than True Touchstone. Actually, it is the induction period was 2 cohort. The first one around more than 600 a patient. It was randomized to 2 to 1, placebo to ozanimod fixed dose, 1 milligram oral daily dose. And the cap of this cohort for better anti-TNF was around 30%, while the cohort number 2, it was around 367, and it is open label with ozanimod 1 milligram daily, and the cap of better anti-TNF was around 50%. The primary endpoint was assessed at week 10, and after that, the patient, the one who responded, re-randomized to either placebo or ozanimod to maintenance of 52 weeks. The non-responder was maintained on open label extension study. The eligibility almost the same, male and female adult IBD patient with the extent of the disease should be beyond the rectum, above 15, so the majority are either left side or extensive. You see a Mayo score of 6 to 12 with endoscopic subscore more than 2, rectal bleeding subscore more than or equal 1, and stool frequency score more or equal 1. And it is different than Touchstone. Also, it is allowed to have 5-SA and prednisolone. However, it has to be tapered during the induction, not allowed in maintenance phase. This is a demographic of those patients, which also show tough population with total Mayo score ranging from mean of 8 to 9, 40% extensive, and the remaining left side. And I mentioned that bare medication steroid has to be tapered, anti-TNF in around 40%, and on those population, vidozolumab, bare vidozolumab was included. And as you know, vidozolumab is leukocyte trafficking. It's the same almost mechanism of action, and ozanimod is lymphocytic traveling agent, and this will we'll show in a while the result. Primary endpoint, it was clinical remission defined by 3 objective components of my score. The 4th component, where the physician assessment, was not included to have a more of objective outcome. So it was a solid outcome. Also a lot of key secondary endpoint in clinical response and endoscopic remission and mucosal healing, which is defined by endoscopic improvement plus histological remission with Scopus less than 2. This is induction. While maintenance, almost the same endpoint, but it was added that's corticosteroid-free remission because not allowed to continue steroid after induction therapy. This is the result, the efficacy data on this study. This figure shows the left one, clinical remission. Also, it was ozanimod statistically significant over placebo. If you look to the other secondary endpoint, all were met and were in favor of the drug. As all the other class, better or anti-TNF was less response compared to one who's naive to anti-TNF. We can see that most of the secondary endpoint and primary endpoint were met. Patient-reported outcome is very important. Those patients with moderate severe UC, they would like to have a quick report of the symptom improvement in symptom. And as you know, trafficking agent, we expect to have little bit delay response. However, when we look to the change from baseline from rectal bleeding over the 10 weeks induction, we can observe from this figure that even the improvement in symptom and rectal bleeding started from week 2 and evident from week 4, the patients start to have significant improvement in their symptom. This is a maintenance phase. Also, actually, the drug did very well in terms of clinical remission at the maintenance phase, and all the secondary endpoints were met, and also as shown in the figure in terms of clinical response, endoscopic improvement, corticosteroid-free remission, and mucosal healing, and the most important, the durable remission. The one with no barrier anti-TNF, as you all expected, is better than the one with a barrier anti-TNF. This is the histological remission, was defined by Gibbs score less than 2, also was in favor of ozanimod. Fecal calprotectin, as Dr. Asara told us yesterday and educated us, that it is a good monitoring tool and very important to look at it in terms of monitoring our patient plus the symptom. Also, it was a very significant change in fecal calprotectin at week 10 and even was durable, and the efficacy was extended beyond the maintenance phase. And we can see in this figure, it shows clearly decrease in fecal calprotectin. Safety is still an important issue for us and concern for the patient and for us. Also, there is no much of safety signals with the medication. The majority, as I mentioned, even like in a Touchstone study, True North also showed that up to 52 weeks, the maintenance, the side effect was favorable. What we have to be in precaution when we start ozanimod? I think we have to be cautious with patients with active cardiac disease, active infection, active malignancy. However, it doesn't differ than any other class. In this class of group of medication, it is preferable to have basic workup with CBC because it is lymphocyte trafficking agent and trap the lymphocytes. So in more than 50% of those patients, they have lymphopenia. So basic CBC with differential is very important. Liver function test, because around 4% they have raised transaminase. Also in the study didn't require discontinuation of the medication. Having distributed the S1P receptor throughout the body, include the cardiac cell and muscle. So basic ECG to rule out any conduction abnormality, it has to be done from day one. In patient, it's preferable that in patient with diabetes, history of uveitis, macular edema, it should be avoided, and this is why ophthalmological assessment at the start of the medication should be done for all patients, and favorable those three patient, diabetes, uveitis, macular edema, not to start ozanimod. Herpes zoster vaccination is required, and as I'm sure all of us practicing now, all our patients from day one, we advise them to go for vaccination. And in True North, actually the inclusion criteria include the patient who are vaccinated or had a history of herpes zoster in the past. Despite that, still there was around 4% developed herpes zoster, but it was mild and doesn't require hospitalization. But we have to encourage all our patients to take the vaccine. Ozanimod, there is a lot of study on pipeline of ozanimod in IBD. True North just finished. Yellowstone, I think they are approaching ending recruiting the patient. It is study in CD and other ongoing study on pipeline. It is very important to look at the durability of the patient of the medication, and this is very important for the patient perspective. They would like to have drugs that is durable and safe over time. We have open label extension from True North program. It was presented at the ECHO this year, 2023. Actually, the one who this is the one who were on maintenance. And they complete the maintenance phase of True North study. The one who was in ozanimod and completed the maintenance phase, they went for open label study, and approximately up to 3 years, they look at the efficacy and safety. And this is actually very impressive because initially it was significant in the maintenance phase, but the open label, I think, was highly significant, as you can see in the right side on the figure, up to 3 years of continuing ozanimod, the clinical remission reaching up to 70, and we are in secondary endpoint clinical response, endoscopic and clinical response, we are seeing a figure reaching 95. That means, in the other figure on the right side, the one who respond to induction and maintain, and they continue to have control of the medication and clinical response throughout 3 years up to 95, and only few was they had secondary loss of response. In terms of safety, for a long-term extension study, also the majority are most frequent, side effects, which is common in other classes. If you look to the risk of infection, more than 3%, it ranges from sinusitis, pharyngitis, upper respiratory tract infection, upper sinus infection, or chest infection in 1 to 2%. Herpes zoster, as I mentioned, up to 4%, but not required any hospitalization. Malignancy was also reported in 2 patients, actually 3 patients, one with malignant lung neoplasm and 2 with basal cell carcinoma. And the most important, the cardiac side effects, which are of our concern in terms of high conduction abnormality, 3rd-degree heart block, or other hypertension, worsening of hypertension, as well as the major side effect, macular edema, was reported in 1 to 2%. And overall, only 6% from those patients who maintain up to 3 years only discontinue the drug. This is also open label extension data from Touchstone, but here it is beyond 3 years up to 200 weeks, and also favorable outcome, and very safety was also very favored, and no significant safety issue. Only herpes zoster in 1 patient, lymphopenia also in the majority of patients, but significantly than 200, reported only on 9 patients, serious infection in 4 patients, and no serious cardiac abnormality, and 1 death occurred after 2 years of study. Mucinous adenocarcinoma of unknown origin was reported in 1 patient. So the author conclude from the long-term data that the one who responded on induction, they had the sustained efficacy up to 2 years, beyond 2 years, and we have up to 200-week data. No new safety signal was observed, and the finding provide an extensive efficacy and safety for ozanimod, and based on that data, the ozanimod got FDA and EMA approval for treating ulcerative, moderate to severe ulcerative colitis, but not yet in Saudi FDA. And Saudi FDA not yet approved, I have to highlight that. Also, it is in the process. So where Prof. Miguel, he just highlighted the positioning of the therapy from his experience. Actually, it was, I noticed that in his slide, he mentioned that he positioned ozanimod in moderate, not hospitalized UC, and I think it is approved in the United States, and they are using it. This review was published last month, August 2023. It was review of all available medical therapy to treat moderate to severe ulcerative colitis, and the proposed algorithm. And for ulcerative colitis, they put both ulcerative and Crohn's, and you can see it's a little bit busy slide. However, for moderate, actually a lot of first line, most of the drugs that we know, they put it and propose that it is effective in first line, anti-TNF, as you all know, anti-integrin, VDU, IL-12, ustekinumab, and even S1P1 modulator, ozanimod. And in this study, they propose that it should not wait to fail 1 or 2 biological. It can be used right away after failing 5-SA. So positioning it in landscape, I think with time we will have a more from all the society position about the therapy. First line, a lot of drugs. Which to choose, it should be shared decision between the physician and the patient, and also patient satisfaction in terms of, from their perspective, durability and safety and convenience on route of administration. It has to be discussed. Just I will go over two case scenario, and with this I would like even to share with the audience about their opinion. I had two patients. The first one, actually, 29 years male, diagnosed as pan-ulcerative colitis, started with symptom of bloody diarrhea and abdominal pain. Colonoscopy showed Mayo score of 1 to 2 throughout the colon. He was started on steroid methylamine as induction. Then subsequent year, he started to flare on 5-SA, required 2 doses of steroid, repeat colonoscopy, active colitis with high immune marker. Infliximab at that time was started, initial great response, and he had colonoscopy in 6 months, which showed complete healing, mucosal healing. So he was in clinical and endoscopic remission. But after that, in 1.5 years, start to have numbness and paresthesia of his lower limb and headache. Taking history, found to have family history of MS. The sister had MS, seen by neurology. Also, he was in deep remission. They asked us to hold it till we do further investigation. During that time, he started to flare. Colonoscopy started to have, because he was still, I resumed him on 5-SA and local, deep ulcer on right side. He developed C. diff at one stage and required vancomycin. Lab showed a high marker in terms of fecal calprotectin, and MRI showed lesion consists, it's subtle lesion, but consists with MS. So how would you manage this patient at this stage? We need maybe opinion. Osman, if you can share this.
So this is a classical patient where he have ulcerative colitis, not respond or respond well to anti-TNF, but then develop some complications. We are seeing these patients, especially neurological manifestations. We don't really have a medication that gives them can tackle both the MS and the ulcerative colitis. At least we don't have them approved yet in Saudi Arabia. I know they may have other options in the United States, but for these patients, I use combination of MS medication like Junefia for them with local therapy, because I don't have like the S1B1 medication being approved yet for ulcerative colitis. I don't know if Dr. Reguero want to mention anything here.
Yeah, I mean, I think, so obviously you give an Ozanimod talk and then you present a patient who might have MS, and this naturally would be a very good S1P choice. And to back up a second, for demyelinating diseases that may come from a TNF inhibitor like MS, really the two options for us would be natalizumab and Ozanimod. Because of the concerns about PML and the JC virus, we've tended not to use natalizumab as much. This would be a very reasonable choice for Ozanimod. One caveat I will make is if you presented that exact patient who had C. diff, TNF, failing TNF, C. diff patients, as you all know, ultimately have a higher rate of colectomy. That would have been a patient I would have given upadacitinib to as my next choice. But with the neurologic changes, I think Ozanimod, I realize here that may not be an option, but I think Ozanimod would certainly be a great option.
Same, Prof. Ala or Prof. Yusuf. So actually, as you rightly mentioned, I think this patient, if we can tackle one medication that can treat both, I think Ozanimod could be the good choice. He failed conventional infliximab-induced demyelinating disease. I think also at that time, actually it's still at our pharmacy, we have Form B, what is, we can request medication even if not yet Saudi FDA, we can request it patient-based request, and this is what we request for this patient. The second case is a little bit, patient was older. He's 63 at age, at 2016. He was like a 63 years old. Hypertension for 10 years, diagnosed as pan-ulcerative colitis since 10 years. And initially he was on ADA, but ADA induced pancreatitis and maintained on mesalamine. Referred to my clinic late to 2016 with active symptom. However, during workup on biological, found to have a latent tuberculosis was positive quantiferon, leading to requiring INH prophylaxis. Then Humira was initiated. In 2019, he had a flare with active colitis. Despite of dose escalation of Humira, and despite that, which was not responding, then we shift him to infliximab monotherapy. As ADA, we cannot use it because of pancreatitis and still active symptom with colonoscopy Mayo score of 2. Then he was started on vidazolumab with great response and great endoscopic remission, subsequent to colonoscopy in deep remission. However, early this year, around February, started to present with flare, symptom again, fecal calprotectin, and he is actually sending me text, messaging me whenever he had active bleeding. He was really anxious about this flare after quite some time in remission. I started steroid short course. Despite of steroid, I scope him, still Mayo score 2. So we have a patient who's 60, almost 7 years old. How would you manage? He failed conventional as an induced pancreatitis, history of latent tuberculosis, failed so far 3 biological, and is still on steroid higher dose. And whenever we taper 20 milligram, he has, again, it's continuously throughout, he's still having symptom, but the bleeding, it become more if we drop it below 20 milligrams. So treatment option at this stage?
So I think the good things here, we have options now. We have more options. We have more mechanism for actions. We heard yesterday talks by Dr. Miguel about optimizing the interleukin, the anti-integrant. This is one of the patients I will try to optimize or increase the frequency of the infusion for vedolizumab for this patient. If they fail, we could treat this patient using the interleukin 2312. We could use the JAK inhibitors, and also other mechanism of actions once it's approved, like the S1B1 will be an option for these patients. It's a good thing that we have different mechanism of actions available for our patients.
Would you use JAK, his hypertension, patient with hypertension, 67 years old? Would you be comfortable using it? Yeah.
So I didn't really notice. I missed the age, but I think this is one of the options for the patients. I would say the safest for these patients will be the anti-integrin, optimizing it. If it's not, this will be the interleukin 2312 will be an option for this patient.
I think using a JAK inhibitor is a very good option in this patient. Now, clearly, this patient is similar to the oral surveillance study, an older patient, 1 cardiovascular risk factor. This chance of a major complication is potentially increased, but I don't think that's an issue. I would definitely give the patient Shingrix, though, an older patient receiving JAK inhibitor, but I think it'd be a good option.
So the only thing I'll add to that, so I agree completely, is don't forget in the upadacitinib, and I know that's not available here, in the upadacitinib studies in ulcerative colitis and Crohn's, 80% of patients met the criteria of having at least 1 cardiovascular risk, and about 25% were over the age of 50. So there were patients like this who had hypertension, high cholesterol. I would not shy away from using tofacitinib, or when it's available here, upadacitinib in this patient. I agree you could try to optimize the vedolizumab. One thing I'll say from my personal opinion, I don't think ozanimod would be a good choice in this patient. 2 different anti-TNF therapies. now failing veto, certainly it's approved for that and there are patients, but when you look at 3 or more failures of biologics, if that's your only option, no problem. One other thing I'll say is ozanimod does work in about 25% of patients who've been on veto. So being on veto and failing doesn't mean that you cannot use ozanimod, and it's certainly reasonable. And if that is your only option, obviously colorectomab, surgery is an option, but assuming the patient doesn't want it, it's not a bad choice. I just think you have better choices.
Yes.
But I have a feeling you're going to put him on ozanimod, so we'll hear what you did in a minute.
Prof. Yusuf?
I agree with the other colleagues, but I think in this particular patient with a history of latent TB, I know that you covered him well with INH, but if you have more than one option at the time, then I would probably tend to go with the IL-12, IL-23. If you don't have the IL-23, then I would use the ustekinumab. I think I would just feel maybe psychologically at least, or at least comfort-wise, I would feel more comfortable than putting him on JAK.
Okay. We had this discussion with a colleague and a fellow last week. Actually, this patient since 2 months is active. And the question raised about possibility of ozanimod after vidazolumab. Also, the decision was to go, I started him on IL-12, ustekinumab IL-12/23. However, to give ozanimod in patient who is exposed to vidazolumab, actually, this is a post-hoc analysis, phase 3 True North, post-hoc analysis from True North study. Actually, this is a design and expose around 180 patient and a total of 1,000 patient were vidazolumab exposed patient. The majority, the key demographic picture of those patients really was tough population, 52 extensive disease, 78% Mayo's endoscopic score of more than 3 at baseline, 85 previously exposed to anti-TNF, and 61 receiving corticosteroid at baseline. And we can see from this efficacy data that ozanimod can be effective after vidazolumab. Also, it is the same mechanism of action, lymphocytic and leukocytic trafficking agent, and it has this efficacy was shown in all the met endpoint in terms of symptomatic remission, clinical remission response, and even mucosal healing. And its corticosteroid-free remission also reached up to 36. And my patient was nagging; he doesn't want a steroid. He was really against colectomy or steroid. But at least this data supportive that ozanimod is effective in patients who were previously exposed to vidazolumab, and this is why ustekinumab was started. However, ozanimod can be used. By that, I will conclude that ozanimod is the first and only S1P receptor modulator that currently approved by FDA and EMA for treatment of ulcerative colitis. I have to highlight, not yet by Saudi FDA. It is once daily oral treatment, having a favorable safety. Data showed excellent durability and extended efficacy up to 3 to 4 years, and it can be effective in patients exposed to vidazolumab. And thank you.
Thank you, Dr. Nahla. Just for the sake of time, we'll continue with the program. Thank you, and thank you for everyone for the great discussion. We'll start with the next session. Dr. Muhammad, I think he's the chairperson, Dr. Muhammad Al-Khatami, and
So, good morning. So, we start session 7, and first of all, I'd like to thank my dear professors for the great invitation and for the success of this Ibd Masterclass we're enjoying since yesterday. We will start with Professor Turki Al-Amil and Professor Sarah Al-Oili, right? They'll be giving us a talk about the debate 2. Patient wants to de-escalate his therapy, agree or disagree. Professor Turki.
Good morning. Thank you so much, Dr. Khurshid, for the introduction, and thank you all for attending. It's really a pleasure and honor to talk to you this morning. And I'm happy to be sharing the stage with my friend, Dr. Sarah Al-Oili, and we'll be discussing and debating whether patients with IBD should stop their treatment or continue. I'll be arguing for the side de-escalating therapy. These are my disclosures. So I'll start with a case from my own practice. This is a 38-year-old lady with left-sided ulcerative colitis, presented initially with diarrhea, up to 10 bowel movements per day. At least 50% of them were associated with rectal bleeding. We performed colonoscopy, which showed a Mayo endoscopic score of 2, and we started her on treatment with induction corticosteroids in the form of budesonide MMX, followed by topical and oral 5-ASA therapy. She did very well. Her fecal calprotectin dropped from 1200 to 128, and we repeated her flexible sigmoidoscopy, and indeed it showed improvement with Mayo score of 1. She did very well for around 2 years, and then she developed some back symptoms. We evaluated her clinically by a rheumatologist, and we performed MRI, and she was found to have sacroiliitis. She did not respond to non-steroidal anti-inflammatory medications, and therefore she was initiated on infliximab treatment for managing her extraintestinal manifestations. So the question now, in addition to her infliximab therapy, should we add methotrexate? Should we continue her topical 5-ASA with infliximab and stop the oral form? Should we stop both oral and topical 5-ASA? Or should we stop infliximab therapy as soon as her symptoms of sacroiliitis improve? Now, I want to assure you that this debate, although this debate may get a bit heated, Dr. Sarah and myself have been good friends for many years. We share passion and interest in Crohn's and colitis, and we both trained in North America. And although she's currently in Abu Dhabi and I'm in Dammam, we both grew up in Riyadh, in neighborhoods not far away from this very venue. But that's where our common interests end. We supported rival teams. She has been a supporter of Al Nasr Club, and I have been, and I will always remain a supporter of Al Hilal Club. And if this debate was about which team is better, I think my task would have been much easier. Al Hilal Club is the better team. The scores, the goals, the championships speak for themselves. But my task this morning is to convince you that my side of the argument for de-escalating therapy is the better side and the winning side, just like Al Hilal team is the winning team. So why is that? Well, the most important factor in this equation is the patient's perspective. And we know from multiple surveys, including this one from Europe, that a significant percentage of patients are interested in stopping their treatment at some point in the future. This is a group of 100 patients with IBD on infliximab, and 19 patients expressed their interest in stopping infliximab at some point in the future. They were more likely to be keen on stopping their treatment if they were younger patients, female gender, or if they have stopped their treatment at some point in the past. They were more likely to be interested in continuing therapy if they had flares in the past that improved with treatment, and if they had high trust in their providers. And that should not be a surprise. That should not be a surprise. There are concerns about the safety. Professor Sharara alluded to this study earlier on. This is a 90,000 population-based study from France looking at IBD patients on infliximab, anti-operian therapy, showing that if you combine these two agents together, you're more likely to develop lymphoma with an adjusted hazard ratio of 6.1 compared to an adjusted hazard ratio of 2.4 or 2.6 if you received either agents alone. And if you look at the outcomes with opportunistic infections, similar results. If you combine both agents, you are more likely to get poor outcomes. Another good reason to consider stopping treatment is cost saving. This European study looked at the cost saving from not stopping infliximab, but adjusting the dose based on TDM. And indeed, you save 6% of the cost on a population of 10,000 patients receiving infliximab. And this translates to 25 million euros if you use the originator infliximab, and almost 13.8 million if you use the biosimilar infliximab. Significant amount of money that you may need to spend on newer agents and newer molecules. So can we stop 5-ASA therapy in a patient with ulcerative colitis, similar to the case I presented? This is an individual participant data looking at clinical trials of anti-TNF agents in patients with ulcerative colitis. And it showed that whether you continue infliximab, shown here in red, or you stop, if you continue 5-ASA, shown here in red, or if you stop 5-ASA, shown here in blue, you reach similar outcomes in terms of clinical remission, clinical response, and mucosal healing. So there is probably little benefit of continuing on 5-ASA when you escalate therapy to anti-TNF agents. And similar findings were reported with other agents, including vedolizumab from the clinical trials of vedolizumab. This is from the University of Calgary group, including our friend Abdullah Mtairdi when he was doing his fellowship there, reaching the same conclusion that whether you continue 5-ASA when you escalate to vedolizumab or you stop, there is no significant difference. And the guidelines are clear. I'll present them in a second. The reason why you should consider stopping 5-ASA is that you will be saving money. You may not save as much money as you did when you stopped your biologic, but the cost saving in the US is around $1,400 per patient per year. And if you're thinking that this is a relatively safe agent with good tolerability, then think about the cost. If you are using it purely to prevent colon cancer, you have to spend around $250,000 to prevent one case of colorectal cancer. And the guidelines are clear. These are the American College of Gastroenterology guidelines stating clearly that in patients with ulcerative colitis who require escalation to advanced therapy, one should stop 5-ASA at that point. Moving on to immunomodulators, if you're using them as a monotherapy to manage your IBD, then one should probably question the efficacy. We know that in Crohn's disease, both the ASTIC and the RAPID trial were open-label trials published in Gastroenterology looking at patients with Crohn's disease, and they showed that there is no benefit in using azathioprine as monotherapy over conventional treatment, whatever that means. And in the SONIC trial, as you may recall, there was a third arm where azathioprine monotherapy was used, and the mucosal healing rates were 15.6%, significantly lower than what would one hope to see in one's own practice. What about in patients who have been on combination therapy of anti-TNF plus immunomodulator? Can we withdraw the immunomodulator? This question was addressed nicely in the SPARE trial, a recently published investigator-initiated study looking at Crohn's disease patients who received infliximab and immunomodulator and have been in remission for at least 2 years, and the question was, should we de-escalate therapy? They divided patients into those who stopped infliximab, continued immunomodulator, stopped immunomodulator, and continued infliximab, or continued on both the immunomodulator and infliximab. Open-label trial, 64 hospitals in many countries, stratified patients according to the duration of Crohn's disease. The co-primary endpoints were relapse rate in a superiority analysis, and then time in remission over 2 years' time in a non-inferiority analysis. This is the design of the study. Patients were screened. Again, they have to have been in deep remission for at least 2 years. They were randomized to continue both treatments, stop either infliximab or immunomodulator. They were evaluated at the end of 40 weeks. Those who were in relapse and have been on infliximab received intensification of the dose. Those who stopped their infliximab were allowed to receive reinduction with infliximab. 211 patients, around 70 in each arm, and the results were interesting. At week 40, those who stopped infliximab, at least a third of them developed relapse. And if you look at the combination therapy arm who continued on combination therapy, relapse rate was 12%. Those who withdrew the immunomodulator, relapse rate was 9%. So no significant added value to continuing the immunomodulator in this patient population. Moving on to 2 years data, again, if you withdraw infliximab, 36% chance of relapsing. Combination therapy group, 14% relapse rate, and the immunomodulator withdrawal group, 10% relapse rate. The SPARE trial, the good news in the SPARE trial is that among those who relapsed after discontinuation of treatment and received the reinduction or intensification of infliximab as the protocol outlined, 25 out of 28 achieved clinical remission. It's worth highlighting that the trial excluded patients who received biologics other than infliximab and excluded patients with perianal Crohn's disease. So this is a group of patients who tend to be sicker with a poor prognostic profile. You may want to continue both immunomodulator and anti-TNF in this particular group of patients. So to make my case for de-escalation therapy, I showed you clearly that you will be saving money. I showed that the continuation of 5-ASA in patients with ulcerative colitis who require de-escalation, who require escalation to an advanced agent is not indicated with no added benefit. And then the SPARE trial told us that in patients with Crohn's disease who received infliximab and immunomodulator and have been in remission, there is no point in continuing the immunomodulator in the long term. Thank you so much.
So I think Dr. Sarah, Al-Nasr team, you have Cristiano, so I think we'll find some...
Sorry?
You have Cristiano in your team,
Well,
so I
that's
think
the
we will
thing,
hear a lot
right?
of
That's
debating
the
here.
exact reason I chose the team, but don't tell Turkey. Such a pleasure to be with you this morning. Thank you very much to the organizers for inviting me, and congratulations on the success of this wonderful conference. Dr. Al-Alamil, you made this very difficult, but I'm going to take on the challenge. So my patient wants to de-escalate his therapy, and I respectfully disagree. Disclosure is non-relevant for this talk. And so, as you so nicely pointed out, we did grow up in Riyadh together. I'm going to be for the Cristiano Ronaldo team, of course. That was so obvious. But let me take on this challenge and see if we can make it better. So starting off with a quick case, my case is a 28-year-old lady who was diagnosed with ileocolonic non-stricturing, non-penetrating disease at age 15. She was first started on azathioprine, did not tolerate it, moved on to adalimumab. She actually achieved clinical remission at 3 months, followed by endoscopic remission 6 months later. Really going with the textbook, did great. She developed secondary loss of response, though, a few months later to adalimumab, and then she developed new perianal fistulizing disease. TDM at the time showed undetectable levels and high antibodies. She was switched to infliximab monotherapy. She had declined being on methotrexate and did not tolerate azathioprine. She went into clinical endoscopic remission. Her fistula closed over time, MR enterography, no active disease, you know where I'm getting. She remained in remission over 2 years, and the last colonoscopy shows no active disease endoscopically, even histologically, and she wants to stop infliximab, so what do we do? So you talked about how it's great to be, the good idea about stopping therapy or de-escalating. I'll try to inform you onto why it's not necessarily a really good idea in some cases. The first thing is relapse, of course. So when you're de-escalating or stopping therapy, there's a very high chance that you may relapse, and that's a big deal for our patients. The other thing is loss of response when restarting. And you were mentioning this, but it is a big deal as well, right? When you're restarting a treatment, you're really not sure that you're going to be recapturing response, and that's a big deal for our patients. Decrease in number of available options. Unfortunately, we don't have unlimited options in IBD at this point, and every option counts. And so once you've used them up, it's really hard to go back. And then the issue of safety, right? Infusion reactions when you retreat. So and then what happens when we stop, right? We really don't know. Our patients are all different, and it's very hard to predict. Patient A will do okay, patient B will not do okay. Of course, precision medicine, we're getting there slowly. That would be ideal, right? Because then you could say, well, listen, the gentleman in red could do well, the gentleman in green is not going to do well based on different factors. But unfortunately, we're not there yet, and we still have to guess and try to predict outcomes and risk stratify like what we do in our clinic every day. So this was a really nice review by Joanna Torres, and she put there, it's a nice summary of essentially risk factors for relapse after you stop anti-TNF and IBD. And I won't go through that whole list, you could refer to it, but essentially the big bottom line is, of course, if you have any signs of active disease before you stop therapy, that's a bad sign. Of course, if they have a high CRP or low hemoglobin, or they have symptoms or absence of mucosal healing. So those are all going to be risk factors. And then, of course, factors reflective or poor prognosis. So for example, young age, perianal disease, smoking, ileocolonic or ileal disease as opposed to colonic disease, etc. And then lastly, something interesting and that we should remember when seeing our patients is even their history is important, right? If they have needed 2-3 biologics to get to where they're at right now, this is a risk factor. If they've had prior immunomodulator failure, etc. So you can see that our patient actually fits, there are a lot of risk factors there, and so it may not be a really good idea to stop infliximab in that patient, as you can tell. So when we do stop therapy, what happens? What are the outcomes that we see? So this is the most recent meta-analysis on the topic. There are a few out there. They tried to look at relapse after anti-TNF cessation in Crohn's disease. They actually tried to get individual participant data. It was about 1,300 patients from 14 studies, 11 countries. And I want to point out that their relapse, the way that they defined relapse, was a relapse that necessitated reintroduction of a biologic, steroids, immunomodulators, or surgery. So this is a big deal. It's not just having symptoms here and there. So how many relapsed? Well, listen, relapses after anti-TNF cessation occurred in about 52% at 2 years. And in fact, it took them a median of 13 months to really get to a relapse. So quite scary there, right? Of course, we can't have a de-escalation talk without mentioning STORY. You all know STORY. This was a prospective study of 115 patients with Crohn's disease. They were in corticosteroid-free remission for at least 6 months. And those patients were on combination therapy and infliximab. And infliximab essentially was stopped. And then the 1-year relapse rate was 43.9%. So again, almost half of the patients there relapsed. We do have long-term data of STORY, and this is the 7-year data that was published a few years later. And just to make it short for you, you could see that out of 102 patients that were followed over time, only 22 did not require biologic to be restarted or had a major complication. So just to do the math for you, 78.4% either needed to restart a biologic or had a major complication, which is not insignificant. How about specifically in perianal Crohn's disease? And you pointed that out with SPARE, Dr. Alamil, is that a lot of the times they don't include patients with active perianal disease, and so they didn't either. This was just an observational study, and 45 patients that were treated with anti-TNF for perianal disease, right? And when that infliximab had been stopped, what they found is that 80% had luminal or perianal relapse during follow-up. So, and you can just see that curve, just the image really tells you everything about it. And the median time to relapse was 14.9 months. Wanted to highlight this trial. This is another trial, so just like SPARE. This also just came out recently a few months ago. This is the STOP IT trial. It was discontinuing infliximab in Crohn's disease as well. This was published in the New England Journal of Medicine, the new online journal. Their version of the new online journal. This was a multi-center, randomized controlled trial, 115 patients with Crohn's disease. They were all in very, very deep remission. Clinical, biochemical, endoscopic for at least 1 year. Look at their SES-CD score there. It's essentially 0 in both arms. And they were essentially randomly assigned to either continue infliximab or to stop it. And of course, that was placebo for 48 weeks. Results, again, very disappointing there, right? Infliximab continuation in orange, you can see that survival curve really just screams, do not stop infliximab. Relapse-free survival was 100% in the infliximab continuation group and 51%. So I think you're getting the point. The issue there were no predictors of relapse that they could find. So they tried to look at different baseline parameters, including combination therapy, blah, 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 nothing. Nothing really mattered. They still relapsed, 50% of them. Also wanted to point out this only trial of ulcerative colitis de-escalation. This is the Hayabusa trial. It's a Japanese trial. And it essentially, their primary endpoint there was remission at week 48. And easy there, you could see in the left, those are the ones that continued infliximab, and on the right, they discontinued infliximab. And again, 80% at week 48 were still in remission if they had continued infliximab, but then only 54% really were still in remission, so quite scary there as well. All right, so then the question is, well, if we do stop and we restart therapy, what are the outcomes? And so a lot of studies have looked at this, and Dr. Lamil was also mentioning a bit of these outcomes. But this was a big cohort that looked at this. The Evodis cohort, it was a Spanish retrospective multicenter study, more than 1,000 patients with IBD that were treated with anti-TNF, withdrawn, and then they, of course, they had reached clinical remission. They had to have reached clinical remission. 31% was the cumulative incidence of relapse at 2 years and 48% at 5 years of follow-up. I mean, this is retrospective observation, also not as clean as the data I just showed. But the good news, and this goes with Dr. Turki's side, 73% regained remission after retreatment with the same anti-TNF. Of course, I'm going to spare you all the studies, but essentially, when you look at the literature, there is about a 70% recapture rate whenever you restart anti-TNF. One more study I wanted to highlight, which really taught us a lot about restarting infliximab in patients. This was a study from Leuven. And what they did is they had 128 consecutive patients and who had restarted infliximab after they had stopped it for about 15 months, so more than a year. And they got a response when they restarted infliximab in 70% of patients at 1 year and 61% of patients at more than 4 years. So I do have to say, your majority of patients will respond. What are some of the factors that were associated with response? You could see there immunomodulators. So if you restarted treatment or infliximab with an immunomodulator, this was associated with a short-term response, and also the absence of antibodies to infliximab after dose 1. So they checked levels after dose 1, and if you had no antibodies, that really predicted you were going to do better. And in terms of long-term response, pregnancy or remission as reason for discontinuation was predictive of a good response. Of course, they were already doing well. And then higher trough levels after dose 1 was also predictive. How about the safety? Well, there you have it. About 20% of patients had infusion reactions. And so those patients are, okay, sure, it's not happening a lot, but it's still considerable, and we have to be aware of this issue. And how can we make it better? So undetectable antibodies to infliximab after dose 1 were associated with the safety of reinitiating therapy. So that leads to the strategy of how should you restart infliximab. This is not, this was from a study published in the Crohn's and Colitis 360 a couple years ago. It's a practice that a lot of us have. I did learn from Dr. Rigueiro's clinic. These are the 3 things. I did write it down in my notes on the phone. Whenever you restart infliximab, these are 3 things you want to do, and I think they're missing one of them in that diagram. First, you pre-medicate with steroids before your infliximab, and you pre-medicate for at least 3 or 4 doses. You'll correct me if I'm wrong. Then you check antibodies 1 week after dose 1. I do 1 week because back in Abu Dhabi, it takes us about a couple of weeks to get results. So after 1 week, I don't wait more than 1 week to get my antibodies. And then I add an immunomodulator, And this is really important, and it is evidence-based, as you just saw with the Leuven study. So, Dr. Alamil, how are we doing? So, you know what? We did actually prepare this talk together. And this was a lot of fun. And we did also want to show you that we do have a balanced view. Obviously, in clinic, it's not just this or that. It's not black or white. It's gray. and we have to take into account everything we have and all the evidence. And so, of course, we are going to have to de-escalate therapy in some patients, and if we're going to do that, what's our checklist? So this is a little mini checklist. First, look at the past. I tried to make it easy. Look at the past of your patient, their disease history and severity. Of course, if you're the patient in the top, it's not going to be as easy to de-escalate. If you've needed a lot of biologics, had surgeries, perianal disease to get to point B, it's not going to be as easy as A to B on the green, for the green patient there. And this is where you have to risk stratify. Look at your present. The patient is in your clinic and wants to de-escalate. Ask them why, and that's, I think, really important. Is it because they want to get pregnant and they're worried about safety, in which case you should not de-escalate? Or is it maybe because of some perceived safety concern they've read online? And this is when you really have a good opportunity to discuss that with your patient. Second, obviously, you need to make sure there's no active disease and you really want to reach the deeper remission you can get. And then future. You talk about the future right there with your patient. This is, if we do stop, this is my strategy, this is how I'm going to monitor you, and we need to be on the same page together. We need to do this together. You're going to have to come back for your fecal calpro, your CRP, etc. And then you do decide on the strategy together. So in summary, define your de-escalation. What does it mean? And I really loved your presentation, Turki, because listen, stopping or de-escalation doesn't just mean stop your anti-TNF. 5-ASAs, when you're already on a biologic, may not make sense, and I agree 100%. So what are we meaning by de-escalation? Is it stopping the 5-ASA? Is it decreasing the dose? What does it mean for your patient specifically? Risk stratify. What is the risk of stopping therapy in my specific patient in front of me? High rates of relapse do happen after anti-TNF discontinuation. We have to be aware of this. Most patients, though, thankfully, do respond after restarting anti-TNF and do have an exit strategy when you're talking to your patient, and shared decision-making is really key. Thank you very much.
Thank you very much, Professor Sarah and Professor Turki. I think that we all have the feeling that stopping or decreasing medications is very satisfying, and we like to tell the patient, we can stop some of your drugs. I think it's good with even the compliance of the patient. So giving more place to optimization, I think there's a lot to say about this great talk, and I'm sure there's a lot of questions, but let's keep it till the end. So, Professor Hussein.
First of all, I'd like to thank the organizing committee for inviting me to this elegant congress. Second, I have the pleasure to introduce Professor Bandar Al-Adwani. He is a consultant of psychiatry and psychosomatic disorders. He is a specialist in assessing and dealing with the psychological issues that come with a variety of medical conditions. Chairperson of the Scientific Committee of Psychosomatic Medicine Fellowship Program of the Saudi Commission of Health Specialties. Currently, he works as a consultant of psychiatry and psychosomatic disorders in King Fahd University Hospital. Professor Badr will talk about a very important subject, depression, stress, and anxiety in IBD patients, challenges in diagnosis and management. Professor Bandar.
Assalamu alaikum. Good morning, everyone. It's a pleasure, actually, to be here with you talking about, hopefully it would be an interesting topic and interesting talk about the psychosocial issues, mainly the depression, stress, anxiety in IBD patients, and hopefully we'll have some points to talk about that. So before starting, let's talk about some of the challenges that are related to the disease of IBD. There are many challenges. One of them is incurability, unpredictability of the disease, and severity of the symptoms, and the possibility of having surgery at some point during the course of the illness. Also, there are a major impact of the medication side effects on the patient themselves. So these challenges, in addition to other psychosocial issues, it would have a negative impact on the patient's quality of life. And as I mentioned, it would cause a lot of psychosocial burden that we'll be talking about it in a few minutes, inshallah. So one of the major questions that we have it on the daily basis in our daily practice and also in the literature, which is chicken or egg, mental health disorder, and inflammatory bowel disease. Does it matter? So in this editorial, they point this question with two aspects or two major issues that we face it on the daily basis in our daily practice, which is if the depression and anxiety symptoms could be a result of IBD by itself, or they have, the depression and anxiety, a direct impact on the disease activity, and it has a negative outcome on IBD patients. So they also comment on this study, which is a prospective study, which they followed around, this study was done in UK. They followed around 760 patients who they are older than 16 years old. And they tried to measure the depressive symptoms and anxiety symptoms as a baseline, in addition to other clinical findings, and to see the disease activity and clinical aspect and biomedical aspects using some of the indexes. So what did they find? That at the baseline, patients who they have high level of depressive symptoms at the baseline and anxiety and depressive symptoms, in addition with disease activity through the clinical and biochemical markers, they are more likely to have adverse effect. Namely, they have 2 to 3 times higher in glucocorticoids prescriptions, flaring and escalation of the illness, and the higher rate of hospitalization if you compare it to the patients who they don't have higher depressive symptoms or anxiety symptoms. Also, they have around 4 times higher in terms of intestinal resection, though it's not reaching the statistically significant. So as we can see here, there are 4 groups as the baseline according to the study. The first group, who they have clinical remission with no symptoms of mental disorder, depressive or anxiety symptoms. There is another group who they have clinical activity in their IBD symptoms, but they don't have symptoms of depression or anxiety. There is a third group who they have a clinical remission with symptoms of depression and anxiety. The fourth group, who have signs of clinical activity and signs of either clinically or through the biochemical markers. And as you can see here, the risk in terms of the glucocorticoids, almost the same. Not almost the same, but they are around each other. But for the fourth group, who they have higher symptoms of depression and anxiety, the risk is higher if you compare it to the other 3 groups. This is applicable also in the escalation of the treatment, risk of hospitalization, and also resection. But as I mentioned earlier, it doesn't reach the statistic significance. This is the same groups, but on the aspect of biochemical remissions. And as we saw on the previous slide, the risk is quite higher if you compare it to other groups if they have high depressive and anxiety symptoms as a baseline. So there are many explanations actually for this finding. One of them, that patients who they have depression, usually they are less adherent to the usual care of IBD. This is not applicable for the IBD patients, but also for the other chronic medical conditions. For example, patients who they have depression and myocardial infarction, patients who they have depression and stroke, patients who they have depression and other inflammatory disease like rheumatoid arthritis and lupus and etc. Specifically for IBD patients, there is data that the depressive symptoms by itself considered to be one of the important factors of TNF discontinuation or TNF non-adherence. This is one explanation. The other explanation could discuss that on the biological background of the communality between the depression and IBD through what we call it the gut-brain pathway. And as you can see here, at the same time where there is the gut inflammation, there is what we call it neuroinflammation and transmission, which also explain the high prevalence of depression in the IBD on the biological basis. Not only that, but also there is a high relation between some of the depressive symptoms with some of the inflammatory marker like C-reactive protein, as we can see here, especially with sleep difficulties, feeling tired or having little energy and poor appetite. One more explanation about the high relationship between depression and inflammatory process, that there is a high role of immunosuppressive therapy, cytokine modulating drugs, and infliximab and filuzumab, and improvement depressive symptoms in the patient with inflammatory conditions. So this aspect could explain why patients who they have IBD, if we compare it with the general population, they are 2 to 4 times higher or likely to develop depression, and 3 to 5 times higher to develop anxiety disorder. Now, if we return back to the previous question that we talked about it in the beginning of this presentation, about the relationship between the depression or psychosocial issues and the IBD, actually the two aspects are quite true. From one aspect, that the depression and anxiety could complicate or could, as a result of the IBD, could increase. Also, as we saw in the previous slides, that it has a direct impact on the outcome and the disease activity. So there are a few messages from the previous study that the common mental disorders, especially the depression and anxiety, are the risk factor for poor prognosis. And there is an importance of screening routinely for patients who they have IBD, especially at the baseline. Also, considering adding the psychosocial issues, especially depression and anxiety symptoms, as a part of therapeutic target, in addition to other treatment targets like clinical and endoscopic targets. The importance of screening have been endorsed by many guidelines, like European guidelines and even the American College of Gastroenterology clinical guidelines, about the importance of screening for patients who they have IBD, as stated here. And we'll be talking, inshallah, in more details about how we can screen and when we are screening. So let's talk about now about some of the management issues and challenges that we face it with some of the IBD patients. Before talking about that, we should really address that there are some challenges in terms of addressing the mental health issues in IBD populations. One of these challenges is lack of knowledge, attitude, skills of some of the gastroenterologists or enterology providers in addressing mental health disorders. As we know from the practice, the busy clinical appointments, which sometimes affecting or it's not giving you a proper time to assess those issues. The other major issue, which is a limitation in accessing the resources for mental health provider who they are willing to work with IBD patients. This is the limitation of accessing the mental health provider is one of the major challenges worldwide, but also here in Saudi Arabia, according to this Saudi National Mental Health Survey, that which showed that around 70% of severe psychiatric disorder, they receive treatment, and around 83% of who they have severe psychiatric disorder, they didn't receive any treatment in Saudi Arabia. So accessing the mental health, it's quite challenging here in Saudi Arabia. This is according to psychiatric disorder, but this could be, you can imagine that if you want to refer your patient to any mental health providers. So if you want to talk about more practical way, there are some advices that could help you to integrate what we call it psychogastrology into your management for IBD patients specifically and digestive disorder in general, because as you see, you are seeing a lot of psychological symptoms in your practice. One of these advices that is having a routine assessment for depressive symptoms and early life adversity and functional impairment for your patients, especially after the time of diagnosis or at the time of diagnosis or the baseline or during any or during the disease activity. Also to having a routine assessment of what we call it extra-intestinal manifestations like fatigue, sexual dysfunction, pain, sleep difficulty, and etc. Not only that, but also having a good background about the common stressors that usually the IBD patient have. It's a good idea to consider it during your assessment. According to this study, there are many stressors, but the most common are family stressors, work and school stressors, and financial stressors. So the question right now is when and how we screen for these psychosocial issues. You can start by having an open question like, how have you been coping or managing lately? كيف أمورك الفترة الأخيرة؟ بعد ما صار مثلا disease activity or during the follow-up. كيف شو مسوي مثلا؟ هل في مشاكل الآن في عائلتك؟ هل في مثلا في الفترة الأخيرة صار في مشاكل بعد التنويم الأخير؟ هل قدرت ترجع مثلا للدراسة أو للعمل أو في أي إشكاليات ثانية؟ Just having this open question will give you a chance to talk more in more detail or more depth about the other psychosocial issues. The other advice is helping yourself and familiarize yourself with some of the common self-report tools like PHQ-9 or Patient Health Questionnaire. It has been validated in Arabic, and also it has a good sensitivity and specificity for IBD patients in comparison with other scales. And it's free. You can just print it and keep it in your clinic or use it. And it has a question about even the suicidality. But one of the concern with this scale that sometimes you will not be able to differentiate about the disease activity symptoms and depressive symptoms. As we can see here, during the disease activity, there is around 45 to 86% they report fatigability. Also, around 77% they report sleep difficulties. And as we saw in the previous scale, that it might mislead you if the patient scoring high in terms of sleep difficulties or feeling tired or having difficulty in the concentration during the disease activity. This is another scale, which is Generalized Anxiety Disorder Scale. It could help you to screen for anxiety. We use this not for diagnosis, but to help you to diagnose and to screen for depressive symptoms and anxiety symptoms. The other advice is having a friendly language in related topic or following related topic, like the bidirectional brain-gut pathway, the psychosocial factors that dysregulate the brain-gut pathway, and the justification why you are referring your patients. Usually, usually the patient, they have a stigma when you are talking about mental health issues, and it would prevent you to have this aspect, and it would prevent you also to refer them to the mental health provider. So having a simple language, trying to explain يعني مثلا انه في احيانا كثيره بعض المرضى قد انه بتجيهم يعني تاثير بين الجهاز الهضمي الجهاز العصبي، وكثير من الاعراض متعارضه يعني متشابهه مع بعض. احيانا بعض الادويه اللي نستخدمها we use it for treating the depressive symptoms and anxiety symptoms, it would help وتساعد بشكل كبير في موضوع بعض الاعراض في الجهاز الهضمي. احيانا كثير بعض المرضى قد يعني will get benefit يعني يستفيدون بشكل أكثر لما يتحولون على أخصائي نفسي. فذات يعني having this simple language during your discussion with your patient, it would help them to accept the treatment and accept the referral if you decide to refer them. The other thing, the other important advice is familiarizing yourself with some of the most effective brain-gut psychotherapy. There are many studies showing that physical activity and exercise and other psychotherapeutic intervention, it's very helpful for depressive symptoms, anxiety symptoms, and also it's helpful for some of the extraintestinal symptoms like fatigability and sleep difficulties. Psychotherapy, the cognitive behavioral therapy, it has many evidence. There are also evidence on stress management, and there are some evidence on what we call resilience-based training. It would help patients in terms of depressive symptoms and having better coping with their illness. The other advice is establishing a direct referral with 2 or 1 mental health provider, either in your institutes or in the private sector of governmental sectors, to help them to either to provide the contact information to your patients or trying to direct communication with them to refer your patient for if they need any help. The last advice is familiarize yourself with 1 or 2 neuromodulators that could help you if you decide to prescribe any of those medications. This is an example of some of the medications that could help in terms of the anxiety, depression, chronic pain, or sleep difficulties. An example of that, if you talk about selective serotonin reuptake inhibitor, commonly I'm seeing a lot of GI consultants who prescribe escitalopram, and it would help you in terms of starting dose, incremental tapering up, and the effective dose. Also, the other common medication that we use it a lot, which is sertraline. It would help in depression and depressive and anxiety symptoms. This is the starting dose and incremental tapering and the effective dose. Also, but if you decide to start a medication, you should also familiarize yourself with some of the common side effects, like agitation, insomnia, night sweat, sexual dysfunction, with the specific consideration of patients who they have IBD, especially patients complaining from diarrhea, nausea, and weight loss. But sometimes the SSRI has a benefit for IBD population or gastroenterology population, especially who they have constipation or diarrhea, and it might help in augmentation with tricyclic. Venlafaxine and duloxetine is an example of SNRI, which would help in sometimes an anticholinergic effect with diarrhea and pain. Tricyclics, one of the common example is amitriptyline. In Saudi, we have difficulty in accessing even nortriptyline. Sometimes it's not available, so we use amitriptyline. Clomipramine, sometimes it's used, but commonly amitriptyline it's available, and even the price is so affordable. These are the common side effects, and as you know, the tricyclics would help with some of diarrhea symptoms or IBS symptoms and reducing the pain as well. Mirtazapine is another antidepressant which is helpful for sleep difficulties, weight gain, and for depressive symptoms. Antidepressants generally, they have a beneficial effect in terms of well-being and depressive symptoms and anxiety symptoms, improving quality of life. However, the efficacy on the disease activity cannot be determined. If you decide to start a medication, start it, but follow your patient, monitor the side effect and therapeutic effect, and consider the absorption state of your patients. Some of the patients, they have difficulty in their absorption, so they might sometimes, they will not get any benefit from that medication. One of my patients, he's not, when I started him on venlafaxine, he didn't report any side effects for that medication. After a few days, he told me that he passed the capsule itself in the stool, so he's not absorbing the medication at all. So you keep especially the patient didn't report any side effects or any therapeutic effect, make sure that he's absorbing that, and you can change the formula accordingly. Lastly, I want to share this statement with the patient, with women with Crohn's disease, it would help in considering our practice. You treat my sexual health problem, you are treating my Crohn's. You treat my eyes, you are treating my Crohn's. You treat my anxiety, you are treating my Crohn's. You treat my self-esteem, you are treating my Crohn's. We are going to get to treat me as a whole. We are both on the same journey, but they are only looking at one aspect of it, and they miss it completely. So, giving that, having some of treatment goal and considering the psychosocial aspect as a treatment goal in addition to other therapy target or other treatment goal, which is a clinical and endoscopic target, it would help you to address the psychosocial issues. Thank you so much.
Thank you, Professor Bender, for this very elegant presentation. Actually, your presence inside this clinic will be beneficial not only for the patient, but also for the MRT team of the IBD clinic. Mohammed?
Started to prescribe citalopram, maybe more than the drugs for gastroenterology since the COVID. So thank you very much. I'd like to present Professor Mariam Mukhtar. She's currently an assistant professor at the King Abdulaziz University Hospital in Jeddah. She completed internal medicine and gastroenterology training at University of Toronto, Canada. She also has an American Board of Internal Medicine. Dr. Mariam completed her clinical IBD fellowship at St. Mark's Academic Institute and National Bowel Center in London. So the floor is yours, Dr. Mariam.
Thank you so much for the introduction. It's my pleasure to be here today. So the talk today is about histopathology in IBD. I have no financial disclosures. The only disclosure I have is I actually come as introduced. I'm a gastroenterologist. I'm not a histopathologist. So I'll approach this talk looking at it from a gastroenterology perspective. So I'll try to walk you through the role of histopathology in the making of IBD diagnosis and then in follow-ups. Starting off at index endoscopy, when a patient presents with colitis-like symptoms, our role as endoscopists is to provide the histopathologist with a specific biopsy sampling. So the guidance is usually to provide them with the normal mucosa as well as the most abnormal looking mucosa, specifically sampling the edges of ulcerations. You're expected to provide them with the biopsies from the ileum, from the rectum, as well as from 4 colonic sites at minimum. And then these should be submitted in, with identification of the anatomic location and with clinical background history of the patient, providing them with the presentation, with the risk factors, with the infectious exposures, etc. The histopathologist will then use this sample of biopsies and will go through a process in his mind. So the first question they ask themselves is this mucosa normal or is it inflamed? If it's inflamed, is this IBD or is this another colitis? If it's IBD, can we differentiate this into ulcerative colitis, Crohn's disease, or can we just say it's IBD unclassified? And then they'll assess the severity, the extent of the disease, but also they'll look at the complications, including presence or absence of dysplasia, neoplasia, or even superimposed infections like CMV or C. difficile. So with that in mind, I'm going to walk you through starting off with normal histology. So depending on how you cut the histological slides, the crypts either look like tubular structures or they are rounded, looking like suckers. If they're cut in this way, then they should actually run parallel to each other in a nice regular way. Some occasional branched crypts are acceptable if it's at the anatomic location of the anorectal junction, but more than that, it's abnormal. The crypt extends from the epithelium into the muscularis mucosa. You have to realize that in a normal histology, there is a variation of cellularity as well as the density of the inflammatory cells. It is acceptable in the right side of the colon, specifically the cecum and ascending colon, to see a high density of inflammatory cells, excluding neutrophils. So you'll see lymphocytes, eosinophils, plasma cells, that's normally accepted. The other thing that you see is a Paneth cells. So Paneth cells are intestinal epithelial cells. They have an immune regulation role. And they're accepted to be present in the cecum, but if they're present in the left colon, it's called Paneth cell metaplasia, which is a marker of chronicity or colitis. So what defines active inflammation? Many definitions, but the hallmark is the presence of neutrophil polymorphonuclear sites in the crypts. So that's cryptitis, in the crypt lumen, that's abscess, or in the surface epithelium or the lamina propria. Chronic inflammation is actually manifested or seen as an architectural change. So whether it's a crypt dropout, if it's or crypt atrophy, crypt irregularities, and other morphological changes, including changes in the surface epithelium into what's called a villiform surface epithelium. There will be also monocellular cell infiltration and hypercellularity in the lamina propria, and some, as I mentioned, the Paneth cell metaplasia in the left colon. So in this slide, as you can see, the surface epithelium is irregular. There is a continuous inflammation. There is a basal plasmacytosis, and on the extreme right side, you can see an erosion in the mucosa. Again, another picture of cryptitis, so infiltration of neutrophil in the crypt epithelium, and the lumen being filled with the neutrophils, which is crypt abscess. And the other picture is for Paneth cell metaplasia and cryptolytic granuloma. Having said this, all of these changes, whether it's active or chronic, it does not actually identify the type of colitis. So there are non-specific features. So if the histopathologists see them, the next question that follows is usually, is this IBD or is this another cholidity? I'm not going to go into the depth of this because there is a talk in the afternoon about the IBD mimickers, so I'll leave it to that. But just to highlight, histologically, the best marker to differentiate IBD from non-IBD is the presence of basal plasmacytosis. There are other highly reliable features, including the presence of background crypt distortions and changes that goes with chronicity in this colitis. So the follow-up question is then, is this UC or Crohn's disease? We all know the gross morphological changes of the typical way Crohn's disease and ulcerative colitis present. But we have to always be mindful that atypical UC distribution happens, specifically in the adolescence or pediatric age group, where you actually see rectal sparing and you see cecal patch and backwash ileitis. But also, in a long-standing ulcerative colitis, if the patient specifically has been treated with oral or topical treatment, it's expected that the rectum will actually normalize and there will be histologic resolution of crypt abnormalities. So if you do not provide your histopathologist with the clinical context specifically saying this is actually a long-standing ulcerative colitis, this will potentially lead to a misdiagnosis or a change of diagnosis from ulcerative colitis to Crohn's disease. So this is something just to keep in mind. Now, histopathological features of UC is basically a collection of the active and chronic inflammation features I just mentioned. Again, if you want to use one point or one feature, it's the basal plasmacytosis. It's the earliest. It's the one with the highest positive predictive value. Histopathology of Crohn's disease, it's a few features: the focality, the patchiness, the transmural ulceration and involvement, and the granuloma. I'll stop here and talk about granuloma. So what is granuloma, or what do we know about granuloma? There are two types that we know of. There is the non-cryptolytic granulomas. So this is unrelated to infection, unrelated to crypt rupture or infectious etiologies. This is in the context of clinical background of IBD, very distinctive of Crohn's disease. But it does happen. The other big differential we have here is TB, and the distinction is usually the presence of necrosis. If it's cryptolytic granuloma, it's a non-specific feature that results from crypt rupture. Basically, any injury to the mucosa, whether it's infection, whether it's colitis, leading to crypt rupture will look like cryptolytic granuloma. This can happen in IBD as well as all infectious colitis. It does not discriminate anything. So the BSG, British Society of Gastroenterology, has a nice table where they actually list features, histopathological features, and they divide them into reliable and less reliable features in trying to differentiate Crohn's disease from ulcerative colitis. But again, this is not a simple, straightforward distinction. It has to be put into the clinical context and background. What are the other adjunctive tests we have to differentiate? So we all know that we can use the histopathological specimens and run multi-gene analysis, trying to differentiate the cytokine expressions of Th1 and Th2. We can use them also to look for something called beta-catenin and RB protein in adjunct with serum ASCA and PIANCA. And this has been basically a way to differentiate ulcerative colitis from Crohn's disease. If the pathologist if he believes that this is actually an IBD colitis, but he cannot see any discriminatory features like fitting this into ulcerative colitis or Crohn's disease, then the term is IBD unclassified. And we always highlight the fact that this is actually a better term than indeterminate colitis, because it unequivocally stresses the fact that this is IBD. However, we don't know which type of IBD it is. So after the IBD is established, the next question is the histologic activity of this IBD. So what's the severity and what's the extent of the inflammation here? I'll walk you through some histologic scores that are not so much used in the clinical practice, but more in the clinical trial setting. So if we start off with UC scores, there are more than 30 scores that have been proposed. Partially validated ones and the most commonly used ones are summarized here up to 2017. And then a systematic review done by Dr. Mosley looking into these scores at the time concluded that the Nancy and Roberts scores are the most validated, but none of these available ones are actually fully validated. It's different for Crohn's disease, given the fact that it's transmural, it's patchy, it's difficult to actually histologically score the ileum and the colon similarly. So there is currently no mucosal histological activity score that is specific or validated for Crohn's disease. So we've had many wonderful talks over the past 2 days about STRIDE-2 and histologic remission. So just looking at this from a histological perspective, though, how do we define a histologic remission? So over the years, there have been many proposed definitions. Some of them were so strict, which is basically a complete normalization and restoration of colonic mucosa, and others were less stringent. But however, more and more, we realize that it's actually absence of intraepithelial neutrophils is the requirement for mucosal healing. The neutrophil being present is a marker of inflammation, and its absence is healing. We all heard about the discordance between endoscopic and histologic findings, the benefits of histologic remission in patients with ulcerative colitis. So I'm going to skip over this. One histologic remission score that has actually came in light in the last few years is a very simple, straightforward one. That's called the Picasso histologic remission score. So basically focusing on the one criteria of whether or not there is neutrophil infiltration in the mucosa. It also was integrated into AI and had a very good accuracy in correlation with endoscopic healing. Moving on to dysplasia in IBD. So just a little bit of history. In 1907, the British surgeon who, because of his work in colorectal surgery, he earned the title King Rectum at the time, was the first to recognize that UC patients had an increased risk of colorectal cancers. Among 30 of his UC patients, he's found that 7 of them had colorectal cancers. And in collaboration with the pathologist working at St. Mark's at the same time, Dr. Dukes, who we all know due to his Duke classification of colon cancer, basically over the span of the following years realized that the background mucosa does not look similar to the sporadic adenocarcinoma. And in 1922, Dr. Dukes called these changes dysplasia. This was followed by the first surveillance program that took place at St. Mark's in 1968 and led to the development of dysplasia classification in 1980s. The histopathologist's role did not stop there because they actually helped us develop the guidelines, whether it's CINIC guidelines or AGA dysplasia guidelines in 2021. And they also helped us understand more about the different pattern and non-conventional ways dysplasia can present in histopathology. And then eventually in 2023, just recently, they actually published a consensus classification for dysplasia in IBD. What are the adjunctive methods for dysplasia detection? So these additional testing can be done. So P53 tumor suppressor overexpression, it's something we can see in dysplasia and also in UC-associated colorectal neoplasia. However, it can be falsely positive, so it's not highly reliable. The better marker is the alpha-methyl-CoA racemase, which is a very sensitive and highly specific for dysplasia, and also has an increased positivity in low-grade dysplasia and adenocarcinoma. The co-expression of both of these is actually predictive of developing advanced neoplasia and rapidity of development of the dysplasia or the neoplasia. So the roles of histopathology does not stop here. If you look at this, this is basically a pediatric study that using a histopathological multigene analysis and looking into the inflammatory pathway and cytokine profiling, they tried to basically predict the inflammatory expression in these patients' population compared to the normal, and then predicting treatment response according to these profiles. If we talk about markers of activity or inflammation, so using quantitative ELISA, we can check the pro-inflammatory cytokine concentration in the mucosa. So we can check interleukins, we can check TNF, and the myeloperoxidase activity can also be used as an index of inflammation. The new, or the sort of like the new novel histologic biomarker that came into light is the mucosal oncostatin M as well. So this is a cytokine that belongs to the interleukin-6 subfamily, and it has actually been associated with a severity of inflammation in IBD, but more than that, it actually had a strong association with a prediction of failure to anti-TNF medication. So patients who expressed this in their histopathology were unlikely to respond to anti-TNF. So basically, this was an overview of the histopathology role in IBD. Thank you so much for listening.
Thank you so much, Professor Mariam. I think St. Mark is a tough place. They develop tough people at St. Mark at London. So having your training there, it's make you a lot of make you good speaker. So we'll take 2 questions to go to the next session, please, sir.
Mr. Kari.
Hello.
Thank you very much to all the speakers, wonderful talks. And the question is to Dr. Amil and Dr. Sarah regarding this de-escalation of therapy. In the patient that Dr. Turki that you presented was a May 1, May 2, I think, and then what prompted you to start the biologics was the sacroiliitis that the patient had, so you thought it was a good choice and everything. How about if a patient like this, you give them the infliximab, they get better, They have Mayo 1, Mayo 2 disease that was relatively controlled for about 2 years on 5-ASA. Now, at that point, if the sacroiliitis got better and all that, is there any chance to put them back on 5-ASA and stop the anti-TNF, considering from the beginning that it was a Mayo 1, Mayo 2 disease? I want your thought about that.
Yeah, so that's a good question. So if I understood the question correctly, it's the patient escalated not because of a luminal disease, but because of an extraintestinal manifestation. Would you stop it? And my feeling, and I tend to agree with Sarah on this, is that once they're sick enough to require biologics and anti-TNF therapy, if you de-escalate, at least we know from a luminal disease that there's at least 50% chance that they will relapse. And in my patient's case, she was planning to have children, so we didn't want to have relapse at the time when she's pregnant. But to be honest with you, I don't know if there are exact numbers, and you can help me if you know the answer, if there are exact numbers on the risk of flaring of extraintestinal manifestations after stopping biologics.
So it hasn't really been shown to be a predictor of relapse based on the studies we have, but it just really makes sense that if you, on top of having one indication for IBD, you really, well, for biologic, you really have two indications. It certainly wouldn't be a patient in which I would de-escalate easily. I'd have a really, really long conversation and make sure that they are aware that there's a very high chance that they're going to relapse from an IBD standpoint, but also from an ankylosing spondylitis standpoint.
The other question, just a continuation of the same one, a very short one. We know 50% will relapse if you stop the treatment, but this is looking at about a year from stopping the treatment. What about 2-3 years down? We know that we're dealing with a chronic disease. Do you have any idea, like further down the line,
Excellent question.
whether that number goes higher or?
Right, excellent question. And so we don't actually have a lot of long-term data. Probably the longer-term data we have is from the STORY study that I showed earlier. So they had the 7-year data. And what they found is that most people did relapse maybe the first couple of years, but you still had people that did well the first 2 years and ended up relapsing the following years. So over 7 years, they still had a bit more than 50% relapse. And you could really relapse at any point, which really makes you think you should be monitoring these patients not just the first year or two, but you should really be monitoring them over time.
Professor Sarah, we know much about the anti-TNF de-escalation, but what about other classes of biologics and small molecules, especially they are lacking immunogenicity, like anti-TNF?
It's a great question, and actually we don't have data on this. We have only one study looking at vedolizumab. And in that study, it was a retrospective study, it was a JETADE study, and they found that about 70%, 65% relapsed after stopping the vedo. But 70% of them did better when they restarted the vedo. But you would think that they have less immunogenicity, and so you'd be able to recatch response, but not necessarily in all of them. But we're going to get more data over time, right? The data we have is mainly anti-TNFs, because when we've been starting ustekinumab and vedo in these advanced therapies, it was mainly in patients that were already on anti-TNFs. But over time, we'll get more data.
Any more questions? Yes, Professor Ala.
No, I think it's okay. So I'm going to take the same question about de-escalation and ask Miguel. I remember actually fondly you had a session with Bill Sanborn in Las Vegas at ACG that was exactly that, and you had the de-escalating strategy. And I remember you said 50%, okay, let's look at the full side of the cup. Let's stop in those patients and see. So obviously, I like the checklist that you, Sarah, put at the end. It's really important that you get the past, the present, and the future. But is there a situation that in your practice would make you stop?
Yeah, so it's interesting. Those who are on Twitter, I actually tweeted this out. So the practical reality comes up in patients who are in a deep remission, repeatedly normal scope 0, and the histology is normal, and they're feeling well. the patient's preference obviously sometimes is pushing to stop. That's number one. Number two, in the United States, the insurance companies sometimes switchers lost and the patients lose the ability for their medicine. And the third is in a patient who develops a side effect or an adverse event from the medicine. And then you can put pregnancy in with small molecules. One thing I tell my patients, and this is very much a shared decision discussion, we don't have the cure for inflammatory bowel disease, as much as we'd hope to think. And that makes us think this is a systemic immune-mediated phenomenon that the disease will likely recur. The second part we don't know is who will it recur very slowly and mildly? And I liked your kind of spaghetti graph where it's all over the place in terms of severity. If we knew a patient, deep remission, we could stop, and it was very mild recurrence, and we monitor with calprotectin, maybe yearly colonoscopy, and we detect it early, that'd be okay. Generally, though, I am not recommending stopping in my patients. I agree with what Sarah said. It's about 80% long-term will recur. We don't know the 20% who don't. And the problem is some of the patients who recur more severe. They get this almost cytokine storm of inflammatory disease and often will need surgery. So we have to be a little bit careful. But those scenarios are the ones that could be considered, but generally are not the ones we'd like.
Can I ask a question here? Okay, great. Well, thank you all for this session. It was very, very informative and really enjoyed it. Just to go on treatment de-escalation, I think one area that we're lacking a lot of data is, especially when we use non-anti-TNF biologics, such as Veto and ustekinumab, we know that the dose escalation can be anywhere between 40 to 50% in these populations. And from your experience, and I'm not sure there's any data on this, are there any scenarios where you get to a point where you say, you're on ustekinumab every 4 weeks, I can probably de-escalate you to every 8 weeks? So have you encountered that in your clinical practice? What do you do in these scenarios?
It's a great question, Badr, and I don't think there's much data on this either. The way I approach it is exactly like, that checklist. Really make sure that they're in really deep remission. And again, why am I doing this? And so, for example, someone that's on ustekinumab every 4 and on vedolizumab every 4, you'd have to really see why are we trying to de-escalate. A lot of them cannot make it every 4 weeks to the hospital for their infusions, or it's a big struggle. Sometimes it's insurance that is going to tell us, hey, listen, we've approved your every 4 weeks for 6 months, we're done. And so a lot of the times you're still kind of forced to do it, but I'm still very reluctant, honestly. So once you've actually had to escalate dosing of a biologic in those patients, it's really telling you that they needed it, and they may be at really high risk of relapse. But again, there's not much data on this.
Great, thank you so much. I just have a follow-up question on de-escalation also. The other thing is with small molecules, we've seen this with tofacitinib, is even after a flare, after de-escalation, and if you go, let's say, from TOFA 5 to 10 BID to try to recapture, we only recapture 50 to 60%. So this is kind of a precaution that we should not treat these agents like, oh, you can restart it up. You can always restart, there's no immunogenicity, but I think I just want to put out a word of caution that we actually don't capture that many patients with dose de-escalation of small molecules.
I think Miguel has a comment, but I completely agree with you. Miguel was mentioning this whole cytokine storm. We've done this, right? We've had to at least at sometimes stop therapy, and you do see your patient relapsing and not responding to anything. And I don't think this is just immunogenicity related, obviously, because otherwise we would see that. Agree, Miguel?
So I won't repeat what you said, both of you, I agree. The thing I will tell you, though, and this has come up at this conference a few times, there are now intentional studies on using combination biologics or a biologic with a small molecule, where the strategy is you might be able to induce remission. So use, for example, upadacitinib and vedolizumab. Use them in combination to start. Upadacitinib induces the remission, vedolizumab maintains remission, withdraw upadacitinib, and Badr, I agree with what you said, but the advantage to a small molecule is no immunogenicity, If they relapse, rather than using steroids, we might be able to get away with not using steroids and using upadacitinib or tofacitinib in combination with a biologic. The problem is the regulatory agencies and the labeling make that very difficult, but those studies are underway, and you'll hear more about sequencing de-escalation and combination de-escalation studies in the coming years.
So thank you very much. I'd like to thank our speakers, Professor Sarah, Professor Mariam, Professor Turki, and Professor Bandar. And I call for the next session, session 8. There won't be any break. And we ran over it already. So session 8, please, we can start now. Thank you, Professor Hussein, for good sharing.
Assalamu alaikum wa rahmatullahi wa barakatuh. Break? Okay. Hello everyone. It's our pleasure here to be with you at this event. I would like to thank the organizers for the invitation. I'm here joined by Dr. Al-Khathami. Dr. Al-Khathami is gastroenterology consultant at Security Forces Hospital, Riyadh. Please allow me to introduce our first speaker. Dr. Reguero is the chief of the Digestive Disease Institute at Cleveland Clinic and professor in the Department of Medicine, Cleveland Clinic, Renner College of Medicine of Case Western Reserve University. Dr. Reguero's main clinical and research interest is inflammatory bowel disease with focus on the natural course and medical surgical management of Crohn's disease and ulcerative colitis. He leads research on post-operative prevention of Crohn's disease as well as developing new models of healthcare. Dr. Reguero, the floor is yours.
Thank you. Thank you again. And we're going to switch gears. I'm going to talk about the management of post-operative Crohn's disease. Again, here are my disclosures. I also want to thank my colleagues Stefan Hullabar and Ben Click. We've put together several studies on this, and some of their slides are included. So briefly, we're going to talk about the post-operative course of Crohn's, understand the risk factors, but really then get into the medical options. I will also discuss Reprevio, which is using vedolizumab after surgery, and then give you my algorithm at the end in terms of how I approach Crohn's disease. In fact, my algorithm over the years gets updated with each new information, so the very final slide, or second to last slide, will include the algorithm. So let's think about this for a minute. The question is, patients with Crohn's disease often come to surgery, and then we have to stratify them after surgery to decide, do we put them on a medicine or not? Then the question is, when we put them on a medicine, we're using it to prevent post-operative Crohn's. The question is, how do we monitor them? And then ultimately, who recurs? So let's back up for a minute. In your practices today, you see a number of patients who have Crohn's disease. Look, before 2000, about half of the patients we saw had an intestinal resection for Crohn's. Now, we've gotten better, but we still have a long way to go. At least 1/4 of our patients will have an ileocolonic or an ileo or separately colonic resection. So the rates of surgery in Crohn's disease are still very high, and this leads to the question, what do we do after surgery in a patient who has a resection? You may have seen this before. I put this together over the years, but I think this really gives the story of the natural course of Crohn's. So start for a minute where the red arrow is on the left-hand side. That's a patient that undergoes an ileocecal resection. An ileocecal resection is the most common surgery for our Crohn's patients, and they undergo a primary anastomosis. The majority of patients after surgery will tell you, once they recover from the surgery, I feel great. This is the best I have felt in a long time. When you look from left to right, though, on the slide over time, look at what happens. Within 1 week of surgery, there's histologic recurrence. Now, this was done on diverting ileostomy patients who they took the stool from the stoma, put it down into the ileum, and they saw recurrence. The reason I mention that is after a talk I gave recently, somebody said, do you do a colonoscopy 1 week after surgery? And the answer is definitively no. So even though we see histologic recurrence, we don't scope that early. Look what happens, though, as you go further to the right. It was mentioned yesterday, up to 90% of patients have endoscopic recurrence at 1 year. And it takes time, but over time they develop clinical symptoms, and about half the patients require surgery. If you look at the yellow arrow up top, this is what you see in your practices. Think about how many patients a year to 18 months after surgery, maybe they're on no medicine, and they tell you, I feel wonderful. You do a colonoscopy, you look at their anastomosis, and you see Crohn's disease. It is clinically silent. By the way, I think the post-operative opportunity for research will let us understand Crohn's. So to take a pause for a minute, how many times do you actually see a patient, newly diagnosed Crohn's, forget surgery, newly diagnosed Crohn's, they've had symptoms for 3 months, you do a colonoscopy and you think, oh, this looks terrible. How can you only have 3 months of disease? Well, the clock probably started years ago. Same with post-op Crohn's. They feel well until they start to develop a complication. So Crohn's is often clinically silent, and we need to keep that in mind. So let's consider some of the risk factors. I consolidated this into one table. So risk factors for post-operative Crohn's disease recurrence, meaning what are all of the factors? We actually put this together as part of a study, and we actually have published this data. When you consider risk factors, what are the high risk factors for post-operative recurrence? One is prior surgical resection. Sorry, let me go back. One is prior surgical resection. So patients who see you now and they're on their second, third, or fourth surgery, those are the patients I would put at the highest risk for recurrence. Second, patients with penetrating disease. They have a fistula. They have an intra-abdominal abscess for which they need surgery. The caveat is some patients get a stricture in their ileum. Stricture builds a lot of pressure. It's like a balloon, starts to dilate the small bowel, and then they have an ulcer that penetrates. Strictures with fistula are difficult, but the true penetrating complications, patient comes with an abscess, no stricture, that's a second high risk factor. And then the third is cigarette smoking. Those are probably the top 3 risk factors out of everything I listed here. I was part of the AGA guidelines. You talked about guidelines yesterday, and these are guidelines that we put together for postoperative Crohn's. It's about 6 years old, but I think that this still holds true today. We actually put together an illustrative, and this really is the summary of my entire talk right here. We put together a summary on low risk versus high risk patients. So low risk, not smokers, short disease. They may have had disease for a long time, but finally come to a short resection. We actually say for those patients, maybe they don't need treatment. You heard a minute ago about de-escalating therapy. Some of the deepest remission we induce is actually a surgical resection. I joke again, colorectomab is sometimes our best biologic. We take out the disease. The high-risk patients, though, are those under 30, smokers, more than 2 surgeries, and you could add penetrating disease. So simply put, that's how I approach post-op Crohn's. So the question is, who do we wait and watch, and who do we start treatment right after surgery? And that's really the kind of question that we're always faced with. And I don't know that we have the perfect answer. I'll acknowledge that up front. You might be familiar with the POKER study, and this has been presented at several meetings, but this is the wait and watch approach. And just for if you haven't seen this, this was one of the pivotal post-op Crohn's studies. The simple part of the study, the primary outcome was have surgery and 18 months later do a colonoscopy to see if there's active Crohn's. That's it. That's the primary outcome. The randomization scheme is one group of patients had a colonoscopy at 6 months and 18 months, so they had an early look at 6 months. The other group did not have a colonoscopy at 6 months. They just had the colonoscopy at 18 months. So early look at 6 months versus waiting to 18 months. Now, the patients all received metronidazole. I will tell you up front that may work, but many patients do not tolerate it, and I don't do that normally now in my practice. But in this study, the low-risk patients had no treatment. The high-risk patients were on thiopurines, and if they didn't tolerate that, they were on adalimumab. So there was some treatment in this, but the real point of the study was, does doing a 6-month colonoscopy after surgery make a difference? And what they found here was simply yes. So the red bars are recurrence, the blue bars are remission, and the left-hand side is actually active care, meaning you do a 6-month colonoscopy. The right-hand set of bars are you just do an 18-month colonoscopy. And what that means is by doing an early colonoscopy, statistically speaking, you can lower the recurrence rate. It kind of makes sense. 6 months after scope, you look, patient feels well, and you say, whoa, there's a lot of Crohn's here. Let's start them on a medicine or do treatment. You know, that makes sense that we lower it. The only thing that's interesting is about 50% of the patients that they looked at 6 months still had recurrence at 18 months, and that's not very good. When you dive into the study, and I didn't, for purposes of time, include this slide, but probably because thiopurine is the primary treatment after Crohn's surgery did not work. Adalimumab patients only had a 20% recurrence. Remember 20%. 20% recurrence is the best we see with all of our post-op anti-TNF and vedolizumab meds, which is actually better than we've seen with others. Then the question is, what about starting treatment? This is one slide that includes all the data on post-op Crohn's prevention. You can see the table from some of the natural approaches, vitamin D, curcumin, mesalamine. You can look down the list. Anti-TNF has the best data, and the very bottom on the left-hand side, I've included vedolizumab, and I'll get to that study in just a minute. Metronidazole has been looked at. The problem with metronidazole is to prevent recurrence. To prevent recurrence means you need to stay on metronidazole. Once you stop the metronidazole, the recurrence comes back. So yeah, there's probably a microbiome element, and maybe diet could play a very good role for some patients. And then infliximab's been the best study. So this is the studies that I was involved with several years ago. This was the first study that we presented in Crohn's. You may have seen this before. For the young faculty and fellows out there, yes, you can do small studies and make a difference. This was only 24 patients. 24 patients randomized to placebo or infliximab for 1 year. At the end of 1 year, we did a colonoscopy, and these are the endoscopic recurrence results. Endoscopic recurrence, red is placebo, yellow is infliximab, and obviously we saw a big difference. Now, these were very sick patients, so this took the highest risk, multiple surgeries, smokers, penetrating disease, probably why we saw that risk. That study then led to several international open label studies. The blue column is anti-TNF. Sorry, the middle column's anti-TNF. The blue is infliximab. The white at the bottom is adalimumab. And what you can see here, even though these are open label, you see about 10 to 20% recurrence with the anti-TNFs, which is, again, the take-home message. It's about 20%. The control on the right side was a variety of other treatments or no treatment, and those were higher. This then led to the PREVENT study, which I was involved with, an international study that really took the proof of concept and did a placebo-controlled study. I think you're probably familiar with this study, but simply put, patients had a surgery. 18 months later, they had a colonoscopy. They were randomized to either placebo, this was still a placebo-controlled study, or infliximab. Now, clinical recurrence was the primary endpoint. You might all say, Ruggero, you're stupid, you're an idiot. Why did you pick clinical recurrence? You just told us that clinical recurrence is very low. You're not going to see a difference. Well, it's because when we presented the study, at the time it was Senecor, then Johnson wanted an FDA indication for post-op Crohn's. So I had to go before the FDA and argue that endoscopy should be the primary endpoint. The FDA said, nope, we want clinical symptoms to be the primary endpoint. I turned back to Johnson & Johnson, Janssen now, and said, you're going to have a failed study. Primary endpoint we're not going to meet. We might meet the secondary endpoint of endoscopy. And that's essentially what happened. So this is the primary endpoint. Just look at the left side. Blue is placebo, gray is infliximab. This is looking at clinical recurrence at week 76. On the right-hand side is week 104. Couple things. Look at the p-value. Everybody always, when we present these, you always look at the p-value and say, oh, it's less than 0.05. That's just natural. P-value was not met, 0.097. Now, one other thing that's interesting, though, is look at the recurrence rate in placebo. It's very low, which again speaks to the fact that if you do a resection on a patient with active Crohn's and do nothing else, they feel well for a long time. Now I think the FDA is realizing probably clinical recurrence is not the best endpoint, but so this wasn't met. That's why it's not in the label. The secondary endpoint was met. Again, blue is placebo, gray is infliximab. This is endoscopic recurrence, which I think all of us now agree is probably the better recurrence. Take-home message, look at the gray bar on the left-hand side, 22%. So when I see a patient, high risk, starting anti-TNF, I tell them it's not zero. You're not going to be cured on infliximab or adalimumab. It's about 20% of you will have a recurrence. Usually it's mild, but we do see about a 20% recurrence. So what about other post-op? So this is hot off the press. I don't know if you've seen these data. This was presented at ECHO and then at DDW, and you'll hear this again at some of the European meetings coming up. What about vedolizumab for post-op Crohn's? So this is the Reprevio study, Now this is a little bit different than PREVENT, and I won't go through all the differences, but one of the primary differences, this is looking at a 6-month colonoscopy. The bars here, vedolizumab is purple, placebo is gray, and they looked at a couple things, low risk and high risk on the left-hand side, endoscopic remission, which is an I0 or I1 on the right-hand side. And what you can see is that there are higher rates of remission and less high-risk disease in the vedolizumab studies. So you might sit there and say, okay, well, what should I use? Which is better? We don't know. There are not head-to-head studies, but I'm going to commit an academic sin. I'm going to do something that we always say we shouldn't do, and then we do it. I'm going to actually show you Reprevio and Prevent side by side. Now, these are not head-to-head infliximab and vedolizumab studies. So on the left-hand side is Prevent, on the right-hand side is Reprevio. Infliximab on left, vedolizumab on right. Clinical recurrence, clinical recurrence. The message is, do surgery, do nothing after surgery. Most people feel great. And the clinical recurrence rate, interestingly, in both studies, is around 20%. So actually, if you ever take a test on post-op Crohn's, just say 20%. Clinical recurrence is 20%. Endoscopic recurrence with infliximab is about 20%. And I'm going to show you it's about 20% with vedolizumab. But clinical recurrence was low. And even in Reprevio, on the right-hand side, no difference in clinical symptoms between placebo and Entyvio. What about endoscopic recurrence? To keep it easy, the red outlined areas are really what you should look at. So the left-hand side is looking at infliximab, endoscopic recurrence, 22%. The right-hand side is looking at vedolizumab. Now, infliximab was looked at 18 months. Vedolizumab is looked at 6 months. And if I was asked to critique the study and kind of poke holes in it, one question is, that's at 6 months. Is that 23% recurrence in the Entyvio group going to be higher over time? And we need to wait and see, but at least the data look very similar. The other part, you don't have to look at all the data, just look at the title. It might be more about when we start the treatment after surgery than which treatment. So what you're seeing, infliximab, vedolizumab, my suspicion is ustekinumab, risankizumab, JAK inhibitors started within 4 weeks of surgery probably are all going to have a prevention of recurrent Crohn's disease, and it's probably all going to be around 20%. Now, I'm using the crystal ball. I don't have any of that data, but that would be my bet. Charles Bernstein and I put this together. I only have a couple more slides. This is on how we monitor after Crohn's. We came up with a simple unfortunately, the reference at the bottom got cut off, but this was a study we just published recently. So patients who have surgery, we obviously follow their symptoms. You had a wonderful course and discussion on ultrasound. This is where I think intestinal ultrasound really may play a role. For those that don't do ultrasound, I do a fecal calprotectin at 3 months. Remember this, the number 150. If it's less than 150 at 3 months, I leave them alone. If it's over 150 at 3 months, I'm starting to think about doing a colonoscopy, certainly earlier than a year. We do a colonoscopy at 6 to 12 months. If a patient is on treatment after surgery, low fecal calprotectin, and they feel great, I don't think we need to scope them at 6 months. I think we can wait a year, and I often now will wait 1 year. So I think the future state is we talk about precision medicine and epigenetics and epiphenomenon. I do think diet and microbiome play a huge role, and I think this is probably an area that deserves further exploration. The problem is we just don't know exactly what that is, and maybe combination therapy will be some microbiome changing agent with some gut modifying agent that we don't yet know. So this is kind of the future state. And then finally, this is my algorithm. So this is how I approach it. You may have seen this over the years, but each time something new comes out, I update it. So for the low risk for recurrence patients, these are the patients who've had Crohn's for years. They've done relatively well, and they've finally come to surgery for a stricture, maybe 10, 15 centimeter stricture in the ileum, ileocecal resection, primary anastomosis, uncomplicated, they do well. I think these are patients we can wait. I don't know that we need to put them on medicines. The Mount Sinai group presented at DDW. Interesting data. It was just published in Gastro, I think, last week, showing that there are probably some patients who do very well long-term. You heard about the LYRIC study that was presented, which is using surgery as a first-line agent. And maybe there are these patients that do well. The problem is we don't know exactly who they are, but I think as long as we monitor them, fecal calprotectin at 3 months, off of medicines, doing well, low fecal calprotectin, colonoscopy with a 0 or a 1 score, I think we're okay. High-risk patients, I still think these are the majority of what we see. These are patients with multiple surgeries, penetrating disease. You can kind of see that at the very bottom. But this is how I approach it. If they've never been on a therapy at all, they come and they really are one of these Crohn's patients that presents very acutely, they're sick, they need surgery early, I still am using a TNF inhibitor. I think we can get away with monotherapy. Maybe this is one of those times we're doing proactive monitoring. Remember, usually we use medicines when there's inflammation and we worry they're not getting a good level. These are patients who usually don't have any inflammation. We're using them prophylactically. They have very high levels of TNF and maybe don't need the azathioprine or 6-MP. And I mentioned this, I do a calprotectin on all of my patients at 3 months. If you have intestinal ultrasound, I think this is a really good tool to look. And then if they're doing well, low calprotectin, we do a colonoscopy at usually a year. And then depending on what happens, if they have recurrence or not, we adjust therapy. In the middle, I also put vedolizumab. Vedolizumab is not a wrong choice, and I cannot argue that if you use Vedo now post-op as your primary prevention, I think that's fine. I'd like to see the longer-term data. The numbers were smaller in the group. It's not a criticism. I think the study's great. I just don't know that we have enough information for me to comfortably say that's the answer. But if you're going to do anything, start it within 4 weeks of surgery. Prophylaxis is within 4 weeks of surgery. But then interleukins, antibiotics, and diet are the other questions. So in summary, these are really just my kind of take-home points. I've said all of this already. Recurrence is common. Risk factors we went through. Smokers should stop smoking. We now have 2 studies, TNF inhibitor and vedolizumab. Both, I think, are reasonable. I tend to use TNF more. If they've been on a TNF, this is one exception to what I said yesterday. If they've been on a TNF, they have surgery, and they have surgery, they'll wipe the slate clean from Crohn's. This is one time where I am using Vedo after TNF. That's different than an active Crohn's patient failing TNF, then going on Vedo. Small bowel ultrasound, fecal calprotectin for monitoring, and then I put some questions at the end that we still need answers to. So with that, I really appreciate your attention. Thanks again for having me, and I look forward to discussion later.
Thank you, Dr. Reguero, for excellent presentation. It's my pleasure to invite the next speaker, Dr. Ibtisam Al-Mghaysib. Dr. Ibtisam is a consultant gastroenterologist, IBD specialist, and head of gastroenterology division at Bin Sultan Military Medical City. She completed her advanced fellowship in IBD and EUS at McMaster University. She is going to talk about microbiome, diet, and IBD. Dr. Ibtisam, floor is yours.
Assalamu alaikum. I would like to thank the organizing committee to invite me again for this amazing event, IBD Masterclass. We are learning and trying to give some information from our experience. And I have the pleasure and wonderful job to talk about food right before lunch. So keep your appetite. So today my task is to talk about microbiome, diet, and IBD. It's not moving, sorry. Can I? Yes, yeah. No, it's okay, it's moving now. But how can I go back? Sorry. Okay, before we talk about diet and IBD, let's think about some question. Like who gets IBD and why? And part of this, we can answer it about changing the environmental landscape. What dietary component may be causative of IBD? High fat, emulsifier, ultra-processed food, sugar, fiber, yeast, herbicide. What dietary strategy to prevent IBD in patient at risk? diet as a treatment for IBD, and this is will be the scope of our talk, to induce remission, to prevent disease flare, and what can we practically do today, advice, challenges, opportunities, and adherence. So we know that urbanization and westernization, and especially Western food, are driving the incidence of these devastating IBD disease through the roof. We know environment, genes, and microbiome all are important. But if it's purely genetic, like cystic fibrosis, the incidence will be stable over the years, like what's happening with cystic fibrosis. But this IBD incidence is different. It's mostly environmental, and by environmental, there's a lot of factors. Like we know that using antibiotic during early childhood can increase the risk. And we know now from the studies that taking antibiotic early in the childhood, from the pediatric studies, can increase the risk. And even they compare to the risk of smoking in lung cancer. But still, diet has a role. And by diet, we know that Western diet changed the incidence in many countries that before they don't know even what's IBD, and also increased the incidence over the past decades, in the past 2 to 3 decades. And for Crohn's, even the past 5 decades, it's increasing. We know that increasing sugar, fat, animal protein increase the risk of IBD. But we are lucky if we think that the diet is only sugar, protein, and fat. No, diet can have also a lot of complex things like additive, emulsifier. And we know now additive like carrigan and sucralose might be a role for IBD. And also emulsifier, that is additive also, it's a sugar. It's a starch that is used to add enzymatic effect on diet, also can increase the risk of IBD. So in IBD, the homeostasis between microbiome, intestinal barrier, and immune system is disrupted, resulting in what's called dysbiosis. And this dysbiosis can increase the barrier permeability, or what we call intestinal leak, and inflammation. The impact of diet on all 3 components of IBD paradigm can intestinal microbiome, mucosal integrity, and immune system. So the diet in IBD, it can be the cause and it can be also the treatment. And it should be state-of-art treatment for IBD. So what do we mean when we say Western diet? When we say Western diet, we mean the diet that's high in animal protein, low fiber diet, high fat content, polyunsaturated fat, omega-6, and high sugar. But the healthy diet is rich in vegetable, fruits, polyunsaturated fat, omega-3, and vitamin D. So by increasing the Western diet, we change the microbiota. And microbiome is a very important organ. It's not only a bacteria, it's an organ, now recognized an organ in the GI tract. And microbiome is a commensal of bacteria that is present in our GI tract. And the count is more than 100 trillion. And it can weigh up to 2 pounds of our weight. So it's not, you cannot ignore that microbiome has a very critical role in pathogenesis of IBD. So microbiome, which is the commensal of the bacteria, is making the intestinal health stability with our health. But when this microbiome change for any reason like diet or genetic susceptibility or other factor like antibiotic, this microbiome become more pathogenic than helpful to our GI system. And when this happens, it will make what you can see in the second part of the picture, holes in the intestine, which we call intestinal permeability. So the pathogen can pass from the bowel to our system. So basically, what Western diets, we said high sugar, low protein, less vegetable, plus the additive, the emulsifier, food colorant, carbohydrate. All this will cause what's called dysbiosis, with the disruption of intestinal health. And by dysbiosis, we have more pathogenic bacteria, like E. coli, that can affect our intestinal health. And these pathogenesis can also release more and more inflammatory danger response in our system, like interleukin 6, interleukin 8, and interleukin 1b. So diet and gut inflammation, the diet and host immune response determine the gut microbial composition and function. So excessive intake of specific micronutrient enriched in Western diet promote experimental gut inflammation by disturbance of the host microbiome commensalism, and which result in dysbiosis. So there are certain anti-inflammatory diet principles, but before I go in that, I have to mention that there's difficulty in doing research in diet in general and in IBD specific. Why? Because first, these studies usually it's difficult to find sponsor for these studies, because most of the drug company, they will sponsor drug related research rather than diet research. And these are very expensive researches. Number two, it's difficult to keep track of what you eat. And it's difficult to ask compliance of the patient about keeping track and very strict compliance with the diet. Number three is also the patient, they can eliminate some of the food, but they cannot eliminate additive or emulsifier or other things. So that's why it's very difficult to have a diet-related, very good quality studies. So in general, there's most of the diet study you will see, they will tell you to avoid gluten, dairy product, limits insoluble fiber. I will go about these in details later. And there are certain also micronutrients that can result in pathogenesis of ulcerative colitis. Also, I will go about this later. But to save the time, I will go into specific diet. So before we talk about certain diet for each patient, we have to talk to our patient. What is the goal of this diet? Who is the right patient? What are the primary therapy? What sort of diet we will look for before we decide which diet we will choose for our patient? And we have to keep in our mind, in our IBD patient, most of them, they have malnutrition to start with. So because of poor digestion, malabsorption of the nutrient, loss of appetite, increased caloric need of the body during the active stage of the disease. So not only that, they have 1 in 3 of IBD patients, they have anemia, either iron deficiency anemia, vitamin B12 deficiency anemia, pernicious anemia, folate deficiency, anemia of a chronic disease. So what about the diet and management of active IBD? So one of the most well-known and established nutritional therapy is the EAN, which is exclusive enteral nutrition. It started to be used in the 30s. First, it was used in before the certain exclusion diet. First, it was used for celiac disease. Then they thought about it in the 70s for pediatric patient. It is alternative to steroid in inducing remission. Basically, it's exclusion of all other food type for 6 to 8 weeks, but variation in practice Like in pediatric, sometimes they use it for 8 to 12 weeks. In adult, we can use it to 6 to 8 weeks, but it's mostly used in pediatric patient. It's nutritionally complete. It's formula delivered orally or via feeding tube. So the patient can take it orally or through feeding tube. First-line treatment in pediatric, and it's suitable for adults who are willing to follow this diet. So EEN, it is over 200 publications on EEN and multiple meta-analysis that use EEN in children and for Crohn's disease patient. And adult Crohn's disease EEN have conflicting result other than pediatric. In pediatric, we know it's equal to steroid with additive effect that it can induce mucosal remission. But in adult, it has conflicting result, and in 2018, Cochrane database systematic review comparing EN versus steroid showed greater efficacy of steroid in adult. And it's unclear whether because the efficacy in pediatric and adult different because of compliance, because of greater duration of the disease, or prior exposure to immunosuppressive agent. EN also, studies in children and adolescents have demonstrated ability to induce remission in active Crohn's disease in 80 to 85%. It's equivalent to steroid, as we mentioned, with another effect over steroid that it can induce mucosal remission. Exact mechanism of EN we don't know about, what is the mechanism, but the hypothesized mechanism include limiting antigen exposure and antigenic monotony, enhancing nutritional status and nutrient delivery, which can alter the microbiome and immune response. So why someone with IBD or ostomy, this is extra information, need feeding tube for malnourishment, for combat weight loss, to provide nutrition before after surgery, bowel obstruction or severe inflammation. What are the limitations of EN? Effective in Crohn's disease into remission. So only it can induce remission, but what's next? What's after remission? It's difficult to sustain long-term maintenance therapy, not effective for UC. What about low fiber or low residue diet? This diet help to reduce the amount of roughage or residue in the stool by basically restriction the raw fruit and vegetable and their skin, restriction of the seeds, nuts, sweet corn, restrict high fiber carbohydrate like brown whole meat. These diets are used to significantly reduce the diarrhea, high output stoma and stricture. And by basically following a low residue diet, we limit the fiber to 10 to 15 grams per day and limit the serving of dairy to 2 servings per day and 2 servings of protein. So what other novel treatment? I will touch briefly on each one. Crohn's disease exclusion diet, Mediterranean diet, specific, which we call specific carbohydrate diet, SCD, CD treat, and autoimmune protocol diet. Exclusion diet, it's also recently published Cochrane review, analyzed 18 randomized control trial, comprising 1,878 participants, published between 1965 and 2018. Intervention diet following a complete exclusion or significant limitation of certain food. Just basically, there are 2 different diets, depends on where it came from. And each diet has certain limitation, but all of it, mostly they exclude carbohydrate or carbohydrate related. But in some exclusion diet, you will find also they canceled additive, like carcinogen-free diet and Alberta-based anti-inflammatory diet. And the outcome of these studies looked into outcome values, like induction for remission, clinical relapse, surrogate biomarkers of inflammation. So there's no firm conclusion from these studies. So EN versus exclusion diet, and this goes in details the difference between them. And as I mentioned, EN, everything excluded except the formula and exclusion diet, each diet has certain nutrient to be excluded. Let's go about Mediterranean diet, which is the trend now in IBD. The Mediterranean diet, as we know, like it's come from Mediterranean countries like Lebanon, Greece, Egypt. This diet basically has these people from the countries, they used high amount of daily serving of whole grain, fruit, vegetable, olive oil in high amount, and less amount of protein from like meat or eggs or cheese or poultry or yogurt. So this is the basic of the Mediterranean diet. So if you want to go strictly about how many like daily serving or weekly serving, daily serving as it's mentioned here, fruit, vegetable, bread, olive oil, large amount of olive oil, fish, seafood, eggs, cheese, it should be less amount, and the least for meats and sweet. And the effectiveness of Mediterranean diet in children adhere with IBD was significant in this study, and it was published in Nutrient 2020, and it was found that it improved the symptoms, improved the disease severity, and also improved the decrease the disease flare. And basically, it's not called the Mediterranean diet here, but it's the same principle. The low-fat, high-fiber diet reduce the marker inflammation, dysbiosis, and improve quality of life in patient NUC. That was published in the Clinical and Gastrohepatology 2021. So what are the pros and the cons of Mediterranean diet? The pros that it's not restrictive, the cost is cheap, and flavorable, enjoyable. Patient, he doesn't need to be isolated. He can join the family, join the friends, eat anywhere. All the restaurant can give this Mediterranean diet. And it might, as we mentioned, improve the patient symptoms. No need to social isolate. But the cons, sometimes it's expensive, sometimes not accessible everywhere, and certain food items may be more costly. What about, I will touch just briefly on the topics here. SCD, which is specific carbohydrate diet, and this diet remove all grain sweetener except for honey, processed food, all milk product except for hard cheese, yogurt fermented longer than 24 hours. And both clinical and laboratory improvement have been reported in pediatric and adult patients on SCD diet. And one study over 12 weeks in children and adolescents used capsule endoscopy demonstrated mucosal healing on these patients using this diet. And it was also shown to improve the microbial composition on patients using this diet. So the difference, as we mentioned, the Mediterranean diet high in olive oil, fruit, vegetable, nuts, cereal, but in SCD, high unprocessed meats, mostly it's organic like food. Unprocessed meat, poultry, fish, shellfish, eggs, most vegetable, fruits, nut, but avoid grain, which is it is used in high amount in Mediterranean diet, and homemade cheese and homemade yogurt. What are the pros and the cons? It might improve the health system, decrease the inflammation, might reduce the need for medication, assist with weight gain also, but it's restricted for special nutrient. Food not always easily accessible, expensive, and it has social impact because it's not always accessible to find unprocessed meat and homemade yogurt. This is very difficult and need time to prepare. What about FODMAP? FODMAP is fermentable, low and fermentable oligosaccharide, disaccharide, monosaccharide. How many minutes we have?
1 minute more.
Okay. So basically this diet, I'm sure you are aware of, it's used in IBS symptoms, but it might also improve the symptoms in IBD-like, IBS-like symptoms when patient with IBD. Just also to touch quickly on dying to introduce remission in Crohn's disease, it's dying 3D study. It's also Mediterranean-style diet versus comparing Mediterranean-style diet versus specific carbohydrate. And they found that over 6 weeks, the outcome was always almost comparable, as you see here, after 6 weeks. Just also a few words about the recent recommendation from International Organization for Study of Inflammatory Bowel Disease and the European Society for Clinical Nutrition and Metabolism. They recommend recently that diet rich in fruit and vegetable, rich in omega-3, low in omega-6 fatty acid associated with decreased risk of developing IBD. And ultra-processed food dietary emulsifier such as carboxymethylcellulose can be associated with increased risk of IBD, and it's better to be excluded. Also, we don't have time for FMT, but just to conclude with 2 or 3 slides. Avoid during a flare. Usually I tell my patient to avoid trigger food that can cause symptoms. High fiber food like beans, nuts, seeds, and popcorn, high-fat food, caffeine and alcohol, spicy food, raw fruit, and vegetable prawns. Adhere, food is essential for life. Environment also, it's important to consider always in the disease and the disease incidence, risk, disease flare. Processed food as highly addictive. Diet are hard to maintain and see decades of weight loss trial and industry. Just in summary, diet is not the cause of IBD, but it can contribute to etiology. It can drive inflammation. And dietary therapy for IBD combined with medical and microbial therapy, prevention strategy based around the diet, preventing disease flare and disease onset. Compliance and dietary therapy is a major personal and societal changes. Take-home message, IBS-like symptoms are common in quiescent IBD, but can be improved by low FODMAP. And also EEN can be used in Crohn's disease to support mucosal healing. We have to use it more in our adult treatment practice and induce remission. Novel whole food-based diet are being investigated that induce and maintain disease remission. And dietitian involvement can improve adherence to dietary. But also I have to mention here that patients sometimes they have a lot of conflicting dietary advices from dietitian, from media, from doctors. So we have to minimize the messages and the advices for the patient, and we have to tell him to take simple messages, don't complicate things, don't leave the medicine, take the medicine, but you can try other diet therapy while you are on treatment. Thank you very much.
Thank you, Dr. Ibtisam, for healthy and scientific diet before the lunch break. We can take 2 questions before we conclude. Yes, Dr. Nahla. Yes, Dr. Nahla.
Yes, hi. So I have 2 questions for Miguel. The first one is, how do you approach anastomotic lesions, so I2A lesions? The data is quite controversial. Some data tells us that they do okay. Some data tells us that they're at high risk of recurrence. How do you approach I2A in your clinic? And the second question is regarding patients with an endoleostomy. How do you detect recurrence in those patients? Sometimes they can have stricturing at the stoma or a bit of ulceration the first 2-3 centimeters. So 2 questions.
Yeah, so I'll start with the second one first. So the ileostomies, technically patients who have Crohn's colitis and they get a colectomy with a permanent ileostomy, that's the closest to cured we have. However, and there might be surgeons in the room that can comment, sometimes the fascia is tight around the stoma, and then it almost acts like a pouch where the patient starts to get inflammation and they'll get a stricture. For those, sometimes what happens is the patient needs a revision of that area, a pull out of a new stoma. That's different than Crohn's recurring, where usually it's separate from just the fascia, it's more upstream. So for the strictures right at the ostomy site, unfortunately most of them just need re-resection, new ostomy. For extensive Crohn's, then I would treat it like anybody else with Crohn's. Your question about the anastomosis, and I think probably everybody in the room is familiar, but the Rutgert score is 0 through 4, and the question always becomes, what do we do with the anastomotic ring of ulcers that occur? It had historically been thought those were ischemic from blood supply changes. Probably it's not. It probably really is Crohn's right at the anastomosis, and you see this ring. I2A is just little ulcers at the anastomosis less than 5. I2B at the anastomosis extending into the small bowel. So your question about I2A, what do you do? I've joked about this. There's I2 little a and there's I2 big A. I2 big A are these big ulcers at the anastomosis. I worry about that, and I would treat them almost like I3. I2 little a, meaning you see a few little ulcers there, they're not too bad. Generally, I leave them alone, but if whatever therapy they're on or if they're not on therapy, I'll continue doing fecal calprotectin and I will rescope them at a year. I don't let them go longer than a year without another scope to make sure.
Makes sense, thank you.
And the only final thing I'll say is sometimes they stricture. The strictures at the anastomosis respond exceedingly well to balloon dilation. That's one time where I think endoscopic dilation works.
Dr. Mahmoud?
Yes, thank you. So thank you both for these wonderful talks. I have more of a comment that is ending with a
Actually, can you speak up a little bit? The microphone's not.
Should be working. Hello? Is it working? No? Thank you for the two wonderful talks. I have a comment ending with a question for Miguel. So I think we can agree that the low-risk patients with Crohn's disease and those who go electively for ileocecal resection, mainly for a stricture, it's quite easier to deal with. But for high-risk patients, especially when they've had a long or prolonged duration of delay in diagnosis, they go on to start on biologics, second, third, and then all of a sudden you deem them refractory and you just have to take them to the OR for a resection. Now, post-op, when you want to restart biologics, you struggle with your choice because they've been on multiples, and some of them, you really don't know what happened with the initial anti-TNF. Was it a primary non-responder or a secondary? So how do you mitigate that? That's number one. And number two, we didn't hear about ustekinumab or the IL-12/23. I know there's not much evidence, but we still need to make up our minds because some of them are on ustekinumab when they go for surgery, and then you don't know what to do with it post-op. Do you continue? Do you go back to another biologic? And the final thing is some of them are on escalated dosing. So do you regress back and start with the conventional dosing, or you do, restart the escalated dose post-op? Thank you.
So I'll answer it in reverse order, and hopefully I remember all the questions, but those are excellent. So the first is you have a patient who's on every 4 weeks ustekinumab, every 4 weeks vedolizumab, or escalated doses of infliximab. They go to surgery, and now the question is, can you de-escalate their dose? Usually I keep them on the same escalated dose at least for the first 6 months to a year. If their fecal calprotectin is less than 50, their first colonoscopy after surgery is truly 0, probably those are patients you can de-escalate. If it's a TNF, I'll sometimes monitor their drug levels, and their drug levels shoot way up because they no longer have disease. And then that would be an appealing time. Maybe it's 6 months if you have an ultrasound and fecal calpro to de-escalate. The question about ustekinumab, I'm going to answer it 2 ways. There was a post-op prevention study comparing ustekinumab with azathioprine retrospectively, not prospectively, retrospectively. And it did show ustekinumab performed better than azathioprine, which gets back to probably any of the biologics are going to work for prevention. And then I'm going to bundle your second question with your first question. The question comes up What happens in a patient? You start on a biologic, then they come to surgery. What do you do with that biologic, whether it's ustekinumab or another therapy? I have the 6-month rule, the 6-month rule. If you've started a biologic within 6 months of the surgery, they probably needed surgery 6 months ago, and we try to use the biologic to prevent surgery, but they really need surgery. And all of us know that. We see these patients, they say, please give me one more shot before surgery. You know it's not gonna work. I continue that biologic post-op. I don't consider that a failure. If it's more than 6 months over time and you can see them progressively failing, if it's a TNF optimal dosing, then that is a time I will switch them to something else. Much more common, it's within 6 months you can continue. There are multiple studies that I took out for time looking, the Japanese and others have looked at continuing, but that's the bottom line.
Thank you.
Dr. Nahla.
Thank you for both speakers for Ibtisam probiotic rule in addition to the diet. Era of probiotic is growing.
Probiotics, the problem with probiotics, we don't know how much we should use, what is the right organism to use, because you know probiotics has different combination. It's not the same, and the number in each probiotics has different number. The mostly used is lactobacillus or VSL3 for decreased recurrence in UC. But the role of probiotics in Crohn's, for example, is very controversial, very weak studies, and weakly, the studies was also analyzed and investigated in a weak way. I know it's mostly media driven now, and even my IBS patient now, they are talking probiotics. I don't know what's the effect in the future. I don't know what's the effect will be in the coming few years, whether it will increase risk of something or decrease risk. But even my patient, I have one patient who's IBS, she's taking probiotics for her asthma, not only even by IBS. So it's bigger now, it's getting bigger and bigger. It's mostly commercial, I can say. And also I would like to hear your comment as well, and the expert comment here, because this is a daily question in my clinic, and always I tell them, I don't know what to recommend for you, which company, what's the dose. I don't know whether I'm giving you the right. The only probiotics rule in IBD I can say that when it is used in UC after recurrent, either a patient who has CDF like many times and they have relapsed, the rule for probiotics here, they have some significant effect, or patient after subtotal colectomy for decreased risk of pouchitis. This is the only time I consider using VSL3. Other than that, I don't have recommendation because I don't have good evidence.
Dr. Bawardi, then Dr. The last two questions.
So I've got one question actually it's a long-winded question for Miguel. So we're still using the Rutgers score for defining post-op recurrence, and we know there's limitations with the score. It's interesting that it hasn't been even fully validated, and it doesn't take into account colonic disease. And there's some recent data to show that any recurrence or any erosions even in an I1 can predict further recurrence of Crohn's disease. And obviously we're not starting therapy for I1, but what's your practice in monitoring patients who are I0 versus I1? And do you think it's time we move to a different endoscopic score, potentially like an SCSCD, which has been shown maybe to have better predictive value for post-op recurrence?
Yeah, so the first editorial comment I'll make is, why is the Mayo score for ulcerative colitis and why is the Rutgers score for Crohn's so used? It's easy. I mean, we all like easy, and if you have something too complicated, people don't use it. With that in mind, and I think the modified Rutgers with the anastomotic changes has been better. With that in mind, to answer your question, if it's an I1 or an I2 little a, I do the same thing. I'll monitor their fecal calprotectin, and I will repeat a scope in 1 year. I don't necessarily escalate therapy the first time. And if in a year they have the same thing, I leave them alone. Think about how many mild asymptomatic ileitis patients you have. Al-Sharara mentioned you pop in the ileum, you see it. There's probably a lot of very asymptomatic mild Crohn's walking around that does fine. Monitoring is the key. I don't think it's as much the score, it's how we monitor. You're right, and I'm part of an endoscopic guidelines where actually, when I was here, one of the questions was how do we look at post-op? My sense is we'll keep it because it's simple, but we need to monitor.
Oh, the last question, please. Yeah, go ahead.
Yeah, thank you for the question. I can still say that it's not simply underdiagnosed. Yes, before we used to have from the data more of intestinal tuberculosis rather than purely IBD. And even in, you can say, in Asia and India, they had before more of intestinal tuberculosis, mostly affecting the small bowel. But now, no, we have more of IBD. We have IBD in families that they don't have any, generations before that they have any intestinal disease. And not only that, they come from relative marriage, so they are not, they don't have different gene. It's the same genes that runs in the families, but they have different environment now. And I cannot say it's purely or the cause is diet. As I mentioned, can be environment, can be exposure to antibiotic early in childhood, can be hygiene hypothesis, like it's mentioned, a lot of theories. But diet and urbanization, modernization, westernization of the diet, it has important role. But as I mentioned, the disease study in diet and diet as a risk factor, excluding all other factors, difficult to do. But definitely the role of IBD and diet is clear.
Yeah, I think it's pretty obvious. So at the Riyadh airport, I got off the plane and now there are 4 McDonald's and 2 Burger Kings. I think diet's playing a huge role. And my sense, unfortunately, is the rates of obesity are probably going to go up. I mean, the United States, obesity is an epidemic, and we're seeing more pro-inflammatory diseases. So you're right, it's not only diet, but I think that's a large part.
And we see also from the US study and North American, the migrant who came from countries with low risk of IBD, the generation that is raised in US or in new countries or Western country, they have more and higher risk than their older generation.
Thank you very much. I think we have to conclude here. So thank you all for your attention. So you will have break for 45 minutes and we'll be back here at 1:15, okay?
Excuse me. Last question, please.
The floor is open until 1:15. I didn't, but okay.
Last question, please. My question for Prof. Miguel. Do you think those patients that develop I1 at 6 months, the same risk and treatment those patients that develop I1 at 2 to 3 years?
No, I mean, the simple answer is I don't know. The real answer is if the I1 at 6 months remains the I1 at 3 years, I think that's a mild case of Crohn's and probably don't need to do anything. The problem I don't have the answer is what is the trajectory of I1 at 6 months? We don't know. That's why I monitor and follow. The I1 at 3 years, that's a long enough time. That patient might stay that way, and maybe if they're okay, we can leave them alone and relax our monitoring. So I think they're different. It's a good question.
Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everyone. I hope everyone has enjoyed a good meal of lunch, and I think you're ready now. Everyone is full, hopefully, from GI point of view, and hopefully Dr. Al-Bawardi will try to give us as well an additional meal from IBD point of view. So Dr. Al-Bawardi doesn't need an introduction. He's a colleague. I'm biased to introduce him. He's joined us in King Faisal Specialist Hospital recently, and he's been a great addition. Dr. Badr Al-Bawardi is a consultant gastroenterologist in King Faisal Specialist Hospital. He graduated from the George Washington University School of Medicine in 2016. He completed his fellowship in gastroenterology and hepatology 2017, inflammatory bowel disease in 2018, Mayo Clinic, Rochester, the US. He practiced as gastroenterologist, IBD specialist in Yale affiliated hospital. And as well, he was a program director for a fellowship in GI and advanced inflammatory bowel disease fellowship director as well, before moving to Saudi Arabia and joining King Faisal Specialist Hospital. Dr. Al-Bawardi is going to give us a talk about raising the efficacy bar in ulcerative colitis management. Dr. Al-Bawardi, the floor is yours.
All right, thank you, Dr. Abdullah, for that very kind introduction. So I'm hoping that this talk would generate much discussion. So there's not going to be a lot of data presented, but some theories here. So these are my disclosures, and the main disclosure is that this talk is funded by AbbVie, funded by Takeda. So I'll start with an ulcerative colitis case. This is a 24-year-old woman you're seeing in clinic who was diagnosed with extensive UC just 3 months ago. She presented initially with 5 to 6 bloody bowel movements per day, tenesmus and urgency. At presentation, her CRP was mildly elevated at 15, albumin was 36, and hemoglobin was 12.5. She was initially treated with prednisone 40 milligram taper and mesalamine at a dose of 4.8 grams daily. She actually did pretty well. She achieved clinical and biochemical response. But as soon as she was tapered off prednisone, she had a recurrence or a flare with 5 bowel movements more than normal, so up to 7 bowel movements a day, 50% with blood, and minimal abdominal cramping. So workup showed a negative stool C diff. Her hemoglobin has now dropped slightly to 11.2. Her CRP has now increased to 45. Fecal calprotectin is 1223. And then you do a flexible sigmoidoscopy, which shows these findings with ulcerations throughout the extent of the exam, and biopsies were obtained, and they were negative for CMV. So if you're seeing this patient in your clinic, what would be the next kind of course of action you would take? Would you give this patient another course of prednisone? Would you add topical mesalamine? Would you start azathioprine? Or would you start advanced therapies? So I'm just going to poll the audience and see how many would go with A, another course of prednisone. So no takers. What about topical mesalamine? Great, no takers there. She has extensive colitis. Start azathioprine. So only 1 vote for azathioprine. And what about advanced therapies? So the majority of you would start advanced therapies. And I think, one of the things that we have talked about in this meeting is risk stratifying a patient. So this patient is high risk with extensive ulceration seen on endoscopy. So she would be a candidate for advanced therapy. So I'm talking about UC. So you're wondering, why am I bringing this infamous graph that Dr. Ala talked about earlier? Well, we hear this over and over again, that Crohn's disease is a progressive disease. If it's left untreated in that window period, it can progress to stricturing, fistulizing complications, and we know that up to 20% will develop perianal disease. Now, the 20-year risk of some of these complications can approach 50%, and if left untreated, will result in surgery. So older data suggests that risk of surgery is 50%. You saw some of the newer data in the biologic era that Dr. Miguel presented earlier, where the risk now has gone down to about 25%. The reason I bring this up, since the talk is about UC, is I think ulcerative colitis is technically a progressive disease too. If we look at initial diagnosis, up to 30% will be diagnosed with proctitis, up to 40% will be diagnosed with left-sided colitis. But we know that disease extension does happen, and it's kind of helpful to know these numbers, because when we diagnose a patient with proctitis or left-sided colitis, there's always that question of, am I going to progress? Is this going to spread into the rest of the colon? And looking at some of the epidemiologic data, the risk can be anywhere between 12 to 30%, and the 5-year risk is about 13%, so maybe remembering a number around 15% would be helpful. Now, older data suggests that the risk of hospitalization in UC is up to 50%. I think newer data is suggesting that it's actually lower, closer to the 25% mark. Now, the reason it's also progressive, because the risk of colectomy is there, and these are older numbers where the 10-year risk of colectomy approached 15%. Dr. Miguel shared with you some of the more recent systematic reviews and meta-analysis looking at, in the post-biologic era, that 10-year risk maybe has dropped down to about 10%. So why is disease extension important? This is a very interesting study from Norway and Copenhagen County. And what they did in this study, they looked at patients who were initially diagnosed with pancolitis and compared them to patients who were initially diagnosed with, let's say, proctitis or left-sided colitis and then progressed. And the take-home point from this slide is that, I don't know if the pointer is working, from this slide is that those that extend, those that go from proctitis or left-sided colitis to pancolitis, actually had a higher risk of colectomy at 28% versus those who were initially diagnosed with extensive colitis, and you can see that on the reverse Kaplan-Meier curve. Now, I think we're taught in medical school over and over again that ulcerative colitis is a mucosal disease, but there has been really interesting progression in our understanding of UC being a progressive disease, that it's probably not just a mucosal disease. And what we've seen in our practice, those patients with long-standing UC, even if they go into remission, you can see that tubular ahostral colon, they have decreased rectal compliance, so patients will continue to have symptoms such as urgency, maybe incontinence, and even diarrhea. And what we also have learned is that fibrosis does occur in ulcerative colitis, so it's not only in Crohn's disease. And this is a nice study of about 89 patients who underwent colectomy. So they had colectomy specimens that were looked at under H&E. And they've noticed that there is a significant amount of fibrosis noted in the submucosa. And it's interesting that the fibrosis is directly related to not only the active inflammation, but it's the combination of active inflammation and chronic mucosal injury. So these are patients that probably have had the disease for the longest time. So how do we prevent this progression? So I hope you're convinced that, yes, UC is a progressive disease, and I know we treat UC traditionally in a step-up manner, which is appropriate, but I think the most important thing is how we monitor disease and adjust therapy to prevent cycles of corticosteroids. So the key here behind this, and if you've seen the STRIDE consensus, is that we should treat the patients, monitor the patients, but more importantly, it's the steroid-sparing therapy. Now, when we look at insurance claims data from the US, and this includes both commercial insurance and Medicare, unfortunately, a significant proportion of both Crohn's and UC are still treated initially with corticosteroids, so up to 25% for UC. And what's interesting when you look at physicians' perception and patients' perception of corticosteroids, patients actually have greater concern about use of corticosteroids. When they were polled here, up to 765 patients, 42% said they had significant concern of long corticosteroid duration. Well, if we look at the 600 plus physicians that were polled, only 27% were concerned about the length of steroids. Now, as we know from guidelines, the goal of maintenance therapy is to maintain steroid-free remission. So the key here is steroid-free, and long-term corticosteroids we know does not necessarily prevent disease relapse, and our job is to make sure that our patients are doing well on steroid-sparing therapy. So we talked about this window of opportunity for Crohn's disease, and we have probably less data, I think, to support that for UC. But in general, these are some arguments that have been brought up when we talk about treating patients and treating them early to the desired goal. So one, there's a worry about overtreatment, and I think the counter argument to that is we need to make sure we make a clear distinction between disease activity and disease severity. So if you look back to our patient, if we just take a snapshot of disease activity, she was having maybe up to 5 bowel movements a day, but we know if we classify this patient based on disease severity, she's actually high risk with having deep ulcers. So that wouldn't be a worry, and we need to distinguish disease activity from disease severity. The other counter-argument that has been given is, well, we don't want to go too aggressive. We're worried about infections and malignancies. But we also know that untreated disease, and this was brought up earlier by Dr. Miguel, is actually a significant risk factor for complications. And thankfully, we have safer treatments right now and treatments that are easier to manage, such as non-anti-TNF biologics or even JAK inhibitors. Okay. So for the next few slides, I'm going to go over ulcerative colitis management and medical therapy in the context of short-term goals, intermediate goals, and long-term goals, and we'll apply vedolizumab as an example of these goals. So we always think about distinguishing our advanced therapy as either biologics versus small molecules, but another way to look at this, and I think this is relevant when we're thinking about combining agents, is the actual mechanism or mode of action. So you could think about this as anti-trafficking or anti-lymphocyte trafficking, such as anti-integrin, and the rest are actually targeting cytokines, whether it's TNF or interleukin-12/23 or even JAK inhibitors. So going back to the slide, now over the next few slides, we'll take vedolizumab as an example of how we can monitor short-term goals, intermediate goals, and long-term goals. So let's look at our short-term goals. So as we learned from the previous slide, we want to see our patients clinically get better. So we want to see some clinical response when we start these agents. So how does vedolizumab do when it comes to achieving some of these short-term goals? This is post-hoc analysis from the pivotal Gemini 1 trial. And this is looking at induction of vedolizumab versus placebo in both anti-TNF experienced and anti-TNF naive. So if we look at vedolizumab, which is shown in purple here versus placebo in gray, you can see that the clinical response, which is at week 6, is actually up to 50% in patients who are anti-TNF naive, and it can also be seen in up to 40% who are anti-TNF experienced. So we see this fallout of anti-TNF experienced and naive as we see with our other biologics. Now, how about as early as week 2? Again, post-hoc analysis from the Gemini trial. And I want to just emphasize that now we're just looking at anti-TNF naive. So these are biologic naive population. When they get started on vedolizumab, you can see a separation between vedolizumab and placebo as early as week 2 when it comes to symptoms, including rectal bleeding and stool frequency score. I think this kind of data is also helpful to set expectations for you as a clinician and also with the patient. So the patient wants to know, how fast am I going to get at least better, or am I going to get a clinical response? So if they're anti-TNF naive, you can see some response as early as week 2, but definitely by week 6. Now let me explain this graph here. This is post-hoc analysis from the Visible-1 trial. So if you recall, this is a trial where patients were given intravenous vedolizumab induction followed by either subcutaneous or continued intravenous. Now what we're looking at is the open label result. So these are patients who had clinical response after induction. And this is how they do on week 6, week 14 and overall. So again, this is emphasizing that if patients get a clinical response early on, they tend to do well on the subsequent doses. Now this is data from the Varsity trial, and just as a review, we know Varsity trial is a head-to-head clinical trial between adalimumab and vedolizumab in ulcerative colitis patients. And again, we're looking at short-term targets. So this is showing that as early as week 2, vedolizumab gets a little separated from adalimumab when it comes to change in the partial Mayo score from baseline. Also from the Varsity trial is looking at the clinical response at week 14, and we see that there is a separation between vedolizumab and adalimumab with clinical response rates as high as 67% at week 14. So that covers the short-term targets. So you can definitely see some clinical response early on during induction, but I want to emphasize that it's mainly seen in patients who are anti-TNF naive. So our intermediate targets, we want to achieve remission clinically, but we also want to see our biochemical improvement in CRP and fecal calprotectin. So this is exploratory outcomes from the Varsity trial. This is looking at fecal calprotectin reductions observed at week 14. And what you can see in the blue line is the amount of fecal calprotectin reduction in vedolizumab group versus the dark blue, which is the adalimumab group. And you can see there is a separation at week 14 in terms of the reduction in fecal calprotectin in the vedolizumab, which was higher reduction or more reduction compared to adalimumab. In addition, looking at clinical remission, this looks at long-term outcome at week 52, and we know this is the main result where there is a higher clinical remission rate. And then finally, looking at long-term targets. So this is data from the Varsity trial also that shows that vedolizumab was superior to adalimumab in terms of achieving hard outcomes, including endoscopic improvement at week 52. So, the title of the talk was Raising the Efficacy Bar in Ulcerative Colitis. So is the answer in histologic healing? And I know we had a really nice talk by Dr. Maryam on histology, so I'm just going to briefly touch on histologic healing in UC. So what is the definition of histologic healing? We know that there are multiple definitions that exist in the literature. I think the simplest definition is the absence of neutrophilic inflammation in the mucosa. And clinical trials have defined histologic response based on the Robarts or Gabos or the Nancy score as shown here. So what's the value of histologic healing in UC? So this is a nice systematic review and a meta-analysis that took patients who achieved a Mayo endoscopic score of 0 or 1, and they followed the patients up to the last follow-up to see what's the risk of relapse based on, first, the endoscopic score. So there is actually a significant separation. If you achieved a Mayo endoscopic score of 1, your risk of relapse is as high as 29% over long-term follow-up. But if you achieve a score of 0, the risk of relapse is lower at 14%. Now, if you go a level deeper into histologic healing, the annual risk of relapse, it goes down significantly to single digits at 5%. So this systematic review supports that histologic healing is associated with lower risk of relapse compared to even a Mayo endoscopic score of 0. Now, going back to vedolizumab, again, data from the Varsity trial, has been shown that with vedolizumab, you get higher frequency of histologic healing as defined by both the Gabos or Robarts histology index. And you can see the rates here. The deltas are around 20% and about 15% between the two groups. In addition, if we look at a different definition, a more stringent definition of histologic remission, which was a Gabos score less than 2 and a Robarts less than 3, we can see a delta of 7% and a delta of 17% in favor of vedolizumab. Now, the whole idea of histologic healing has been brought, I think, into question with this study. This is actually a very nicely done single center, but it was a prospective cohort of UC patients out of Canada. And they were looking at the risk of relapse based on the Gabos score, where it's a similar definition of 3.1. And interestingly, what they noticed is that histologic healing did not predict risk of relapse in this group, but only one feature, which was basal plasmacytosis, really predicted the one-year relapse, and it was kind of marginal with a p-value of 0.52. So I think that the value of histologic healing has shown in previous studies, but it's being brought into question with more prospective studies. And I think one trial that hopefully will help us answer this question is the VERDICT trial. So if you're aware of the VERDICT trial, this is a randomized trial that's going to have one of 3 groups, and patients could be either on mesalamine or vedolizumab, or if they failed mesalamine, they would be started on vedolizumab. And what happens in these 3 groups, so group 1 would be treating to symptoms, group 2 would be treating to symptoms and endoscopy, as we do in clinical practice, and group 3 would be treated to symptoms, endoscopy, and histology. And what happens at week 16, 32, and 48 is assessment if these goals were achieved. If the goals weren't achieved, then vedolizumab would be dose escalated, for example, to every 4 weeks. And the primary endpoint is a composite endpoint of surgery, hospitalization, or loss of efficacy of the drug. So this trial is currently ongoing, and I think it will help us kind of understand the value of histologic healing more. So we just talked about histologic healing. I think we have to kind of wrap it up into what are the evolving targets and goals, where are we now, where can be in the future, and what's more practical. So the new concept here is disease clearance, and I think we borrowed this term from psoriasis, where they have the term skin clearance based on parameters. But in UC, disease clearance is defined as clinical remission. You can base that on PROs, for example, endoscopic healing, and histologic healing. Now, a step further is molecular healing, and that's also kind of being investigated in prospective studies. So how has disease clearance been investigated? There's not much data on disease clearance, but it actually has been looked at in the Varsity trial. And I'm just going to point out that these are very low values. For example, if you look at disease clearance in the adalimumab group, it was about 16%. And disease clearance in the vedo group, which is shown in the top right, it's about 30%. Now, we keep talking about STRIDE, which is setting our short-term, intermediate, and long-term goals.
But I think the next step after that is once we achieve that, are we modifying the disease? And this is where the Spirit consensus came in, is looking at disease modification, which is defined as, returning to a normal quality of life, preventing complications, and reducing long-term complication. And this is kind of where the future is going to be. So what is the problem with having more stringent targets and goals? So number one, we're really not doing a good job getting to our current treatment targets and goals. If we look at endoscopic or deep remission, and in this setting, deep remission refers to clinical and endoscopic, not histologic, may not be attainable for all patients. We know a significant proportion of our patients don't even achieve endoscopic remission. Now, even if we add a more stringent goal, such as histologic remission, as it stands, many patients are not even reaching our current goals. So this is the issue of having a more stringent target that is not even achievable. So until we have more efficacious drugs, until we have more data to support this, I just want to make it clear that we are not advocating to switch therapy for any patients who are currently in clinical and endoscopic remission but are not in histologic remission. So definitely no switching of therapies. And this is why we need further prospective trials, such as the Verdict trial, to tell us a little more about the value of histologic healing. So I'll end here. So I hope I convinced you that ulcerative colitis is a progressive disorder. And we know that long-standing inflammation in UC has been associated with structural damage, including submucosal fibrosis. Tight control and monitoring is key, and utilizing our biomarkers early and to achieve steroid-free remission. And the current treatment goals for UC are clinical, biochemical, and endoscopic, and prospective trials such as the Verdict are needed to really see the impact of histologic healing on disease modification. So I want to thank you for your attention, and I'll take any questions.
Thanks a lot, Dr. Brighty, for this elegant and nice talk as always. Now we'll open the forum for questions from the audience. I might just start with one question until we hear from the audience. So in Verdict trial, Dr. Brighty, are we gonna, so this seems to be one of the treat to target, trials. So the escalation of treatment will be targeting histological remission. So if the patient is not achieving histological remission, then the patient will be escalated to the next step, which is optimization. Now, what do you do in your current clinical practice in a patient who's already achieving clinical remission, yet you still have this Mayo score 1 kind of like not achieving the Mayo score 0 as shown in the meta-analysis? Would you escalate if the patient is on a standard dosing of vedolizumab? Would you add? Right. Do you consider keeping 5-ASA? What would you do in clinical practice if you're not achieving the endoscopic response that you're hoping for, yet the patient is feeling fine?
Yeah, no, that's a great question. So, if you look at the STRIDE consensus, I think they said, we should achieve Mayo endoscopic score of 0, but you can take 1. And I think in the majority of patients I see, if they reach to Mayo endoscopic score of 1, I'm happy with that. However, I think there's now a subset of patients that I think we can optimize our current therapy maybe to get there. And I think a lot of things have to be taken into consideration, right? Is the patient on their first line, or is the patient on their fourth line? What did they start with in terms of inflammation and where they are now? The patient's comorbidities. And also, I think what we don't talk about very often, especially with histologic healing and more stringent goals, is the risk of colon cancer, right? So if I'm dealing with a patient with PSC, family history of colon cancer, very long-standing UC, I might try to optimize therapy to get to that Mayo endoscopic score of 0. So I think it's a sort of a case-by-case case, but definitely not switching therapy when you've reached a Mayo endoscopic score of 1.
Any questions from the audience? Or I can take maybe one last question before we close the symposium. Yeah, Professor Garo, go ahead.
So, Badr, very nice talk. The question I have with Vito, and we've talked about this before, where patients over time, some patients lose response, and we go to every 6 weeks, go to every 4 weeks. One specific question, well, first of all, are you using sub-Q? Yeah.
We have it available, yeah.
So my question is, do you think the sub-Q dosing every 2 weeks is going to afford a different durability of response? I know the data, but long term, I'm just wondering from a pharmacokinetic standpoint if you have any insight into that.
Yeah, that's a great question. So if we look at the both Visible-1 and Visible-2 trials, they actually tracked the vedolizumab drug levels, and the sub-Q always had higher drug levels than the IV, and they were maintained for longer. And what's interesting, if you look at subcutaneous infliximab, CTP13, kind of replicated the same thing. They had higher infliximab levels, and they were maintained longer. And post-hoc analysis from that study showed that even without an immunomodulator, you might do well with infliximab. So I think the sub-Q dosing offers the advantage of that. But what's different between Vedo and infliximab, I don't think that drug exposure is as important when we look at infliximab. So yes, pharmacokinetics is better, but I'm not confident that it's going to translate to effectiveness clinically. But on the other hand, with CTP13 sub-Q, I think it's going to translate to better effectiveness, less immunogenicity.
I think we have just one minute for last question.
Thank you, Dr. Badr, for a nice talk. I didn't get what is the implication of disease clearance in changing the treatment algorithm. Is it going to change your management, or later will change your management? So where you can put the disease clearance in the management?
Absolutely. That's a great question. So practically now, we are not trying to achieve disease clearance based on the therapies that we have, based on how we're able to achieve even endoscopic healing. I think we're looking into the future, whether this is going to be something that we're going to aim for, because the goals are getting more stringent, but I think practically speaking, we're just aiming for clinical, biochemical, and endoscopic at this point.
Okay, I think we're running out of time. Thanks a lot, Dr. Bardi, for the nice lecture. Thank you for the audience for listening and attending. I think it's time to conclude our symposium and move to the next session. So we'd invite the chairperson for the next session to come up. Thank you.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين. Thank you, SGA, for this nice, wonderful meeting. Thank you, IBD Interest Group, for this. Really, we enjoyed today, inshallah ta'ala, in this last session. We are happy to have case discussion. We will start by Dr. Yasser Mir Alam. He will speak about how to manage biologic immune modulator during active infection in Crohn's disease. Dr. Yasser Mir Alam is currently consultant gastroenterologist with specialized in inflammatory bowel disease, head of gastroenterology department, digestive and liver disease center, King Abdullah Medical City in Mecca. Welcome, Dr. Yasser. The floor is yours.
Hi. Thank you for the pleasant introduction, and thank you for the chairman. Thank you for the SGA and the Ibd Masterclass for having me here to talk about the management of patients in IBD patient in active infections during active infection. Okay, so I don't have any disclosure. I will start with the two cases, and first of the cases is a 38 years old male patient who is new to our hospital, diagnosed outside with the chronic Crohn's disease on infliximab and azathioprine, and presented to emergency department with a 2-week history of worsening abdominal pain, vomiting, and diarrhea with loss. Physically, patient is afebrile, but he looked ill. He had rebound tenderness and guarding in his abdomen. He had the white cell count of 12 and elevated biomarker. ESR is high, and fecal protectin is more than 2,000. Cultures for C. diff and for ovum parasite were negative. Chest X-ray was normal, and CT interrography was done and showed thick wall throughout the colon with a skip lesion and prominent lymph nodes which indicate the active infection, or there is an infection, or activity of disease. So because he's a new, we did an upper for him, endoscopy that was normal. The colonoscopy showed a severe inflamed colon with ulceration throughout the colon. The biopsy taken from the colon and turned out to be TB at the end. So the patient has a diagnosis on intestinal TB while he's referred to us with infliximab and azathioprine. So the initial plan for any patient with active infection, we should hold all the biologic therapy and immunosuppression, and then once we have discovered the TB, we start the full management of tuberculosis. So we don't know if this is a superimposed infection or it's a TB from the start because he's coming from outside of our facility. So we'll come later to the case 1 and the case 2 at the end of the discussion and see what's happened. In the case 2, the 30-year-old male patient with the ulcerative colitis with an infliximab and Imuran, and presented with a 2-week history of bleeding per rectum and fever, and the patient has difficulty to be weaned off from the steroid. And the patient, he had abdominal pain on examination. He had a leukocyte count is high, ESR and the CRP and the fecal creatinine also in the elevated side. The colonoscopy, the C. diff toxins and the stool culture were negative. So we performed colonoscopy for this patient, and she had multiple and severe ulceration in his colon in the continuous matter. The biopsy taken throughout TB, histopathology at the CMV. CMV came in positive, but being the TB is positive is not enough in PCR, so we did the DNA for this patient, and the COB is more than 350. So initially we stopped the immunosuppression and the biologic therapy for this patient, and because the patient had refractory to be in steroid, we start to wean the steroid after we give him the antiviral therapy. So in introduction to because the inflammatory bowel disease, both UC and Crohn's disease, is requiring high, or the management, especially in severe cases, is required to be on biologic therapy and immunosuppression medication. We have to be sure that these medications can suppress the immune system and let the patient have a lot of side effects, as well as the infection, including the opportunistic infection. So make the treatment be difficult and sometimes complex. And with the new emergence of the biologic therapy and new novel therapy, we are trying to be the selective medication toward taking the more selective medications, because these selective medications could help us in reducing the side effects and as well as the serious infection. So we have to know that the predictor of the opportunistic infection, IBD, malnutrition, old age, obesity, chronic disease, other comorbidities, and the severity of the disease itself. And the patient, of course, if he's taking immunosuppression medication. Why it's important? Because IBD with immunosuppression medication is prone to have infection, which can increase the mortality and the hospital stay and visit to the ER frequently. So in this study, when the meta-analysis that showed that the risk of infection is increased when they compare with the combo therapy more than in the monotherapy with the infliximab. And also, when they compare which one is the monotherapy infliximab or the independently on the immunomodulators, so it's the infection is more there in the anti-TNF or the monotherapy of biologic therapy. So this factor can be categorized into internal factors, external factors, and additional factors. Internal factor, the age of disease, severity, and malnutrition. And additional the external factors, the immunomodulator or biologic that we are using. And the external factors, the overweight, surgery, and the other comorbidity and the disease activity of the patients. So some of the most common infections that presented with immunosuppression medication that candidiasis, and biologic therapy is having, especially the anti-TNF, is towards having TB and the fungal infection more. So in this table, they show that which biologic therapy is the safest, and and other medications that can cause higher infection. So the anti-TNF, osteokinumab, tofacitinib, is in the higher rate of it labeled in the red line that this medication is high risk of having infection in patients with IBD. While and then the systemic steroid, of course, the vidazolumab is have because of gut selectivity is has the low risk of infection. So in better view, see how combined monotherapy with the thiopurine is increasing the risk of infection, and the anti-TNF is having more risk of infection, and while in patient with combination have a more or higher side of infection, including the opportunistic infection. In this meta-analysis that shows also the systemic review meta-analysis, it showed when they compared each biologic therapy to other, it showed the anti-TNF whether the osteokinumab has a less prone to have a patient on osteokinumab prone less risk to have infection compared to anti-TNF. So when they compared all the anti-TNF to vidazolumab also had the lower risk. And in general overview, what they concluded that osteokinumab and vidazolumab have a lower risk of infection comparing to the anti-TNF. So this table is too condensed, but this is the whole trials have been studied from the ACT-1 in infliximab and ACT-OCTAVE study and the other study. They showed that how much infections or opportunistic infections appearing in this study. So I will not go through each one, but this is indicate that there is a risk of infection for each biologic therapy, and it depends on the biologic therapy is used. The most common opportunistic infection is the TB, herpes zoster, and CMV, and then the candidiasis depends on what type of candidiasis. When they compare the osteokinumab, tofacitinib, and anti-TNF infection, but the osteokinumab is the most among them. They have a low risk of infection, of having the infection compared to the tofacitinib and alpha-TNF. So in general considerations, once we have indication of viral infection, before selecting a patient to having biologic therapy or to be on immunomodulators, patients they have to be screened and see does this patient have a good immunization therapy before? Does he have a risk of having infection before? So this is most important before starting any biologic therapy or immunomodulators. We'll come to if the patient have a hepatitis, so patient who's not immune to or having a vaccine for hepatitis A, they should have a vaccine for hepatitis A before starting the immunosuppression medications. Patient who is in chronic active carrier of hepatitis B, he should have a DNA level to appropriate to suppress the level of the activation, and he should continue on the medication therapy as well, or for hepatitis B. Hepatitis C, there is also a risk of reactivation. Should be closely monitored these patients if he need to be on the antinucleotide therapy. CMV infection, the concurrent infection with the IBD on therapy with the CMV infection is make it more difficult to wean from the steroid, more difficult of these patients to be responded to the biologic therapy, and the risk and the mortality is increased about 2 to 3 folds at the rate of the colectomy than after. So in these patients with the CMV infection, we have to hold the immunosuppression therapy, and we'll start the antiviral therapy, once this patient had a high copy of DNA CMV, it's not only the PCR should be positive, the copies is most important as well. So usually we not stop the biologic therapy because the patient is having an active disease, but to overcome the refractivenesses of these medications due to the viral therapy, we should continue these medications and the antiviral therapy. We could hold the immunosuppression medication as the first line. So this is the sequence of how it's bad when the CMV is coming with the patient with ulcerative colitis. Okay, so this is the vicious cycle. Patient have an infection, severe inflammation due to the immunosuppression medication. So the patient, he will not respond. He will be in steroid for a long time. So that's why we need to act and give him the antiviral therapy, and then the patient will be improved. The microtuberculosis is mostly important, especially in the endemic area like Saudi Arabia, because most of the patients, we don't know, it's one of the mimics of Crohn's disease, the major mimics, and complex to decide if this patient having TB or having Crohn's disease from the start. So this is most important to know that we have to screen the patient to check for the latent TB, quantiferon, agar, chest X-ray, BDD test, and before giving the medication, taking clear and deep history, family history of this patient, because we are facing a lot of patients who is having really a TB patient, a TB, family history of TB, and once we start him on biologic therapy, he will develop TB at the end. So what about CD infection, CDF infection, the CDI? It's one of the other competing infection with the ulcerative colitis, one of the mimics in ulcerative colitis, CDI and CMV colitis as well. So it's most important that we have any patient with the flare, we have to think about CDI, we have to do the PCR and or the toxins A and B to confirm the diagnosis. So CDI is not coming only in patients who had previously having treated with antibiotic or previous hospitalization. No, it's coming with the TB, with IBD, if he's taking his biologic therapy or immunosuppression medication. The rate of CDI with the 5-FSA in the meta-analysis is less, or there is no risk of CDI. When using the systemic steroid, the chances of having CDI in the IBD patient is high, and in biologic therapy and immunomodulatory will be higher. So and also in the biologic therapy, it seems that the patient being active disease or IBD and he's taking biologic, the chances of having CDI is much more. So not only that, even the patient on antibiotic and IBD, he's having the chance to have the CDI. So why that is most important? Because CDI in active IBD patients, the risk of colectomy will be high as well. So this is a good table actually from the inflammatory bowel disease that mentioned that patient on IBD patient on active infection, what should you do? Anti-TNF infection with viral infection should be continued if the patient is not, you have to weigh the risk and the benefit. Okay, if the patient has opportunistic infection while using anti-TNF, you should be stop the anti-TNF. And if he had C. diff and it's not mild to moderate or mild disease, you can continue the biologic therapy and give the patient the antibiotic. And the most safest medication is the anti-integrin biologic, the vedolizumab, and the interleukin and the JAK inhibitors as well. You can follow the rule. The patient, they are higher. This biologic therapy have higher risk of infection, so be cautious in treating patient with active infection. So this is I think Dr. Miguel, he presented this one in the early morning. So this is from the Inflammatory Journal. This is the most safest, indicate what biologic therapy to be choose in active infection, or the most safest, based on the most safest biologic therapy they can use, or the immunomodulator. So the most safest one is vedolizumab. And I'm not sure if I ask Dr. Miguel, with the introduction of the new selective medications nowadays, like Skyrizi, where do you put this one in this diagram? With osteocumab. Okay, so the Skyrizi with osteocumab. So this is how important is the vaccination. I will not go through this. That each patient, we have to initiate the vaccination program before giving the patient the biologic therapy or immunosuppression medications. So I think it's all be available. should be available in the center before selecting the patient to have the biologic therapy. So when we back to the case 1, the patient who has an TB and discovered that he has a TB and referred from our side, and we don't know is he having TB from the start, but the patient, when we stopped all the biologic therapy and the immunosuppression and started for the anti-TB medication, the biomarkers start to improve, symptom-wise improve. So we continue so we consider this patient's anti-TB, the TB. So he's not a Crohn's. We continue the full management for him for 9 months, and then we had the response even in his colonoscopy. So this is the idea. If you don't know a patient from the start, you have to hold the biologic therapy or the medication and see the effect of your the antibiotic or the anti-TB before decide if this superimpose or not superimpose, or he's a TB from the start. So in this case too, this is the patient who had a severe ulcerative colitis with CMV infection, and he's had a refractory to steroid therapy. So what we did actually, we stopped. We continue. We give him the antiviral therapy, and we continue infliximab, and we start tapering the steroid, and we hold the azathioprine. Okay, so the patient is success to normalize his biomarker, and his colonoscopy came out of the ulcers, and we success to be out of steroid. And after we reach to that area, that stage, we add the azathioprine again for this patient. So in conclusion, we have to weigh the risk and the benefit in patient with acute infection who's taking biologic therapy, because not every patient who has infection need to be stopped the biologic therapy of the immunomedication, because we don't want to suffer the patient from the IBD. So be cautious when treating the patient with TB or treating the patient TB, and because these mimics, it's usually can mimic Crohn's disease TB. The TB is the most mimicker to IBD, the Crohn's disease. CMV and CDI is mimics to ulcerative colitis. Thank you very much.
Thank you, Dr. Yasser.
Assalamu alaikum jami'an. I would like to express my happiness for being here for the first time. I would like to thank Dr. Nahla for her kind invitation and for her utmost effort for letting this conference to be in its best shape. Thank you, Dr. Nahla. And thanks for Mr. Nawaf. He is the man who is behind the scene. I would like to present myself. I am Dr. Nawal Al-Khalidi from Iraq, Baghdad. I am the head of the Arab Board for Gastroenterology and Hepatology subspecialty, and I am the vice president of the Iraqi Society of Gastroenterology. By now, we will take you outside the gut, as Dr. Iman Al-Qurtas will talk beyond the gut, IBD-related erythropathy. Dr. Iman Al-Qurtas, rheumatology consultant, head of medical day unit at King Saud University, Medical City. She is the chairperson of biologics and biosimilars subcommittees. Please, Dr. Iman, the floor is yours.
Thank you. Thank you for the kind introduction, and I'm very thankful of this invitation. So I usually keep in mind the timing of the lecture when I'm making the slides. So I try to keep them as light as possible. I know everyone has just had lunch, 2 lectures, I'm the 3rd one. So hopefully it's not going to be too heavy on everyone. So we're going to talk about spondyloarthritis, actually. We don't really like to use the term arthropathy anymore in rheumatology when it comes to inflammatory diseases. So it's more of a spondyloarthritis rather than an arthropathy. Arthropathy is more of a general term. It can include degenerative causes and inflammatory as well. So keeping in mind that inflammatory bowel disease in general can be observed in 5 to 10% of spondyloarthritis patients. This percentage can vary according to the registry you're looking at, the location, and how they collected the data, the nomenclature they used, and all of that. Microscopic gut inflammation has been reported in some reports up to 46% and some up to 60% in patients with SPA, and the other way around. Patients with IBD had evidence of sacroiliitis up to 40 to 60% of those patients. So it has been linked to the degree of bone marrow edema actually in sacroiliac joint imaging on MRI. And there is a prevalence of IBD in patients with psoriatic arthritis as well, ranging from 0 to 20%. Now, it's always important, does it really matter to understand whether which one happened before the other? Not all the time you can actually identify that, because most of the time it's actually more of a dormant disease when it comes to spondyloarthritis. The patient is suffering from so many other things, so they're gonna go with their symptoms based on priority. So whatever is bothering them the most, they're gonna mention it in the clinic, and after a couple of years, they might mention to you in retrospect that they've suffered of back pain or joint problem, and it was never actually mentioned. Until it became more prominent and their gut symptoms were more under control. So keeping in mind, we're always now talking about a spectrum of diseases. It's not ankylosing spondylitis anymore. You can still find the terminology of ankylosing spondylitis in clinical trials and literature, but using the terminology of radiographic or non-radiographic axial spondyloarthritis is a lot more accurate and more inclusive to your patients. So it's more of a predominantly axial disease or predominantly peripheral disease, keeping in mind that both can overlap in all of our patients, regardless of their association with IBD, psoriatic, any other disease. Keeping in mind that someone with IBD can still have a tendency to develop psoriasis, uveitis, and other associated diseases. So, now when we used to use the terminology of extra-articular manifestations or extra-musculoskeletal manifestations. What we use in this terminology is basically three things: uveitis, anterior uveitis, and inflammatory bowel disease and psoriasis. These are the things that we consider extra-musculoskeletal manifestations, and they are actually correlated to the pathogenesis of the disease itself. When it comes to other extra-articular manifestations that we will find in literature and in reports like aortitis, fibromyalgia, other types of complications, these are not really related to the pathogenesis of the disease itself. So you will not really target them with your biologic or advanced therapy, but you have to keep in mind that your patient is prone to developing other extra-articular manifestations. So what are the predictors that we can keep in mind for extra musculoskeletal manifestations? Patients who will have a higher tendency, as mentioned, for anterior uveitis, up to 23%, psoriasis, and IBD. There is a similar prevalence when it comes to uveitis, to all of them, sorry, in radiographic and non-radiographic when it comes to IBD and psoriasis. It's just for uveitis, it's probably more prevalent with and associated with radiographic axial SpA and with HLA-B27 positivity. Now, when it comes to undifferentiated spondyloarthritis, which is a terminology you might hear from your colleague rheumatologist, undifferentiated spondyloarthritis is basically a patient who has the disease but does not qualify based on the classification criteria and the diagnostic criteria to fit in one category. But they have actual evidence of either peripheral arthritis or axial arthritis, or both of them, but they just don't suffice any clinical criteria or diagnostic criteria. But at the end, you're treating a patient, you're not treating a research paper. Now, I'm sure you've heard of the classification of type 1 arthropathy, type 2 arthropathy, and all of that. If you attend a rheumatology clinic nowadays, you'll probably never hear anyone using this classification because it doesn't really help us. It's not sensitive enough to actually classify our patients using that. It's just probably, it used to be helpful to identify patients, but not really anymore. It's that helpful. So when we're talking about the pathophysiology, I'll just give you a chat about one of my patients. She's actually a medical doctor. So she's 33-year-old, known to have Crohn's disease. She had the disease for almost 7 years by now. She also known to have plaque psoriasis, axial spondyloarthritis with clinical evidence of the disease and MRI activity of bilateral sacroiliitis. She already failed infliximab, adalimumab, and certolizumab. So she was wondering about whether vedolizumab, she heard of it, she's a medical doctor, she heard of vedolizumab, and she was wondering if it's a good option for her. And so anyone has any thoughts? I really thought that it's gonna be a small room and I can ask questions and get answers. So just to give you some thought, would you consider it for her or would you not? Yeah, so you would consider it only if it's a combination. But what's against the combination in this patient? She's a medical doctor, she's exposed to patients, so you will really be worried about her risk of developing infections. So the combination is not really the best option for her. Probably there are other options because lucky now we have actually multiple other options when it comes to biologics and advanced therapy. So patients who will have silent macroscopic and microscopic gut inflammation can be up to 60% in our patients, and it's usually more common in younger population, male gender, progressive disease, early onset of the disease itself, with patients who have radiographic evidence of sacroiliitis, and high BASDAI. BASDAI is our clinical outcome measure for disease activity, and patients with restricted spinal mobility. So it's more or less with advanced and progressive disease rather than a patient who just got diagnosed. So we have the gut synovial axis, and I'm sure you covered most of this during the past 2 days. So you'll think about the bacterial antigens involved and the reactive T cell clones as well. You'll think about the genetic predisposition in those in this category of patients. So this is a very common question in clinical practice, whether the patient is inherited this disease or not, whether they're genetically predisposed to giving it to their offsprings or not. So first and second degree relative history is very important with ankylosing spondylitis, IBD, and all of that. Genetic factors and through alteration in both adaptive and innate immune pathways are important. Now, 25 to 78% of patients with AS and IBD will be HLA-B27 positive, keeping in mind that this data doesn't really apply to our region. In our region, the positivity of HLA-B27 in ankylosing spondylitis patient is around 60 to 70%. When in worldwide data, you'll find it up to 95%. So it doesn't really apply to our patient population. And with time, you will find more alleles reported and more differentiating phenotypes that might apply more to our ethnicity and our region. 38% of patients with active ulcerative colitis or Crohn's disease have been identified to find an allele of DRB10103. So there are multiple alleles that will come. You cannot really test for all of those in your clinical practice, but just to keep in mind that there is a strong correlation when it comes to the pathogenesis of the disease itself. And this will help you in making the decision of the treatment for those patients. Now for the IL-23, IL-17 axis, which can apply to our patient I've just mentioned, she already failed anti-TNF therapy, and you're considering another biologic therapy for her. So you will consider the IL-12, IL-23 axis. Risankizumab can be one of the options that you will consider for her. And the other way to go with it is the small molecule JAK inhibitors as well. So keeping in mind that this axis plays a major role in both axial spondyloarthritis and in IBD. So the microbiome, I'm not sure if you've covered this or not, so this is more of your topic rather than my topic, but it's always important to keep it in mind that there is a strong correlation when it comes to the gut microbiome, not just when it comes to gut activity, but also to spondyloarthritis and inflammatory arthritis as well. Now, let's talk about treatment. So for my other patient, he was a 27-year-old gentleman. He presented to my clinic. He's been diagnosed with Crohn's disease since childhood. He's not sure what was his age, not really sure about all of his prior treatments, but his mother remembers that he was on one biologic that was IV, so probably infliximab, but we were not sure about the duration, the dose, and all of that. When he presented to our clinic, he was already on adalimumab. He tried azathioprine before that. He had severe inflammatory back pain. He had disabling bilateral hip pain. He was on both crutches. Keeping in mind, this is a 27-year-old fresh graduate. He just joined a new job, moved to Riyadh from another city. So he has so many things happening in his life, basically. And he was really depressed at the time of presentation to the clinic, and the news that we delivered was not really very helpful after imaging. So he had bilateral sacroiliitis with erosive disease. He had bilateral hip arthritis as well that might require surgery and joint replacement as well. So that really didn't help his depression, and his depression was quite advanced with death thoughts and all of that, unfortunately. Now, after discussion of the options of clinical treatment on all of that, we actually went with infliximab, although he has used it before, but we're not sure about the duration and optimization of the dose itself. But we wanted to give it the maximum benefit of the doubt before moving to a different category of medication, given that his disease activity is more focused on the joints rather than the gut itself. So we went actually with infliximab, and luckily, I'm only telling you the good stories, of course, today. So luckily, after probably 6 to 8 months, we actually started to see some improvement. And now it's been almost 18 months now. I've seen him recently. He's not using his crutches anymore. He's mobilizing freely. He got engaged. He started a master's degree, actually. So it's all perfect good news. But that's just not to advertise. It's just a matter of you can actually make change even in patients with really advanced disease. So on presentation, and just a reminder, so he really still has the severe bilateral hip arthritis. He has an erosive sacroiliitis bilaterally. His gut inflammation was still active, but we were able to control his disease with infliximab so far. For how long we're going to be able to control this? Are we really going to be able to achieve remission on the long run? Is he not going to need the surgery? Probably he's still going to need the hip arthroplasty, but we were able to delay it a little bit because you have to keep in mind the age of the joint itself when they replace it and all of that. So, and the treatment was not just with the rheumatologist and the gastroenterologist. We had the major involvement by the psychologist and the psychiatrist as well with us. So always keep a multidisciplinary approach in your mind. It's not just from the medical team, from other allied services as well. So talking about treatment, non-steroidal anti-inflammatory drugs, we love them and hate them in rheumatology, but we still use them very commonly. When it comes to IBD, there is a general understanding that we should totally avoid them. But when you look at cohorts of thousands of patients and they compare the likelihood of an IBD exacerbation, there was almost similar results in some major cohorts.
2 minutes.
Thank you. So there was a huge similarity when it comes to the response to an IBD, a risk of an IBD exacerbation. Does that mean that we're going to use NSAIDs freely in patients of IBD? No, it's just a reassurance that if your patient used it without telling you, if you used it for a very short time because you didn't really have any other option, it's not really a major risk of gut inflammation, but it's not really the mainstay of treatment when it comes to spondyloarthritis anyway. We still need a more advanced treatment. Glucocorticoids are only effective when it comes to peripheral involvement of the disease, so dactylitis, synovitis, enthesitis, but when it comes to the sacroiliitis and axial involvement, unless you're doing an intra-articular injection, it's practically useless to give systemic steroids. Sulfasalazine, again, we still use it when it comes to peripheral involvement, but it's a weak agent. And usually we will move to more advanced disease. Methotrexate has no role. Azathioprine, we will never interfere with the azathioprine because it doesn't do anything for us when it comes to spondyloarthritis. So when it comes to biologics, as we've talked already, so vedolizumab, as much as it's effective when it comes to IBD, it might actually, there are some case series that it might trigger arthritis or enthesitis, so we tend to avoid it. Anti-TNF, you have a variety of options. The good news now that we have the upadacitinib, the JAK inhibitor, so we need more data and more clinical practice on it, but at least we have it approved for treatment. Risankizumab, which is approved for Crohn's disease, and it's actually effective when it comes to peripheral spondyloarthritis. But until now, from what we know from the data, from the axial spondyloarthritis and the psoriatic arthritis data with axial involvement, it's not that effective when it comes to axial disease. Although if you look at the clinical trials, some of them are promising, but we're still looking forward to more evidence. When it comes to our clinical practice in my hospital, most of our patients respond very well to risankizumab when it comes to their skin, to their peripheral joints, but never when it comes to their back. For the IL-17 inhibitors, which we love in axial spondyloarthritis and in psoriatic arthritis, they're actually not advised when it comes to IBD because of the risk of flare. The only thing to keep an eye on is bimekizumab, which is more, it has a more inhibition of IL-17F in addition to A. It's a non-selective inhibition, so we're not sure if it's going to be safer in IBD or not, so we're still waiting for the data. So for our guidelines and recommendations, it actually goes over the same thing. So we all use monoclonal antibody, anti-TNF, when there is an evidence of IBD. We go for JAK inhibitors if there is upadacitinib, if there is any risk, and the IL-12, IL-23. Guselkumab was still waiting for the data. Risankizumab is already approved, and you can give it a chance of a trial. So always keep in mind, multidisciplinary approach in your patient. You're treating the same disease, basically, with 1 or 2 agents. So your biologic is treating the gut and the joints as well. And keep an eye for ongoing data and targeted synthetic DMARDs. Thank you very much.
Thank you, Dr. Iman, for such nice presentation.
So it's, now we will go to the next lecture. Lessons learned from the transition of care in IBD, multidisciplinary discussion. Our speaker, Dr. Ahmed Darmaki. Dr. Ahmed is Vice President of Oman Gastroenterology Society, consultant gastroenterology specialized in inflammatory bowel disease. He's graduated his medical school, internal medicine from Oman, and gastroenterology advanced inflammatory bowel disease from University of Calgary. Dr. Ahmed, the floor is yours.
Thank you, Mr. Chairman. Good afternoon, everybody. It's very nice to see this amount of audience staying until now. So thank you for staying, and thank you for the organizing committee for inviting me. I wonder if we have pediatric gastroenterologists around with us in the hall, but they are a major player in this topic. So let us start. My disclosures. In the 20 minutes or so, we will be discussing the transition of care and its role in inflammatory bowel disease, review the differences between the type of care in adults and pediatrics, and review the adult gastroenterology specialist perspective of transition, and discuss the definition, rationale, and timeline for process of transition. I'll be using, or you will see, the term IAS, which stands for adolescents and young adults. That has been used in the recent Canadian guideline of transition of care in IBD. So I'll be having one case, and I'll try to be brief. So this is a 13-year-old boy with a history of bloody diarrhea and weight loss with urgency. He had poor oral intake and nausea, typical symptoms of suspected IBD seen by pediatric gastroenterologist. Investigated, was found to be anemic. He was malnourished, CRP of 25, and normal other labs. Admitted to the hospital for investigations, done OGD and colonoscopy under general anesthesia. OGD was normal, colonoscopy showed features of severe inflammation in different parts of the colon with normal terminal ileum. And based on the histopathology results and the endoscopy results, he was diagnosed with Crohn's colitis. So here it comes the management. You are having a patient of Crohn's disease, severe, young, malnourished. The initial discussion between the pediatrics gastroenterologist and the patient caregiver was to start enteral nutrition, which was mentioned this morning, but the family was sort of reluctant, then agreed, but the patient refused, so they went with the corticosteroids and later azathioprine. Had a good response, actually, and then continued without like with steroids tapering, but while tapering down, symptoms worsened, so he was escalated to infliximab with a symptomatic response. A while ago, probably a year ago, he had a colonoscopy which showed severe Crohn's ileocolitis, some ulcers in the ileum, and the colitis was still there. At that time, it was like the age of 14, and pediatric gastroenterologists in our setting don't take care of patients after the age of 14. So he was referred to an adult gastroenterologist having symptoms. At the time of transfer, all the options were reviewed, and the patient was switched to another medication out of class, to ustekinumab. However, the symptoms continue to worsen, further weight loss, not much improvement. Patient's mother was so concerned. She had the phone number of pediatric gastroenterologist, and she was continuously talking to her and complaining that she doesn't have easy access to the adult gastroenterologist. Patient was not admitted, but he was still symptomatic. So we are having few issues with this patient. Uncontrolled disease, the timing of transfer, you could argue that it was probably not the right time of transfer. Change of therapy post-transfer happened quickly without very close visits, and there was no transition process whatsoever, and there were some communication issues. So those are part of the issues which you will face during transition of care. So transition is a purposeful, planned, preparation of movement of adolescents with chronic medical conditions into adult-oriented healthcare system. And it has been studied in different spectrum of diseases like diabetes, cystic fibrosis, and other types of diseases. It fosters effective self-management and independence. And here there is an attention to the clinical, psychological, educational needs of the adolescents and young adults. It's not simply a transfer of care, as you can see in the graph. The transfer, yes, it's planned, but it's just changing the care at one point, and that usually might not result in patient satisfaction, or actually might result in patient getting worse after transfer. So you can see that at the age of that patient, it's not only the adult mode of care, it's not provider to patients, it's actually provider to parent to patient, and then back from the patient to the parent, then to the provider. So the process is not easy. There are many challenges in the process when you will need to transfer those patients. There are social pressures, changing roles of those patients at the adolescent age. They might be going to college or planning to live independently, developmental changes, life changes, seeking increased autonomy while parents are trying also to supervise the patient care. Acquiring disease management skills is also a challenge during a very compressed time. There are issues of confidentiality, redefining responsibilities, financial constraints, and shared decision making. So I'll just, I don't need to go over this, but obviously the adolescent age, patients who are beyond the age of 12 or 14 until the age of 25, those adolescents and young adults, they are actually more similar to the pediatrics in terms of their disease phenotypes, disease presentation, disease medication response, as well as their dependence on the family. So you cannot consider them as adults and you give them the model of care of adults in being fully independent, direct gastroenterologist patient care, focusing on their autonomy, or just focusing on disease surveillance and long-term disease goals. It's actually issues of growth, nutritional optimization, minimizing ionization radiation. Even endoscopy is different. For some patients of the age of 18, you might not be able to do conscious sedation. So all that should be taken in consideration. So why this transition is important? Actually, failed transition has been associated with increased emergency department visits, hospitalization, medication escalation, surgery, and overall poor patient adherence and attitude towards medications. The adolescents and young adults patients with IBD frequently have suboptimal ability to recall personal health history, knowledge of medications, and the impact of drugs and alcohol and substance abuse. They may defer the responsibility for scheduling appointments or requesting medications. They might have difficulties in processing their emotions or coping with the disease, and they are vulnerable in terms of psychological stress, and they have increased risk of poor quality of life. How to go back? So adult GI actually receives sometimes patients with aggressive disease, and the condition of the patient might worsen post-transition. In one study a long time ago in ECHO, it was shown that pediatric IBD patients have significant disease at the point of transfer to adult, with 46% having required anti-TNF and 81% at least on immunosuppressant. the progression of the disease severity continues, with 19% of patients requiring their first anti-TNF at the beginning and when they start seeing their adult gastroenterologist. And it was found that the provider awareness alone is not enough to make sure that those patients are ready to take responsibility for their health. 2 months ago, there is a study which was the largest real-life study in transition. It was a retrospective multi-center study called the Butterfly Study. 278 patients were compared in 2 groups between patients who had transition, patients who did not have transition of care, with at least one joint visit between adult and pediatric gastroenterologists. And if you can see on the bar chart on the right side, the hospitalization was less in the transition group, and IBD flare was less in the transition group. Another study showed that patients who did not have transition, they were at 78% risk of missing their clinic appointments. So from the multi-variable analysis, they found some factors associated with poor outcome after transition, including no transition, just transfer, or IBD activity at transition, or malnutrition, or being on corticosteroids at the time of transition. When we think about transition of care, we have different stakeholders, not only the adolescent and parents, not only the gastroenterologists, the adult and pediatrics. We are having other stakeholders whom we should keep in mind, with the goal to keep the patients after transition with uninterrupted care, coordinated care, age-appropriate care, with a plan for transition when they are medically stable and feel confident and all their needed skills are studied. So the partnership between pediatrics and adult gastroenterologists is critical around that time, even if your model of transition or transfer of care is earlier than the age of 18. So the role of adult gastroenterologists is growing. In a study in the United States, they found that 80% of adult gastroenterologists report inadequacies in the preparation of patients transferred from pediatrics. In another survey of 1,000 adult gastroenterologists, there are many gaps identified in the patient care. Around 55% reported that there is a gap in the medical knowledge of the medical condition of their patients. Also, maybe around 50% of them felt that the component of addressing the developmental aspect of adolescent was not enough. And this is from Saudi Arabia, an online survey also on adult and pediatric gastroenterologists about transition of care. And in this study, 73.8% actually reported they don't follow a defined protocol for transition of care, while more than 78% preferred to have structured transition program. And 35.9% favored the joint clinic model as a transition program. So there are many issues at the time of transfer. You might not see the typical patient every time. Most of the time, you might get a patient who was previously not engaged with his pediatrician. That patient does not call, does not refill medication, does not ask questions. So this type of patients might be an issue for you as an adult gastroenterologist. You might have patients who were transferred at the time of crisis and flare. You might have patients with special needs whom you are not comfortable to manage alone. So the idea is MDT team again. Some pediatric physicians might be reluctant to send patients who are having very severe diseases because changing a physician at some stage might result in deterioration of the condition. Regardless of the model of transfer and the age of transfer, a structured transition program is needed, and it should incorporate delivery of personalized care with multidisciplinary approach, collaborative goal setting between patients, guardians, and healthcare providers, either pediatrics and adults. Communication strategies that are adaptable to the patient, healthcare providers, and local settings. A defined post-transfer adult transition phase, and an evaluation of the program process every time so you can improve it. The age of transition is probably 12 to 14, but you might need to continue doing the transition process steps after the patient is transferred to you as an adult gastroenterologist. The specific transition program should suit the need for the population and should be flexible. It should be within the available resources you are having. You cannot adapt the other programs from other countries. So there are different models like the Ready, Steady, Go from UK, the joint clinic, the 6 core element approach, and I have to speed up. The other thing, there are many skill assessment tools. Those skill assessment tools can be used even after transfer to adult gastroenterology if you are receiving patients at the age of 13 and 14 like us, like the IBD specific knowledge assessment, transition readiness, and others. And the NASCN has this healthcare provider transitioning checklist, which can be used according to the chronological age of your patient. The track or transition readiness assessment is a validated score, which should be also used, and it has an Arabic version. I will not go through this. Pretty much we covered most of the things related to the transition. The only thing which we did not touch is the goals and barriers. But in general, what I wanted to convey here, that the transition of care is a process. It's not an event. We have to ensure that our adults, adolescents and young adults can assume responsibility for their own health. The transition itself is a challenging phase in the management of IBD. It does not end at a single encounter if you are having the joint clinic model, but it is a stepwise program. It should be tailored to each individual, and you have to reassess and monitor every time. Use tools as you might have the local tools or the tools which are available in your local language. Flexibility and feasibility of transition program outside major academic centers and tertiary care. Perform regular assessment of patient readiness and ongoing process. And remember, it's not only joint clinic between different level of care. It's actually joint responsibility of those patients. At this point, I reach the end of my presentation, and I'll be happy to answer questions at the QA session. Thank you.
By now, I am very happy to present Dr. Thamer bin Turaiki, as he will talk about advances in J-pouch surgical management. Hopefully, by now, less complication after these advances. Dr. Thamer bin Turaiki, he is an associated professor of surgery at King Saud University, and he is the head of the department as well. He is interested in colorectal and surgical oncology. He is the one who initiated the HIPIC Center at King Saud University Medical City as a new referral center for peritoneal malignancy in Riyadh. The floor is yours, Dr. Thamer.
Thank you so much for such invitation. I'm very happy to be with our colleague in gastroenterology. Colorectal surgeon cannot survive without gastroenterologists. All the time, we need them as they need us. I'll speak about pouch surgery. I will start with the history of surgery in ulcerative colitis. Sigmoid colostomy was the first documented surgical procedure for ulcerative colitis. Till 1940s, the only definitively curative treatment for ulcerative colitis began as the proctocolectomy, as a compromise sometimes for a total colectomy with endoleostomy. But ileostomy has very bad complications with a high burden. 1950s, Brook, he started the ileostomy, where we have part of the bowel above the level of the skin to protect skin from the complication from ileostomy. 1950, some gastroenterologists and surgeons advocate for total colectomy ileorectal anastomosis. But with the rarity of rectum being not involved, lots of people being against such a procedure. Although 5% of UC patients has a spared rectum, so still considered to some extent sometimes in a patient with rectal preserved ulcerative colitis, which is a very rare, we might go for ileorectal. So Stanley, he did 400 cases with low recurrence rate, as well as low risk of cancer. It was to some extent as accepted in a case with no involvement in the rectum. Because of the ileostomy and the complication, Koch identified as what's called a Koch ileostomy or a continent ileostomy, where the patient has a small opening at the level of the skin, and every 3-4 hours, the patient has to intubate the small opening to make sure to evacuate the pouch beneath the skin. From here, pouch came. In early 1970s, the concept of ileal reservoir that Koch has described anastomosed it to the anal sphincter. So pouch came at that time. We have different type of pouch. We have the J pouch, we have the S pouch, we have the W pouch. Each of them at 18 months' time, the function will be the same. In 1 year and a half, the function of all is the same. But sometimes we prefer, I don't know if this laser working, the S pouch, one in the middle, it can be used in case of short mesentery and the pouch does not reach to the anus or the sphincter. Each of them has the same function, but risk of complication higher as you are doing more space or volume of the pouch. If you can see in the last one, does laser work here? Does it work? So the last one there in W pouch, we have 1, 2, 3, 4, and 5 suture lines, and evidence more than 3 suture lines or higher risk of complication. It is the same if you have seeing S pouch, 1, 2, 3, 4, which the anastomosis is down. But we need S pouch in a case of short mesentery. We have to do the pouch around 2-3 centimeters above the anastomosis with the sphincter. The standard most of the time is the J pouch. We have afferent limb, and the elbow joint or the cutoff where we anastomose the sphincter. Most people, they usually start from the elbow and they do the anastomosis. Thank you so much. So most people, they will do the anastomosis starting down at the elbow and they will go all the way up. The new technique, which is a reverse pouch. I adopted this technique. We can see the video here. How can I? Yes, can you make it on, please? So in reverse pouch, I start from up, not from down. And as we'll see it now here. Yeah, so this is the J pouch, around 15 centimeter or 18 centimeter. We flip the pouch outside to make sure the whole pouch completely outside. Not only that, if you will see the next step, again, you are connecting the pouch to itself to make it complete pouch with no any angle inside or any. I use this artery forceps to ensure I completely make the whole 2 limbs are open together. If you start from down, this angle sometimes might be messed up, and we are doing the pouchoscopy, you will see part of the limb in between as a bridge covering both between the afferent and efferent limb. By using this reverse pouch, we are sure the pouch completely opened, 1. Number 2, we are securing the angles. As we're having multiple fires, we are taking suture at each angle of the stapler because these are the weak point where the leak will happen. Last thing, when I take this pin outside or the anvil, it is away from the mesentery, reducing risk of bleeding. Okay, next. No, can we have next? So surgical options for ulcerative colitis, the standard now. In a total rectocolectomy with ileal pouch anal anastomosis with or without stoma, total rectocolectomy with ileal pouch and lobe stoma, then closure of the stoma, total colectomy with endoleostomy, proctectomy with lobe stoma, then closure of stoma. I like number 3, which are a 3-stage procedure. Why? There is no evidence advocating to go for 1 stage, 2 stages, or 3 stages. But myself, when I see the patient are in very bad condition with severely inflamed pelvis, I will go for total colectomy. I leave the pelvis and inflammation to settle down. When I go in, I put my pouch in the pelvis, I reduce the risk of inflammation at that time. Not only that, patients sometimes they were using steroid in acute flare-up, so we'll get rid of the steroid. Number 3, with a flare-up, they are malnourished, poorly tolerating orally. So giving them total colectomy with endoleostomy, this will improve their nutritional status, making all conditions better for our new pouch to survive. So during fulminant attack, the patient's condition is compromised with a potentially poor nutritional status, low albumin, low hematocrit, and complication of high-dose steroid all. So the procedure of choice in an emergency surgery to go for total colectomy only with endoleostomy. Then after 12 weeks, you go in, you do proctectomy with pouch anastomosis, then closure on the 3rd time. Can we do 2 stages? What do you mean by 2 stages? We don't give the patient stoma. If it is an emergency total colectomy endoleostomy, in 12 weeks' time, we go for proctocolectomy with ileal pouch, no diversion. Or, in 1 stage condition, we do total proctocolectomy pouch without stoma. What would happen? Again, in an emergency, I'll come back for my question. Emergency with endoleostomy, it's alleviate the major symptom of the disease, diarrhea, tenesmus, bleeding. Allow the patient to be from steroid, and as well as to confirm the diagnosis. I hate doing it in 1 stage or 2 stages. I like to do them in 3 stages because still we have to confirm the diagnosis 100% by taking the rest of the colon. Most advocating to leave the rectum in place during acute stage because also with severe inflammation, we might injure nerves during our surgery. This will affect the function of the pouch. You need nerves as well as we need the pliability of our pouch. We mean by pliability, distendability. So if the pouch has to be completely and fully relaxed without inflammation around, this again why I prefer 3 stages. Even not an acute, I like to go for total colectomy, leave the pelvis to settle down, then we go for a 3rd stage later on. The surgical goal in acute setting are designed to remove the bulk of disease, restore patient health, preserve reconstructive option after medication being withdrawn. Again, during the next stage of surgery, we discuss with the patient, do you need a permanent stoma or pouch? This in the patient condition as well as the surgeon preference and oncologist and the gastroenterologist. If the patient has incontinence or multiple fistulae, it's very difficult to connect the pouch to that area. Better to leave the patient in stoma. Crippled patient with polyarthritis and he's not improving with the medication should not go for pouch because pouch still they are going to go to the bathroom 6 to 10 times per day. So again, in the stoma is better as a functional outcome for the patient than having a pouch down the pelvis. Again, some point to discuss with the patient, the fertility and sexual function. Usually, pelvic surgery by itself affect the fertility in males by 12%. Doing a rectal cancer procedure or proctectomy in any patient, benign or malignant process, there are 12% nerves will be affected. So always we have to discuss. In a pouch surgery, if you're doing it open, the risk of infertility 50% in ladies. While if you are doing it laparoscopy, which is the standard nowadays, it's the percentage of infertility, it is 39%. So always we advocate to do those cases laparoscopy, not an open. Protective stoma. Again, I'll come back. Shall we do it one stage or multiple stage procedure? In carefully selected patients, this statement, I got it from the ASCAR guidelines for pouch surgery. In a carefully selected patient, one stage ileal pouch inner anastomosis can be considered. But similar anastomotic rate and pelvic sepsis related complication for both diverted and non-diverted. Again, in all of these studies, the use of protective ileostomy was left for the surgeon's preference. What does that mean? Means if the surgery went very smooth and if blood supply is good and the pouch can reach easily without any tension, all favorable points, the surgeon will not do stoma. But if the patient was in a difficult condition, most of the surgeon, what they will do, they will protect the patient with an ileostomy. Protective ileostomy does not reduce risk of leak, but it reduces the risk of septic complication if there is a leak. Again, almost all of these studies showed the stoma based on a surgeon preference, which is completely biased. In general, those patients undergoing one stage procedure are younger, healthier, non-obese, no anemia or hypoalbuminemia, and no other immunosuppressive medication were given. All technical aspects of the surgery were straightforward, no excess blood loss, good blood supply into the ileal pouch, no anastomotic tension, viability intact for the anastomosis. This is what I'm saying. If you leave this for the surgeon, of course, if it's an easy procedure, we don't want to give the patient stoma. But if it is difficult procedure, of course, everyone is going to do stoma. But again, my opinion, I have to put the stoma to my patient for future function of the pouch. Again, pouch depends on pliability or distendability, softness of our pouch. If the pouch thick, stiff, with inflammation and leak, the pouch function is going to be very poor and will affect patient outcome. The non-diverted patient appear to have a higher instance of post-operative ileus, although overall number of hospital stays is less than for those with an ileostomy. We know ileostomy has very bad complications, affecting his patient's comfort, skin excoriation, but we have to explain to the patient before surgery, and we teach them before our surgery, then they will accept that. So in conclusion, staged procedure, in emergency procedure, always counsel the patient for all possible complications. Thank you.
Thank you, Dr. Thamir. Now we reach to the last lecture, the mimics in inflammatory bowel disease. Our speaker, it's Dr. Hamoud Al-Ghamdi. Hamoud, he's a consultant gastroenterology, specialized inflammatory bowel disease, King Abdulaziz Medical City in Riyadh. He has completed his advanced fellowship in University of Western Ontario, Canada. Welcome, Dr. Hamoud. Floor is yours.
Thank you so much for the introduction. Good afternoon, everybody. This is the last presentation of the 2 wonderful days of the Ibd Masterclass. I want to thank the organizers, speakers, and the audience for their interaction. So my talk will be about the mimics of inflammatory bowel disease. It will be a very quick and then I hope informative talk. So objectives, I'll go over introduction, differential diagnosis. We'll have a case presentation during the presentation of the differential diagnosis, and we'll conclude. So introduction, as you know, the inflammatory bowel disease comprises both Crohn's disease and ulcerative colitis. Diagnosis is always based on combination of clinical symptoms, serology, imaging, endoscopy appearance, and histopathology. The differential diagnosis is wide, and that mimics IBD or others that can even complicate inflammatory bowel disease. So differentiation from IBD requires not only the standard clinical assessment, but also the endoscopy, histology, imaging, and other investigations. So this is also true for both incident and treated IBD and applies to both adults and pediatric IBD. So this is the differential diagnosis that I will go over very quickly. The infections on top of this and vascular disorders, including vasculitis, and drugs, radiation, hidradenitis suppurativa, diverticular diseases, and others. The bulk of the presentation will be on the first three differential diagnoses. So infections, several infections including viral, bacterial, fungal, protozoan, and helminthic should be considered in the differential diagnosis, and a detailed clinical history addressing the intestinal and extraintestinal symptoms, travel history, sexual history, and conditions influencing the immune status should be collected. The timing can point to certain infections, as in acute and chronic. We do have a long list of chronic infections that affects the GI tract, similarly to the inflammatory bowel disease. On top of that, yersinomycosis, actinomycosis, amoebiasis, and the rest you can see them on this schedule. It's important to know the clinical syndrome from the cause of these infections that would narrow the differential diagnosis. We can have syndrome of enteritis, colitis, and proctitis. Extraintestinal manifestations also can be helpful, as pneumonia can be seen with strongyloids and histoplasma capsulatum. Skin rash can be seen with lymphogranuloma venereum and syphilis as well. Travel history may help in diagnosis amoebiasis, schistosomiasis, and also stringulodiasis. Sexual history can point towards certain infections like chlamydia, gonorrhea, and syphilis. Immune status, as in HIV and steroid use, and also pregnancy. These can lead to disseminated forms of actinomycosis, coccidomycosis, and cryptosporidosis. The histological features of basal plasmacytosis and architectural changes favor inflammatory bowel disease over infection. Granulomas that can occur in Crohn's disease, but it does occur with a wide variety of other conditions. So granulomas in the gastrointestinal tract, we can subcategorize the causes into infectious causes, which are many, and non-infectious causes like immune-related disorders, intestinal inflammatory diseases, and vascular disorders, and also drugs like immune checkpoint inhibitors. NSAIDs rarely can cause it, and foreign materials. So the most important chronic infection that mimics inflammatory bowel disease is the tuberculosis, which is caused by Mycobacterium tuberculosis and is common in Asiatic and African region. Intestinal tuberculosis is the sixth most common extrapulmonary form and is potentially serious illness. In Saudi Arabia, it is considered highly endemic disease. Necrotizing granulomas on histology or necrotic lymph nodes on imaging are almost diagnostic. So diagnosis is a particular problem in TB endemic countries like our region. So that led to the Asia Pacific Association of Gastroenterology to suggest a trial of 8 to 12 weeks of anti-tuberculous treatment in patients where it is not possible to confidently differentiate intestinal tuberculosis from Crohn's disease, and in patients that are not improving or partially improving, to repeat endoscopy in 2 to 3 months. This is a meta-analytic Bayesian model for differentiating intestinal tuberculosis from Crohn's disease. This model summarizes the reported factors helpful in differentiating Crohn's disease from intestinal tuberculosis. The variables included in the model are prevalence of intestinal tuberculosis, gender, clinical manifestations, endoscopic findings, pathological findings, CT enterography findings, and the IGRA. The model was validated in a cohort of 49 patients and with an accuracy for diagnosis of intestinal TB over 90%. It's available online for public use. So this is adopted from the model, and in intestinal tuberculosis, short disease duration is usually noticed compared to long disease duration in Crohn's disease. As in the endoscopy, the non-patulous ileocecal valve favors the intestinal tuberculosis. And the pathology, the granulomas in tuberculosis are always confluent, large, multiple, compared to absence of granulomas or very few small non-confluent granulomas in Crohn's disease. The image features supports intestinal tuberculosis are the short segment involvement compared to large or longer segments involvement in Crohn's disease. The other bacteria, I'll go over this very quickly. The sexually transmitted diseases like lymphogranuloma, venereum, and syphilis, it occurs in HIV-positive men who have sex with men. The pathology usually shows intense chronic inflammation disproportionate to the mildness of the acute inflammation. Amoebiasis is very common in developing countries. Patients, this is important, patients may be asymptomatic or develop diarrhea. So we'll move to the second category, is the vascular disorders. Vascular disorders comprises vasculitis and ischemia. I'll just concentrate on the vasculitis. So vasculitis, the GI involvement in systemic vasculitis occurs in approximately 1/3 of the patients. The most frequent causes are the IgA vasculitis, ANCA-positive vasculitis, polyarteritis nodosa, Takayasu arteritis, and Behçet's disease. Secondary vasculitis is associated with rheumatoid arthritis, and SLE can also occur. Rarely, the inflammatory bowel disease occur with systemic vasculitis. Young age at onset and other features result in this mimicry with inflammatory bowel disease. The gastrointestinal symptoms, endoscopic findings, and even biopsies may be non-diagnostic. A detailed assessment usually elicits the constellation of symptoms, signs that suggest vasculitis and may point to a particular type. So this is a schedule that highlight the type of vasculitis, gastrointestinal involvement, clinical clues, and diagnostic methods of the main types of vasculitis. I'll move to the next slide, which is about the intestinal Behçet's disease. Recurrent oral and genital ulcerations raises the clinical suspicion for Behçet's disease. It may be extremely difficult to distinguish intestinal Behçet from inflammatory bowel disease due to the similarities in their intestinal and extraintestinal manifestations, and also in the pathological findings. So usually intestinal Behçets require surgical interventions due to complications, mainly perforation. The ileocecal region is the most commonly affected part of the GI tract in intestinal Behçet's disease. This schedule have some differences, help with some differentiation. HLA-B5 and HLA-B51 is positive in approximately 50% of patients with Behçet's. Perianal disease is rare. There are some differences in the endoscopic findings. So in radiology and histology, stenosis, fistulas, and abscesses are rare with Behçet's disease compared to Crohn's disease. Images may show variable vessel vasculitis with intestinal Behçet's disease. And the granulomas here in Behçet's is rare compared to Crohn's disease. And Crohn's disease is also less compared to the intestinal tuberculosis, as mentioned before. So, nevertheless, the distinction may be extremely difficult to make, leading to the patient receiving both diagnoses. And the medical treatments used for intestinal Behçet's disease are often identical to those used for inflammatory bowel disease. So we'll have a case presentation. This is a 17-year-old gentleman who was medically free before. He presented to us at March 2022 with chronic symptoms of bloody diarrhea. So after initial workup, he received the diagnosis of ulcerative pancreatitis, and he was started on steroids, 5-SA, and upfront to adalimumab every 2 weeks. So later in August 2022, 5 months after the initial diagnosis, he presented with symptoms of flare that required also hospital admission. At that time, he was again started on steroids, and the adalimumab was increased or escalated to Q weekly. The patient recaptured response again. So from that time till early this year, in January 2023, he presented with, on regular follow-up in the clinic, he had systemic symptoms, constitutional symptoms, mainly fatigability, decreased appetite, and weight loss. And he was not having severe symptoms from, it's mild symptoms from UC or near normal symptoms, or disease was controlled. So he had mild anemia on lab with normal ferritin. CRP was significantly elevated of 114. FCAL was 133, which is against disease flare. So we went for FlexSig, and it showed Mayo score 1 colitis, which doesn't, it is disproportionate to the severity of the symptoms he's having and the elevated CRP. So we went for CT chest, abdomen, and pelvis, and features showed large vessel vasculitis, which was also confirmed with MRI chest and upper extremities. These are the images, as you see with the red arrow, the wall of the descending aorta. There is signs of inflammation. And on the right side, there is a small arrow that points to the subclavian and the common carotid with the signs of inflammation on CT. This is the MRI showing the hyperintense inflammation also surrounding the common carotid, the left, and also the subclavian arteries. So he was diagnosed at this time with Takayasu vasculitis, or the large vessel vasculitis. He was started on systemic steroids on February 2023, and also methotrexate injections by his primary rheumatologist. And we continued adalimumab also from our side, with discussion with the rheumatologist that anti-TNF may have effect on the large vessel vasculitis, but the patient developed the vasculitis while he's on a high dose or a good dose of the adalimumab therapy. So at the end of steroids course was given for the Takayasu, or the large vessel vasculitis, he fled his ulcerative colitis and required him to present to emergency room. And at that time, the fecal calprotectin jumped into 800 compared to 100 in January. That is in May 2023. So after discussion with the rheumatologist, and we decided to move on to other therapy. And most of the therapies used for inflammatory bowel disease, as per discussion, doesn't work for the large vessel vasculitis except the anti-TNFs. So we moved to ustekinumab from our side, hoping that the methotrexate started for the large vessel vasculitis is doing the job. So started on ustekinumab, adalimumab was discontinued, and later he presented the next month with a pneumothorax to the emergency room, and the images showed the small pneumothorax that was resolved with chest tube insertion while he was on the taper steroid for the ulcerative colitis flare and received 1 dose of ustekinumab. This is the image showing the pneumothorax. So later on July 2023, he presented to the emergency room with hemoptysis, and the CT chest was suggestive of pulmonary hemorrhage or the diffuse alveolar hemorrhage. It was confirmed with bronchoscopy. So he required endotracheal intubation for less than 24 hours, and he received the pulse steroid of methylprednisone 1 gram daily for 3 days. These are the images on the left side. You see the consolidation on the left lung. And also on the right side, you see some the bronchi on the right and left, showing some debris, which is believed to be blood. So at September, that time he was discharged and he was on a course again, prolonged course of steroids. So on follow-up with my clinic in September 2023, he's doing well from GI perspective. Latest FCAL in August 2023 is 61. He received by that time of this month first dose and the first subcut dose of ustekinumab, and the rheumatologist decided to move on the treatment to escalate it to more therapy. So the decision was to give the patient rituximab. As per the discussion, the other option is cyclophosphamide. The patient is young, probably rituximab is a better option from their side. So after discussion, we elected to hold the Stelara, given the strong immunosuppressive therapies the patient is on. He's on methotrexate 20 milligram subcut. He has been on a steroid long tapering dose, and also will be receiving rituximab, and he's been doing fine from the GI. So at that time, even he's doing fine from GI, he just received high doses of steroids. So we elected, because of the risk of strong immunosuppression, and the latest plan from rheumatology, we'll keep monitoring him, and in case of any flares of disease, we'll move on. So the recent plan from rheumatology, they are considering rituximab maintenance in the next couple of months. So vasculitis in patients with inflammatory bowel disease, different types of vasculitis can occur in patients with IBD, including in decreasing order of frequency, large vessel vasculitis, mainly Takayasu, cutaneous vasculitis, ANCA-associated vasculitis, mostly GPA. So the diagnosis from case series, the largest case series, the diagnosis of inflammatory bowel disease preceded that of vasculitis by years. And usually the IBD is not active at the time of the onset of vasculitis, as in our patient. Takayasu and ulcerative colitis were also found to share a significant proportion of their genetic background, which may contribute to their coexistence. Patients with coexistent Crohn's and Takayasu tended to be younger at the time of diagnosis of Takayasu and had more frequent constitutional symptoms. Patients with IBD and Takayasu were on average younger at the diagnosis than patients with Takayasu than those without IBD. The same drugs are often used to treat inflammatory bowel disease and vasculitis, especially the Takayasu. Anti-TNF alpha have been inhibitors have been found effective for cases of IBD-associated vasculitis. However, several cases of new onset Takayasu or cutaneous vasculitis have been reported in patients with IBD receiving these drugs. We'll move on to drugs as a differential diagnosis of inflammatory bowel disease. Numerous drugs and chemicals can cause small bowel and...
1 minute. 1 minute.
We'll finish soon. So numerous drugs can resemble IBD. Some drugs, like rituximab, can also exacerbate pre-existing IBD or even facilitate the onset of de novo IBD. Drug-induced enteritis and colitis may have different histological patterns. These may be features of lymphocytic colitis, collagenous colitis, ischemia, pseudomembranous colitis, eosinophilic colitis, or inflammatory bowel disease. These are the possible mechanisms. I'll move on. Other drugs like the immune checkpoint inhibitors and the PI3 kinase inhibitors. There are several monoclonal antibodies targeting these two mechanisms are available for treatment of advanced malignancies. They cause immune activation and robust anti-TNF, anti-tumor T-cell activity and can greatly improve survival. These are examples of these medications. Also, not to forget the PI3 kinase, similar to the immune checkpoint inhibitors, as causing the colitis or enterocolitis. Immune-mediated adverse events, including enterocolitis, can resemble IBD, and they are common and may be severe. The median time of onset is 50 days after administration. If you could give me 2 minutes, please. The incidence of immune checkpoint inhibitors associated enterocolitis is a serious complication that can be fatal and reach up to 20%. Factors that increase the risk is the combination of two immune checkpoint inhibitors, concurrent non-steroidal anti-inflammatory drugs, and melanoma cancer itself is a risk factor. Any part of the GI tract can be affected. It could be diffuse more commonly than patchy disease. The anti-PD, which is an immune checkpoint inhibitor, colitis can recur even months after cessation of therapy. Other medication is mycophenolate, Mofetil. Gastrointestinal side effects occur in 50% of patients. The features, what is typical is the rectal sparing. Endoscopy can be normal in 50%, so it's abnormal in 50% of those patients. Other differential diagnosis, radiation. I'll move on to the diverticular disease, and it is difficult to distinguish it from the SCAD and diverticular colitis. Difficult to differentiate it from IBD based on the histology. Usually it resolves completely without recurrence. Hidradenitis suppurativa is a differential, especially for perianal Crohn's disease. Usually the fistulas in hidradenitis suppurativa, usually the fistulas are simple compared to Crohn's disease. Others, I'll move on, and I'll conclude with that mimickers of inflammatory bowel disease include infection, diverticular colitis, vascular disorders, drug-induced injury, and immune disorders. Distinction between IBD and its mimics requires comprehensive clinical assessment, including a full history with duration of symptoms, investigations that may include routine blood tests, endoscopic examination, histopathology, microbiological tests, serology, imaging, and fecal and serum biomarkers. Reliable distinction between IBD and its mimics requires constant awareness by clinicians and pathologists of the wide range of differential diagnosis of IBD. Close communication between clinicians and pathologists, radiologists is essential. Thank you so much.
Thank you, Dr. Mahmoud, for your nice presentation. Sorry, no time to take questions. Thank you, Saudi Gastro Association, for this nice, wonderful meeting. Thank you, Saudi IBD Interest Group. Thank you, Mr. Speaker, National, International, Mr. Chairman, for audience who stay with us. until the end. Please join us in the stage for the photo. All of us, please join us.
Everybody, please join in the stage. Everyone, please.